urine. That was the complaint. So when the call came to me, my child is passing red colored urine, I said, okay, bring the urine sample and the child to the OPD.
Dr. Vasudev, there is a slight problem in connectivity. Lot of delegates are saying that they cannot see slides and this thing. If we can have because such wonderful session is going on and
I'll
delegates.
stop and then reshare. I'll stop this.
No, sir. Your PPT is okay. Your is everything is going well. Their connectivity issue is there from technical. Yours is very good, sir. We can see very well. But in delegates group, it is there. Rohit has to check that.
So I'll just wait for a couple of minutes.
Just 2 minutes, sir. Just 2 minutes. Started. We can start, sir. Now I got the message. It started.
Please start.
Should I go back a couple of slides and tell them?
No, shuru kar do.
Okay, fine. So I was telling you that this is the first case. So those who have missed, I had not spoken much. I had just told that once you get a child with red colored urine, it does look scary, but then we have to see whether it is really blood or not or something else. And if it is blood, how do we manage it? So we'll go by step. So I'm just in the beginning of the talk only. So as I said that please bring the child and also bring the urine sample. When the urine was brought, it was not looking bright red, but it was discolored. So I examined the child and history was taken. And in the meantime, I also sent the urine to lab to have a quick review of the urine. So the child was having mild upper respiratory symptoms and was taking some medication prescribed by the general practitioner. When I said which medicine, they were not remembering the name, but they carried the bottle along, and it was T-Minic, which was orange in color. In the meantime, the lab report also came. There was no blood in the urine, no protein. Urine sample was looking normal and microscopic. The pathologist said, sir, there is no RBCs at all. So I was very clear that probably it is not blood. It is because of the drug only. And the diagnosis was immediately made that it is a drug color, and the parents are satisfied. So this is the one example I am giving, that once you have a doubt, immediately send the urine. Within few minutes, you will get the result, and you have to go back into the history to find out whether it is really blood or not. So what I mean to say that all that is red is not blood. There are other causes of red urine also. What can be other causes of red and pink urine? It could be tree hematuria, it could be free hemoglobin or myoglobin, it could be urates or any drugs, beetroot or furin sometimes. And a dark and orange urine could be a concentrated urine, or sometimes because of rifampicin or NFT. And sometimes the urine is dark brown or even sometimes black. Methemoglobinuria, bile pigments, metronidazole, they can make the urine dark brown. I wonder if somebody has seen black urine. In my 35 years of practice, I have just seen two patients, one in AIMS and the other in Apollo, where the mother actually said the child is passing black urine. And when I did not believe, and we got the urine, and within few minutes, it started turning gray and then it turned black. And this is a condition which is called as alkaptonuria. So maybe once in lifetime, you might see such a case. Another case I would like to refer before I go on to the main talk. This is a 6-year-old child who was referred to our emergency room in Apollo from a nursing home. History of passing red urine, less urine, renal parameters were deranged, BP was high. The history was taken, there was fever and URI few days back, and the child was given medication by general practitioner. So our provisional diagnosis was that the child has acute glomerulonephritis probably. The age was also the setting. So we sent some lab investigations, urine, CBC, KFT, ASO, C3, and X-ray chest and others to rule out acute glomerulonephritis. But over the next 24 hours, the urine output started decreasing further. And this was the color of the urine, which the parents had also brought from home, and we saw this was the high colored urine. So the urine examination was done. Blood was present, microscopic. There was no RBCs in the microscopic examination. Again, we got a bell rang that there is something else. And this was actually hemoglobinuria. This was not hematuria. The blood was there, but no RBCs, so this was hemoglobinuria. The course in the hospital, the child was oligoanuric, KFT deranged further, fluid overload was there, supportive care was given, then child required hemodialysis for 5 days, and the child recovered over 10 days. During this period, we had got other investigations also done, and the child came out to be having G6PD deficiency. And for fever, he was given some medications which caused hemolysis and hemoglobinuria, but there was no RBCs, only blood was there. So learning point here was that the urine was looking absolutely red like blood, but there was blood in it, but no RBCs. So this is hemoglobinuria, and the causes are different for hemoglobinuria compared to hematuria. So diagnosis of hematuria, screening test is the first thing that once you get a red urine, you have to identify whether there is blood or not. And to do it is a very simple, there's a urine dipstick which picks up the heme protein. It's a very sensitive, almost 100% sensitive for blood, and 90 specificity is 97, 99% for even 1 to 5 RBCs in the urine. And this is how the urine dipstick looks. Very simple, almost every hospital ward will have it. Once you have a red color urine, even in the clinics also you can keep it, just dip it, you will know it immediately whether there is blood or not. And if it is negative, that means it is not blood, it is something else which is giving color to the urine. If it is positive, that means there is blood in it. So now we have to find out if there is blood in it, whether there is hemoglobinuria or hematuria. To differentiate that, we would send the urine for microscopic. If there are more than 5 RBCs per high power field, it is hematuria. If though RBCs are not present, it is probably hemoglobinuria or myoglobinuria. So positive dipsticks but no RBCs, that means it could be hemoglobinuria or myoglobinuria. Then other information which the microscopic examination can give you is about the dysmorphic RBCs. Again, we'll see down the line that how important is it to see dysmorphic RBCs. So once you have sent the urine, please request the pathologist to see for the RBC morphology, see if there are any cast or any protein. This will help us in making further diagnosis if there is hematuria. This is how the dysmorphic RBCs look, which are distorted, and this is a cast, and these are the normal RBCs, very regular RBCs. So the pathologist can easily differentiate between the regular RBCs and the dysmorphic RBCs. So now to recapitulate what all we have discussed, evaluation of hematuria or dark urine. Once you put in the dipstick, if it is negative, it is because of the pigments. If it is positive, then it is with the, that means blood is there, you send the urine for microscopy. If the RBCs are absent, it is either myoglobin or hemoglobin. If RBCs are present, then you evaluate for hematuria further. So this is what we have covered till now. So now, if you have hematuria per se proper, that means RBCs are present with red urine, it could be gross, which could be a single episode, which could be recurrent, or it could be microscopic, isolated, or with proteinuria, and we'll see the significance of each of these terminologies. Very important that once you have hematuria, most of the diagnosis, I can tell you, you can make it on history. If you take a proper history and examination, most of your diagnosis can be very clear. If you have a child who has got periorbital puffiness, oliguria, dark urine, hypertension, edema, you are more or less certain it's a glomerular cause, and AGN is most common. If you have another child with dysuria and fever and pain with hematuria, think of UTI. If you have a child with recurrent pain abdomen with dysuria and hematuria, think of stones, urolithiasis or hypercalciuria. If there's been a recent sore throat or skin infection, think of post-infection glomerulonephritis with hematuria. And other information which you have to take is about the exercise, about the menstruation, any catheterization, any drugs, or any passing of this stone has been there in the recent past. Some of the difficult cases which can come with hematuria, and we will see some of these cases. Joint pains, rash, and edema is there, think of vasculitis. If there is positive family history of deafness, think of Alport or thin membrane disease. If there's a renal lump, think of hydronephrosis, Wilms tumors, or polycystic kidney disease. If there are bleeding tendencies, think of ITP, DIC, hemophilia. So by taking the proper history, most of the times you can figure out the diagnosis. Again, when you are doing a physical examination, a blood pressure is very important, and with a proper size, cough is important. Look for edema, any purpura, rashes, or arthritis. Look for abdominal lump or renal anger tenderness, and do not forget to see genitalia. Yesterday also I was telling that there are so many children who have meatal stenosis or vulval adhesions and ulcerations which can cause hematuria. The investigations which would be required if it's a gross hematuria from bladder or urethra, normally the color is pink or bright red. There may be clots in it. If you send the urine, there will be protein in it, and microscopy will show RBCs which are eumorphic. Again, the importance of having regular eumorphic RBCs, that means the blood is not coming from the glomeruli, it is from the other tract. Ultrasound can be done for any structural abnormalities, picking up stones. Some of these electrolytes, KFT, CBC, urine culture, they need to be sent, and other investigations depending upon what cause are we thinking about. But if you have a child who has got a glomerular hematuria, gross glomerular, the urine will show proteins, the RBCs will be dysmorphic, there may be RBC cast, ASO may be positive. If it's a post-streptococcal, throat swab can be sent. Complement level will be helpful here. Low values will be seen in post-streptococcal glomerulonephritis or post-infectious glomerulonephritis, SLE, and other MPGN and other. So these are the investigations which will be required if you have a gross hematuria, which is looking bright red, or it is a glomerular, which is looking a brown or a dull one. And some of these investigations would be required further if the child is sick. Now I come to a very common case, which is a common garden variety in your clinics. And this is a 7-year-old girl complained of passing red urine only for 1 day. What further history would you like to have? I can't ask you on the virtual platform, but I would have asked you on, and again, when would you suspect a glomerulonephritis in this child? History is very, very evident. So let's see. If the child has had red or dark or smoky urine, oliguria, early morning puffiness, probably this child has got glomerulonephritis. Other symptoms can be headache, vomiting, blurring of vision, altered sensorium, seizures, cough, breathlessness, and these all can be because of fluid overload, hypertension. Again, taking a blood pressure is very important when we are talking of these symptoms. So any child who's coming with a short duration hematuria, red urine, with this sort of a history and or this sort of a history, do take a BP, look for any other complications. And this is a common garden variety where we say it's acute glomerulonephritis, where there'll be albumin and WBCs may be present, numerous RBCs with dysmorphic RBCs will be there, renal functions may be abnormal or normal, and complement, usually low complement again is very helpful. In this child, the complement was low, and we could make a diagnosis of acute glomerulonephritis. So this is one of the commonest causes of hematuria you will see. And if it is not post-streptococcal, then it could be post-infection. So we have to differentiate. If it is post-infectious, again, it could be a difficult cause where further investigations are required. Coming to a second case, now this case is different from the first one. This child has had fever and joint pains for almost 1 month, 15 days to 1 month. Along with that, now the child has gross hematuria, oliguria, and edema for last 5 days. So this history is not very short. So what do we see in this child? When we examine, the things to be noticed are, one, in the yellow, the blood pressure was high, there was facial puffiness, pitting edema, pallor was very significant, knee joints and ankle joints were swollen and tender, no fever now, rash or ulcers were not present. And these were the findings which were present in this child with a longer duration of hematuria. Then the urine for examination, albumin was 3+, RBCs were abundant, and RBC cast was seen. Then the urea and creatinine were very high in this child. Hemoglobin was very low in this child. And the other parameters were also sent, complement level, DS, DNA, AN and all. What happened that this child's serum creatinine started rising, and if you see the peak, it had gone very high. We needed hemodialysis, and after that we did a biopsy in this child, and it turned out to be rapidly progressive glomerulonephritis. So learning point here is that child who has got symptoms other than hematuria, fever or joint pains and a prolonged thing, we must look into it very closely. And these are the children who need very rapid diagnosis and a referral, quick referral if you need to save them and give them a proper care. Now coming to another child who again has a gross hematuria but little different history. This is a 10-year-old boy with red colored urine only again for a short 1 day. But there was colicky pain in the right flank, occasional dysuria, pain, increased frequency, urgency, and difficulty in passing urine. No fever, no oliguria, no hypertension, no edema. Urine analysis showed appearance was bright red. Albumin was nil. RBCs were abundant and they were all eumorphic. So what is the guess? I think you must have all figured out that this is a child who is not having a glomerular disease. There is blood in the urine. There are RBCs, but they are eumorphic RBCs. That means not coming from the glomeruli, coming from elsewhere. And they were because of the presence of stones. The ultrasound showed calculi in this child, and he probably had passed the stone also. And the acoustic shadows show calculus. So what we have learned, the approach to gross hematuria, these cases exemplify two large groups into which children with gross hematuria can be classified. This is gross hematuria. It could be either glomerular or it could be non-glomerular. So it's very important for us to differentiate between the two, glomerular and non-glomerular, not difficult. The color also identifies glomerular hematuria is normally brown or tea or cola colored, and the non-glomerular is bright. Proteinuria is present in glomerular hematuria. RBCs are dysmorphic. Cast may be present, and crystals usually are present if there is stones or other uric acid. So it's very important to differentiate between the two entities. If it's a child with cola colored urine, proteinuria is there, RBC cast, think of acute nephritic syndrome, and if the answer is yes, then these are the glomerular hematuria, and we need a host of investigation, not all, but step by step we have to do this investigation. And if it's a non-glomerular one, then stepwise again we have to do these investigations, the urine culture, spot urine, calcium, creatinine, electrolytes, creatinine, calcium, renal bladder ultrasound will help us. And if these are negative, then step 2, go in for family history, go in for any other bleeding disorders. Certain children will require voiding cystourethrogram, and some will require renal scans. So step-by-step approach if it's a non-glomerular. Now I'll change gears now. We have now till now talked about two major groups, gross hematuria, glomerular, non-glomerular. So let's look at some of the common cases which you will see in your office practice with this background now. This is an 8-year-old boy, Amit, coming with red colored urine for last 3 months, off and on. This is intermittent, once every 10 to 12 days and lasts for 2 to 3 days. The hematuria is painless. There is no fever, no rash, no joint pains, no history of burning micturition, no frequency. That means we have ruled out UTIs and other vasculitis problem. No history of periorbital puffiness, edema, oliguria, AGN is ruled out. So Amit has got a different history from previous cases. What is it? He has got a recurrent gross hematuria. They were the ones with one episode which I showed you earlier. These are the ones with, this is the one with recurrent gross hematuria. So once I look...
Last 2 minutes, sir.
Sir, please pardon for the technical glitch, 2 minutes more because I told 5 minutes.
4 minutes, sir. 4 minutes.
Okay, fine. I'll finish within 3 minutes.
Thank you, sir. Sorry, sir.
So taking the detailed history, the child's urine examination showed blood, ultrasound was normal. He was an avid football player and used to play for 2 to 3 hours every day. And hematuria would occur on the day he would play football, and it persisted for 2 to 3 days. When he was playing for lesser time, for half an hour, there was no problem. So this was a child who had actually got exercise-induced hematuria. Nothing will help in this child, no medication, no investigations will help. Only that if he has to play, he has to take rest in between. This is another child, blood notice on washroom floor after use by child. The mother was very intelligent. She took a picture and sent to me. Okay, doctor sahab, blood lag raha hai. Maine kaha, haan, lag raha hai blood. Let's see the child and let's see the urine. Passage of red urine off and on. When I took the history, कि डॉक्टर साहब 6 महीने से मैंने कई बार देखा है इसको, पर मुझे ध्यान नहीं आया कि मैं आपसे बात करूं. मैंने अपने पेडिट्री लोकल डॉक्टर से बात की, उन्होंने कहा कोई बात नहीं, हो जाता है, ठीक हो जाएगा. No dysuria, no fever, no colicky pain. Family history was insignificant. The child had a history that leg pains were there off and on, was given vitamin D shots multiple times by our orthopedician friends. Then calcium was given regularly. And he used to eat a lot of gummies, which was imported gummies and contained a lot of vitamin D and calcium. So physical examination was normal, so were the ultrasound and other things were normal. And urine was showing a lot of RBCs, but they were eumorphic. What was surprising and not surprising to me was not a calcium creatinine ratio, which was very high. Urine calcium 24-hour urine was very high. So this was a child who had got idiopathic hypercalciuria. And the treatment he needed was increasing fluids, decreasing salt intake, thiazides, some potassium citrate, and stopping the gummies and vitamin D and calcium preparations. Another last case, 4 children, this is very important, that's why I'm showing 4 children referred to me with gross hematuria in 1 month from the same nursing home in my area. All had history of fever and treatment was given by the same doctor in OPD. Detailed investigations revealed no cause was found, only one common factor on repeated history, and that common factor was all these children were treated with a combination of mefenamic acid and paracetamol combination for fever. And this was an NSAID induced hematuria, nothing would come positive. So I requested that pediatrician, please stop using this combination. Believe me, it's been almost 6 months, I have not got a single case of hematuria from that nursing home again. So sometimes these drugs can be notorious. Last slide, couple of last slides. I've talked about gross hematuria. What about microscopic hematuria? Sometimes you find microscopic hematuria on a routine examination, or if there are some symptoms. If there are more than 5 RBCs, you identify microscopic hematuria, but you have to see a couple of times before you label it yes. And if it's asymptomatic, just keep following them up for hypertension, proteinuria, calcium creatinine ratio, ultrasound. Majority of them would go into spontaneous resolution within 6 months to 1 year. But if it is persisting beyond 1 year, then you need to see a nephrologist. But the caution is when the microscopic hematuria is accompanied with proteinuria, please do not take it lying down or easily. It indicates a significant renal disease. You have to assess for quantitative proteinuria. And if it is significant, you need to refer to the nephrologist. So my carry home message is, diagnosis of hematuria we must see for RBCs. Commonest cause still in your practice would be post-streptococcal or post-infective GN. If it is rapidly progressive, please refer it early. If it is a non-glomerular hematuria, look for calculus and hypercalciuria. If it is microscopic hematuria with proteinuria, it's a serious problem, do not ignore. Recurrent gross hematurias do need investigation and you will find some cause. If it's asymptomatic microscopic hematuria, please keep under surveillance, don't panic, majority of them will get better. These are 2 books which I have edited, Nephrology and Algorithm. You'll find ample material to read if you need to read further for hematuria in both these books. Thank you very much for a very patient hearing. I'll stop sharing my slides here so that we can be all on the panel and we can see each other. Thank you very much.
Thank you, Dr. Vasudeva.
Dr. Uthi, you can please unmute yourself. Yes.
Yes, yes. Can you hear me?
Yes.
Can you hear me?
Yes, 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 Dr. Uthi.
Vasudeva very extensively and comprehensively covered topic, and I think it will be very useful for the general pediatricians. One very pertinent question here is, although you have covered it, but what are the clear indications of such patients to be referred to pediatric nephrologist?
If it is gross hematuria with the rapidly progressing renal deterioration, they need to be referred very early. If it is gross hematuria which is recurrent, this needs to be referred. If it is microscopic hematuria which has got proteinuria along with it, that needs to be referred. I think these 3 major categories, and if you have any other ones, you can please suggest.
I think you have covered quite all right, but just to summarize, as you are saying, if there's a rash also there, the patient is having hypertension, there's a rash, there are joint pains. So obviously these are the group of patients who will need ultimately a biopsy also. So for those patients who are having such associated problems, I think it is better to refer to a nephrologist at the earliest so that patient can be managed properly. Any questions from the participants?
There are a few questions in the Q&A box.
The other chairpersons, Dr. Jani and Dr. third
Great,
call.
well.
If they have any
Sir.
comments.
नहीं sir, I just want to consult and discuss also. There was one patient around 12-13 years old. He was having little fever, and one day he had coffee colored vomiting. So we went to gastroenterologist. Gastroenterologist said the basic investigation should first be done, and surprised, and to the lab and to the surprise of the gastroenterologist also, the blood urea was unimaginably high at 550. And child was absolutely normal. Child was rather eating bread pakoras. And his father was saying that everything is okay. And so ये तो कोई गुरु की महादशा आई है. ये अभी थोड़ी देर में निकल जाएगा. I don't know क्या था वो. Then we all went for मतलब that child went for 3 or 4 dialysis. Unfortunately, a biopsy could not be done. But child became all right within 7 days on conservative treatment only and in dialysis. And this kidney biopsy was also tried, but it missed. So what it could have been, well, just
I think it looks like acute glomerular nephritis. It could be post-streptococcal or post-infectious. And post-streptococcal normally would settle down gross hematuria and things start settling down in a couple of weeks. And by 1 month, normally majority of these children are out of woods.
But at blood urea 550, the child was
Yes,
absolutely normal.
It can go high, it can go sky high also, and they may need a few dialysis also. And most of them, as a common garden variety I showed you, would pass out without problem. But some of them would have, and they are sometimes not post-streptococcal, they may be post-infectious, other causes of infection, where one needs to see and detailed examination. So best is to refer such patients to Dr. Vasudev or Dr. Pruthi so that they can manage well.
Thank you, sir. Thank you.
Sure, sir. Thank you, sir. Dr. Vasudev, sir. I request chairperson to introduce for the next talk. Dr. Vasudev, sir, there are few questions in the chat box. If you can answer there only.
I'll answer them.
Thank you, sir.
Thank you. Thank you very much. It was pleasure being.
दवाई नहीं दूंगा जिसमें तुम्हारी जान चली जाए. नहीं, मैं नहीं दूंगा.
Next speaker, Dr. Pruthi,
Yeah,
sir,
next.
please introduce.
Sir, next topic is actually red flag signs when I would not overlook in headache. So please you introduce, sir. Rohit, please display the slide. Dr. Saurabh Chopra. Pruthi sir, please introduce our speaker.
I think the slide is there.
Yes.
Hello.
Yes, sir. Slide is there. Rohit, it's not properly visible actually.
Dr. Saurabh Chopra is a neurology fellow from Wadia Hospital and a well-known pediatric neurologist. We would request him to start his talk.
Thank you, sir, for the brief and quick introduction. And without much ado, let's start the talk. I cannot screen share. Can you allow me to screen share?
This will have to be stopped. Rohit, stop this so that sir can share his screen.
Yes, sir.
Okay. So thanks to all the organizers. Oh, sorry. For this opportunity. So the topic that I'm going to cover today is basically on headaches and what in headaches I don't want to miss. Not only red flags, certain many things that I personally would not like to miss in a patient with headaches. So when a patient with headache comes to us in our clinic, the first thing that goes on in the parent's mind and to some extent even in our mind is there a tumor going on? And if a distant relative has had a bad experience with a brain tumor, then the consultation can get quite tricky at times. So how rational is this fear? How rational is this fear that headaches might be harbingers of something really bad in the background? Obviously, all of us know that headaches can be a presenting symptom of SOLs and bad intracranial pathologies. But let's start with the facts. So this is a fun fact. So let's start with it. So basically, there was a survey done among neurologists, and they found that almost 40 to 45% of male neurologists and 60% of female neurologists had migraine. And if the neurologist was highly specialized in managing headaches, that is a headache specialist, then the prevalence rate was extremely high. 70% of male headache specialists had migraine, and 80% of female headache specialists had migraine. Now, does this tell you that neurologists are rather boring people who keep having headaches all the time? Not really. It just tells you that the more expertise you have in headache, the more likely you're going to make a diagnosis. Even among children, headaches are quite underreported. The prevalence of headache is much higher than what the numbers we see in our OPDs. So almost 60% of children will have headaches some or the other time during their childhood period, whereas as high as 8% of school-going children have migraine. So these are all surveys that were done, and it has been found if the survey is done by an untrained doctor versus a survey done by a trained person in headaches, the percentages keep rising. So now, the answer to that is headaches are common, but tumors and bad pathologies are rare. So the incidence of tumor is anywhere between 1 to 5 per 1 lakh children, whereas as we just saw, headaches are extremely common. So yes, the chances that a child who has presented to us is going to have some really sinister pathology are very, very low. But as a doctor, we cannot miss those pathologies. So let's start with a simple, straightforward case here. So this was a really interesting case. And in fact, this is a case that ended up teaching even us as neurologists quite a few things. So basically a 9-year-old male child presented with headaches since about a month. These headaches were gradually increasing in frequency and severity. The headache started whenever he went in the morning to pass stool, and he would exert pressure, and that is when the headache got triggered. And it would last several hours after that. Occasionally, there were on 1 or 2 occasions, he had actually got up from sleep in the middle of the night with a headache. The blood pressure was borderline, and then we started doing the neurological examination. Before I go anywhere further in the case, I would just like to spare this one slide on neurological examination. I'm not here to teach anyone how to conduct a neurological examination. I think all of you are well trained to do that. It is just that in our busy practices, sometimes we forget to do a detailed neurological examination because we think that it will waste a lot of time. I don't think so. If we have a clear picture in our mind what we are trying to do, we can quickly finish the neurological examination. So whenever I do an examination in headaches, what I'm thinking, I need to kind of quickly screen all the areas of the brain, starting from the lowermost part, that is the brainstem. So I need to do a cranial nerve examination. Then for the cerebellum, what do I need to do? I need to check whether the child has proper balance and coordination. Occipital lobe, I need to check how his vision is, his field of vision. Again, a confrontation test hardly takes 30 seconds to complete if your child is cooperative. A sensory and a motor exam will finish the parietal and the posterior area of the frontal lobe, which have the motor strip and sensory strip. And then finally, we need to do the higher functions. Again, higher functions are easy to do. In a child, we can just ask them to do a few simple maths calculations. We can talk to them, see how their speech is, and just quickly check how their memory is. We can just ask them to remember 2-3 simple words, and after a few minutes, ask those words again in the examination. That's it. I have done a full neurological examination multiple times, even during online consultations in the last few months. And it is definitely possible, hardly takes 5 minutes. But this examination is extremely important in a child with headache. Why? Because it has been found that all children who present with headaches and end up having sinister pathologies in their neuroimaging always have an abnormal neurological examination. And these are big studies conducted in as large as 600 and 1000 children. So examination is very important. Obviously, the history is as important. Coming on to the systemic examination. Once we have finished the neurological examination, a quick systemic examination to make sure that the child is not having a systemic disease that is being manifested as a headache. Right? Now, coming back to the case. So here, the examination was completely normal. There was nothing in the examination that was abnormal. But again, going back to the history, what are we going to do next? Again, like my previous speaker said that if this were a normal conference, I would have asked the audience. But here, let me go further. So a child with a chronically progressive headache. Can you see what is the first line? Headache since 1 month, increasing gradually in frequency and severity. So this pattern is a very specific pattern of headaches. Looking at what different patterns of headaches do we see. So this is a very nice slide that I have borrowed. Here you can see that the blue, light blue or sky blue lines, if you see, that is an acute recurrent pattern. That is, there is a spike of headache, then it goes down. The child is absolutely fine. There's another spike of headache, it completely goes down. And then a few weeks later, there is another headache. So this is an acute recurrent headache. The type of headaches you see in patients with migraine and tension headaches. So that is not a sinister pattern of headache. Which is the next pattern? Next pattern, if you look, that sort of creamish colored line that is going up and down throughout the slide and is labeled as chronic non-progressive pattern. So here you can see that the headache is there. It does go up and down in between, but overall it is remaining more or less in the same sort of a pattern. It is a non-variable pattern of headache. Look at that red line crossing right across. That's a chronic progressive headache, increasing pattern throughout. That is a very sinister headache and should not be missed. This history we would not get until we actually look for it. And we ask specific questions to get what is the overall pattern of headaches. The last pattern that I would like to highlight is the acute pattern, the green line. The green line shows headaches that occur with, say, any underlying illness. So even a typhoid or a malaria, any garden variety viral fevers will cause headache, including COVID. And so it just indicates that there's something going on. But a very severe acute headache is known as a thunderclap headache, and that is a sinister pattern. So among these patterns, it is mainly the chronic progressive pattern that need not be missed. It's a big red flag. So, like in the history, we looked at the first point, which was suggesting the pattern. And we looked at what is the red flag in the pattern of headache. Next, what is the second point in the history? It's an early morning upon exerting to pass stool. Again, this is a sinister pattern. This is a red flag saying that the child is exerting. So any Valsalva maneuver or any exertion, if it triggers a headache, that indicates that even slight rises in normal physiological rises in your intracranial pressure is triggering a headache. This is not a pattern to be missed, right? The third point is lasting a few hours. That is not a red flag. There's nothing important in that particular history point. Finally, wakes him up from sleep. This is another red flag. It's not to be missed. So although the examination is normal, there are multiple red flags in the history in this patient, and we cannot miss doing a further investigation and evaluation. So what are the red flags are we missing? So we basically discussed all the important red flags in the case, but other things like a very young child, a child less than 3 years, a child having a VP shunt, obviously those are things where we would be quite uncomfortable if the child comes with a headache. Even a headache accompanied by repeated vomiting, headache accompanied with seizures or other systemic illnesses, and finally, an unusual location of headache. Most headaches are in the frontal area and the temporal areas. Occipital area is a very unusual location for headaches. So that would also be not an extremely important red flag, but yes, something to be kept in mind. Moreover, if there are no red flags and the examination is absolutely normal, in that case, one should not do a neuroimaging. Neuroimaging is usually misused in headaches and overused. It's abused in headaches, needs to be reduced by doing a proper clinical evaluation. So obviously in this child, since there were lots and lots of red flags, we definitely did a neuroimaging. It was absolutely normal. The venogram was done on the MRI. Why the venogram was done? Because the pattern suggested a raised intracranial pressure, because the child, whenever he exerted for stool, developed a headache, and that's why a venogram was done, because rarely, even if the overall MRI of the brain is normal, a venous blockage can lead to similar symptoms. But it was normal in this case. So what next? What should we be doing next in this particular case? Again, as I said, in this case, there are multiple red flags. So we cannot label it as a primary headache. We have to pursue what is underlying that is causing the headaches in this child. And since the history was suggesting of raised ICP, the next thing to consider was whether this is an idiopathic raised ICP, where we are not knowing the underlying cause of the raised ICP, but the brain pressure is still high. So the next logical thing to do was to actually measure the intracranial pressure in this child, which is not a difficult thing to do. Measuring intracranial pressure just requires doing a CSF, right? It's pretty simple as doing a CSF, and we measured it by using a simple manometer. The pressure reading was 23 centimeters of water, and the cutoff is 20 centimeters of water. 3 centimeters here and there actually does not make much of a difference. It's like having a SGPT of 43 or 53. We don't get immediately concerned about it. So the lumbar puncture was not suggestive of significant raised ICP that would have explained the symptomatology in the child. So this child was admitted with us in a hospital. We had done a CSF, which was normal. What next? This case was pretty tricky, and I was actually looking like the doctor in that cartoon. I was not sure what to do next. And the parents were asking me questions. They were educated and they were asking me questions. Doctor Saab, is this psychogenic? Ye psychogenic bhi to ho sakta hai. Why are we doing so many investigations? Do you think we were doing unnecessary investigations at this stage? I personally don't think so. Why? Because, as I said, there were just too many red flags. This was not like a usual psychogenic presentation of headaches. There were multiple red flags. The child was not a trained doctor to be able to mimic symptoms that would look like raised ICP. So what next? And his blood pressure was also borderline raised. So what next, right? So since we were convinced that this is a secondary headache, we tried to look for other causes of the headache. We did extensive metabolic evaluations where we found that his serum calcium was 14 milligram per deciliter. It was extremely high, but his vitamin D was normal. So at this very point, we immediately involved our endocrinologist, because a high calcium requires further expertise to deduce what is going wrong. And this is where we as neurologists also learned that hypercalcemia can cause headaches. It can cause hypertension, and it can even cause encephalopathy, and cardiac arrhythmias. So this child was in a precarious state at this point. So the endocrinologist quickly, hello, yeah. So the endocrinologist quickly deduced various investigations and also was able to prescribe their multiple medications to bring the calcium down to more manageable levels. And a nuclear scan revealed that this child was having a parathyroid adenoma. Since I'm not an endocrinologist, I will not go into the details of this particular investigations. Obviously, with this diagnosis, it is very clear that the family went doctor shopping all over Delhi after the child was stable and we were able to discharge him. And finally, sanity prevailed and he underwent a 3.5 parathyroidectomy. And after the initial readjustments, the child is absolutely well now. I have the follow-up of this child through the referring pediatrician. And this case I'm presenting here not to show that yes, hypercalcemia can cause headaches. This case I'm presenting here to show that when there are multiple red flags, one should try to deduce what is the underlying cause, and should not leave it as a psychogenic headache. So giving attention to your clinical acumen helps you reach a diagnosis. There are many causes of secondary headaches. Among them, the most common ones are non-specific infections and specific infections, including meningitis. I'm sure in your examination and evaluation, all of us are well equipped to detect and suspect meningitis. SOL is again something that we always suspect, but doing unnecessary neuroimaging is not helpful. There are many other causes. Let's not go into them, and let's go into the other learning points in headaches. So the other learning points in headaches that I wanted to highlight are the ones in primary headaches. So I'm presenting two very, very brief cases to highlight two further learning points here. So this was a 12-year-old girl who had on and off headaches since 1 year. So the moment you have a long-lasting headache, more than 6 months, you immediately know that this is very unlikely to be a progressive pathology. Because if it were a progressive pathology, it would have worsened by now, right? But the headaches had worsened since the last 1 month, had clear migrainous features, bitemporal, throbbing, photophobia. Basically, the child wanted to stay in a dark, quiet room whenever there was a headache, and the headache was severe enough that the child did not want to do anything and just lie down during the headache. It usually occurred late in the morning or afternoon. It was not an early morning headache. It did not wake up the child from her sleep. Neurological examination, blood pressure, fundus were all normal. So basically, it was very clear this child had a headache and had a migraine headache, and she also had visual auras. I've just put in a few pictures of visual aura just to have a visual understanding of how the patient feels. And this is many times brushed off by the parents as something that the child is imagining because it looks so fantastic. But one should clearly ask for the history. Otherwise, we many times will not get the history of auras. So this child had migraine with auras, and she received multiple medications to control the migraine, but they were just occurring every second day and they were quite disabling. What next? In such a case, in any case of headache, whenever we are stuck, one should not forget to involve the psychologist. That is a major learning point, because in the common clinic variety of headaches, the headaches that present to us in our clinic and not in the hospital, there's a lot of psychological factors going on. This child was undergoing school bullying. And
Dr. Saurabh, we will have to wind up. We have 1 or 2 minutes more, please.
Sure, sir. I have just 2 slides left. Thank you, sir.
Thank you. Thank you, sir.
Okay. So this child was being bullied, and once this was taken care of, the headaches rapidly came down. The last and final message that I have in child with headache is this 15-year-old boy who had clear-cut non-migrainous headache. Again, on detailed history, the headaches were actually there since almost 3 years. rather than what initially they told that they were only there since 2 months. They had actually just worsened since 2 months. They were always there since 3 years. There were no features of migraine. And on further history, it was found that near school exams, the headaches increased and the child started consuming 1 to 2 tablets of NSAIDs daily. And that is where it was very clear that this was NSAID abuse headache rather than the actual pathology causing problems. The moment the NSAIDs were withdrawn, the headaches worsened for a few days, but then rapidly improved. And this is again a history that should not be missed in children with chronic headaches. These are just a couple of headache drawings. I'm not going into the details, but we can actually make diagnosis of migraine versus non-migrainous headaches just by asking the child to draw what they feel during their headache. With that, I would like to end this talk with just few pointers. In headaches, the most important thing is history, and obviously to recognize the pattern of the headache and a detailed examination. This is all that is needed to cover all the red flags. And if they are there, one should pursue the underlying diagnosis. But if they are not there, one should not unnecessarily do neuroimaging. Finally, one should have realistic goals for headache. Even I get headache, and I'm sure most of you also get occasional headaches. So one should have realistic goals for headache, and they should be communicated to the parents. And finally, a psychologist is an important part of the team managing headaches. Thank you.
Thank you, sir, for the nice and comprehensive lecture. I think, shall we move towards the next session, sir? As we are running short of time, question and answers, sir, please take in the Q&A box.
Right,
If you
Dr.
have time,
Shalini.
please. Okay, we are moving towards the next session. Next topic is sleep deprivation in clinician, possible solution. I request all the chairperson to please introduce Dr. Sanjay Chugh. Dr. Jani, Dr. Pruthi, please introduce.
We can start the session. Dr. Sanjay Chugh, we all know, is a well-known pediatrician and known for his work in sleep studies and cases. And Dr. Sanjay Chugh, sir, psychiatrist, sir.
Okay, I'm ready to start. Can you enable screen?
Yes, sir, it is enabled, sir. You can share.
No, it's not. It's saying you cannot start screen share while
Rohit, will you please allow that?
Yes, sir. Now please check, sir.
Rohit, be alert actually. No, every time you have to stop sharing. Yeah.
Yes.
Yeah, it has come, sir.
Okay, great. So I'll just start straight off. Thank you for having me here. The topic for today is sleep deprivation in clinicians and some possible practical solutions. So I've titled my talk, Sleep, Alertness and Fatigue Education, so that we stay safe. All of us are clinicians and we have faced problems with working long hours, working with decreased sleep, building up a sleep debt and so on. So I'm going to shed some light on what this sleep debt and sleep deprivation would lead to, because understanding what these are would probably be the key to overcoming or managing this problem in a healthy way.
So there is no screen sharing, Rohit.
We can't see anything. You know? There's a blank screen is there.
Sir, please, sir.
Now it is there.
Now can you see it?
Yes, yes.
So please set it on slideshow. Yeah.
Yeah. Now is it? Can you see this?
No.
No. Now we can see.
No. For some reason,
Please close the screen share once and then reshare, sir.
I have done that. Now, can you see this?
No.
No, sir.
Not visible, sir.
Then
Yes, sir.
Yeah.
no, but this is not the presentation. So we just go slide wise. I think this will work equally well.
Okay.
The other option is I have mailed the presentation to you. If someone can help me with moving the slides.
Rohit from the backup team.
Yes,
Rohit,
sir.
can you hear me? Can you help in
It's visible. It's visible.
So the
Yes,
screen is
visible.
visible.
So it's not running in slideshow.
Yeah, but he can run in the same mode. The screen is visible on this.
Okay, cool. So let's go like this. Unless the text is very small, then I'll see what is to be done. So the aim is to understand what sleep deprivation and sleep debt are, what their consequences are, and what some practical suggestions and tips are to deal with this problem. So my aims for today are to educate clinicians to recognize the signs and symptoms of fatigue and sleep deprivation, educate you people in alertness management and mitigation of fatigue processes, and basically encourage you to use these fatigue mitigation processes to neutralize the potential negative effects of fatigue on patient care and learning. Like I said, most of us have gone through phases when you're just not able to get enough sleep. Of course, as psychiatrists, we are probably more blessed than pediatricians are. We get a fair quota of sleep. But the problems with being sleep deprived are, some of these problems I've listed here. It can lead to chronic tiredness. It can lead to a lot of mood changes, irritability, frustration, anger, anxiety. There are mood outbursts. There are outbursts of temper. There's a difficulty in controlling emotions. And, once the problems cross a threshold, there's absenteeism. There might be times when you are just unable to work because of the pronounced sleep debt and the sleep deprivation that has been accumulated. Now, I was looking for studies which have shown that at least 60% of clinicians have admitted to having driven a vehicle while they were drowsy. 25% have admitted to having actually dozed off while driving. And again, a good percentage admit to driving faster when they are tired. Whereas if I were a patient, I was going to a clinician, I feel as a patient, I have a right to expect a healthy, alert, responsible, and responsive clinician. So let's move on to some basic information about sleep. There is something called a sleep urge, which is shown with this orange line. This urge to sleep is pronounced around midnight, and then there is one phase around sometime in the afternoon. There is a variation which is individual specific, and these are the two times when the body really needs to sleep. Now, sleep is one body function which is extremely important. The brain needs this sleep, like our streets need cleaners who are brushing away all the dirt, the dust, everything else that is accumulated during the course of the day on the roads. So it's almost as if the sewage workers come out at night while we are sleeping. There is a lot of synaptic pruning that takes place. All the learning that has taken place, which is not required, that is pruned. All the synaptic connections which might have happened, the synaptogenesis, the neurogenesis that might have happened during the course of the day, all of that pruning takes place during sleep. And during sleep, the connections which have been formed, which you need to retain. These are the basics of neuroplasticity. So during both REM sleep and non-REM sleep, the connections that the brain needs, it could be factual learning, it could be procedural learning, these are further strengthened during this phase of sleep. Now, if you see here, if you wake up around this time, and then as you go through the day, after 8, 10, 12 hours of staying awake, the need for sleep starts to increase. And if we do not have a healthy sleeping cycle or a healthy sleep pattern, it's always going to lead to problems. The sleep cycles, there are 4 to 5 of these cycles, essentially comprising of non-REM sleep and REM sleep. The non-REM sleep, there are 4 phases: stage 1, stage 2, stage 3, stage 4. I'm not going into the details. But there are 4 to 5 of these cycles. Each cycle lasts for about 1.5 to 2 hours. We need both these components of sleep in adequate measure. And if we do not get adequate NREM sleep, even on one night, there is a kind of a debt or a deprivation account which is set up, and the same applies to REM. And over a period of time, if we are not getting adequate amounts of either NREM sleep or REM sleep or of both, we pay the price in terms of some of the symptoms that I had shown earlier. How much sleep is adequate? Now, you could be a young adult, you could be an adult, you could be an older adult. I mean, clinicians, they work till they just fade away into the sunset. But it is estimated that a minimum of 7 hours is desirable. I mean, if push comes to shove, even 6 hours might be adequate. But 7 hours gives the glial cells inside the brain, inside the different parts of the body, all the time that they need to do the pruning. And now this is a slide that I pulled up from somewhere, which shows sleep deprivation and fatigue in different specialties. And if you see here, pediatricians report a much, much higher level of sleep deprivation than most other specialists. Maybe neurosurgeons have reported more, general surgeons have reported more, but largely pediatricians are the specialists in the top 5 in terms of sleep deprivation. When we see there is a sleepiness scale which is called the Epworth scale of sleepiness, we find that the sleepiness in clinicians is similar.
Rohit, please run the slides. Excuse me, sir, just a minute. Rohit, please run the slides.
Sir, I don't have this slide, so.
I have sent this presentation.
If you have in your mail, because otherwise this only slide we are seeing. How many slides are there, sir?
There are about 20 slides.
Rohit, just try it if you have in your presentation. You please continue, sir.
No, are you seeing all these slides that I'm showing, that I'm taking you through?
Sir, the slideshow, let us do the slideshow again.
Because
yes,
the single slide is going on.
That's why. Make it slideshow. Yeah, it has come now.
Oh,
make it next slide. Just move the slides. Let us see slides are working.
Okay, now
we can see. No, it is not moving, but it is one slide is there. Sleep apnea.
But next slide should come now. Sir, move to the next slide.
Now?
No, it's not moving.
I think if you can go again back to slideshow, it will start moving from the initial slide.
Okay, 1 second.
You start from the initial slide.
Did you get anything now?
Blank.
This is the introductory thing, the intro slide. Can you see this?
No, it is not there. Blank.
I had sent my presentation. I got an acknowledgement also that it has been received.
Rohit, please see to it. If it has come, then you have to.
We can run from your own platform. Rohit, please do it.
Sir, okay, I'll check.
Yeah.
Sorry, sir. Wait for a minute. Just a minute.
Yeah. I'm just forwarding the same thing to you again if you want.
It's such an interesting topic for
you stop sharing, sir. Dr. Chok, sir. Please, you stop sharing your slides. Then I think it will be possible.
Okay, I'll do it right away.
It is one of the most interesting topics, and we all are waiting for it.
And pediatricians are the most affected, as Dr. Chok is.
It's concerning everyone.
Sir, what is the reason for this? Why pediatricians?
See, it is basically a function of how, of the kind of cases, the number of emergencies that you would be expected to see.
Or is it because of the calls we get at night sometimes?
Exactly, that's exactly it. No? So you are expected to be awake, responsive to patients, your clients' needs, your patients' needs, the parents' needs 24/7.
That's right.
Okay, what are we doing now? I mean, Rohit, are you trying to do this? I've sent the mail again.
Yes, I am trying. Yeah.
Meanwhile, sir, you can start. You can speak meanwhile if you have this thing.
Okay, can you see this slide with these bar charts?
No, sir.
Here-
This is the first slide that is in.
No, sir. We only see the sleep deprivation in clinician sleep. I think on the left side, if you move the cursor on this slide, if
click on
you
the
click
slide.
here, sir.
Yeah.
Yes, sir. Click
Then
on
it will
this. Yeah, click on this, sir.
Yeah.
Yes, click on this.
No, it's not coming. Some connectivity issue is there.
Okay, let me stop sharing and start sharing again.
Yeah, that is it.
Do that, sir.
We are sharing from our end, sir, from the back
Okay.
end.
Okay,
Okay, good.
Dr. Chug, आप
Now, great.
stop sharing. Stop sharing from your side.
Okay, now can you see this introductory slide?
Yes.
Yes,
yes.
sir.
Okay, next.
Rohit, next.
Rohit, keep
Yes, sir.
listening to my next, please.
Yes.
Next. This we have gone through. Next. Next. So this, I'll just go through this quickly. The problems with being sleep deprived are listed here: chronic tiredness, changes in mood, irritability, anxiety, anger, frustration, temper tantrums, mood outbursts, inability to think in abstract terms, absenteeism, you cannot focus, so there are days when you decide not to work. All of these are possible consequences of being sleep deprived. Next, Rohit. Next.
Next.
Next. So patients have a right to expect a healthy, alert, responsible, and responsive clinician, which is what we are trying to achieve today through this presentation. Next, Rohit. This I explained that there are sleep urges. Predominant sleep urge happens at night, and there is one sleep urge spike in the afternoon. And we see here that once you wake up around this time and you have been awake for about 8, 10, 12 hours, the need for sleep starts to spike. And if at this time you get a call at night, you have to go to your hospital, your nursing home, you are on emergency ward duty, that is when your sleep deprivation starts to build up and your sleep debt starts to build up, both of which are extremely hazardous. Next, please. These are the the phases of sleep that I was talking about. There are 4 to 5 of these cycles every night, which comprise of non-REM and REM sleep. Both non-REM and REM are very, very essential components of sleep. Factual learning takes place in NREM. Procedural learning takes place in REM sleep. And if either of these is impaired, because you're not sleeping enough, because there is a sleep debt, because there is sleep deprivation, so the brain essentially stops learning how to learn, which is potentially cause for a huge number of problems. Next. 7 hours is estimated is the minimum duration of sleep. You could be a young adult, an older adult. Push comes to shove 6 hours, but I would recommend 7 hours. I'm very, very happy when I sleep 7 hours. And I know that when I sleep only 5 hours at night, I am never feeling as bright, as cheerful, as chirpy as I normally would. Next. Here I showed how pediatricians, pediatric clinicians, they report a sleep deprivation index of upwards of 3, which is very, very high. The only comparative numbers would be in surgery, neurological surgery, gynecology. So pediatricians, all of you need to take great care of your sleep hygiene. Next, please. Rohit, next. Sleepiness in clinicians is equivalent to that found in patients with serious sleep disorders like sleep apnea and narcolepsy. In fact, this slide that I got, it says residents, but it was essentially a survey done on doctors. Your sleepiness score on the Epworth sleepiness scale is 14.7. if you are a clinician and slash a doctor, even if you have sleep apnea, your sleepiness scale is only 11.7. So there is nothing which comes close to sleep deprivation in clinicians in terms of the potentially fatal consequences that it can have. Next, Rohit.
Rohit, next.
I've added these two slides. Again, it seemed interesting to me. If you look at specialty-specific index evidence, in pediatrics, it was seen that the time required to place an intra-arterial line increased significantly if the resident or the clinician was sleep deprived. And there is another interesting observation in the next slide. Rohit, next, please. Again, 21% where pediatrics is concerned, the clinician was 21% more likely to make riskier patient care decisions after a single 24-hour call shift. This is the impact of not getting adequate non-REM or REM sleep, even in a single 24-hour cycle. And if it is prolonged, if it is cumulative, then the consequences, they do not just multiply, they increase exponentially. Next. So now we come to alertness management strategies. There are 5 things that I have mentioned here: use of caffeine, use of exercise, light, napping, and medication. Next. A lot of us use caffeine to stay alert or to try and stay alert. Now, caffeine, the onset of its stimulatory action is about 15 to 30 minutes, and it lasts for about 3 to 4 hours. My advice is that if you have to stay awake, you must time your dose accordingly and appropriately, never losing sight of the fact that if you take extra amounts of caffeine or you take caffeine closer to your sleep time, it will either affect your ability to go to sleep or it starts to disturb the architecture of sleep, which means you might go into stage 1, stage 2, stage 3, stage 4 sleep, but you might not be able to go into REM sleep if there is caffeine inside you. The second strategy for enhancing alertness is exercise, which means that, essentially use your body to move around, even if you do not have time to get in the requisite amount of aerobic exercise, meditation, yoga, and all the other good things that are advocated by everyone, everywhere. For a clinician, physical exercise actually gets a lot of chemical secretion going inside the brain, inside the body, which is true of serotonin, which is true of dopamine. Endorphin levels go up, and this release of these chemicals is directly proportional to the amount of exercise that you can get. Light or exposure to light. The greater the exposure to light that an individual has, the greater the release of serotonin inside the body, inside the brain. Because real sunlight actually is a kind of a raw material for the secretion of serotonin. So if you can get a certain amount of real sunlight on a daily basis, that's great. But if you can't, then just exposure to any kind of light would help. In fact, there is a condition in psychiatry called seasonal mood disorder, where the treatment of choice is phototherapy. Next, Rohit. Napping. One of the healthiest ways of dealing with sleep deprivation. The optimal time that we recommend for a short nap is 45 minutes. If you nap for more than 45 minutes, you run the risk of something which is called sleep inertia. Sleep inertia is a stage where your brain is fogged, it is hazy, you are groggy when you wake up. So like I said, the optimal short nap time is 45 minutes or less. The advantage, of course, is if you sleep for more than 45 minutes, whatever time that you can get to sleep, it reduces your sleep debt. And the ideal napping time is 2 hours, which allows both REM sleep and overall restorative sleep. The only medication which I would prescribe to someone who says that he's sleep deprived, needs to stay alert for a certain length of time, is modafinil. It's not a stimulant. We still do not know how exactly it works. It is believed to act primarily on the reticular activating system. But even if you take modafinil and you manage to stay alert for the time that you need to stay alert, it does nothing to remove the debt of sleep that has been accumulated. You will still need to make up the deficit to remove the detrimental effect that this sleep debt and sleep deprivation are producing. Next, Rohit. And you must be on the watch out for these few things. Micro sleep. Micro sleep is sleep which typically lasts for 30 seconds or less. And anyone who's sleep deprived, I'm sure all of us have experienced it at times, where you find that, you've suddenly gone blank for a very short period of time. You were non-responsive. Someone was saying something to you. You probably did not hear what the person was saying. You were not responding. Sleep inertia, I said, it's that stage of brain fog or fogginess or haziness when you take short naps lasting more than 45 minutes. Circadian lows, there are specific times during the day when your level of alertness will be compromised. I'm, of course, talking about people who are existing in a state of sleep debt. Isolation and self-deception. We keep telling ourselves that, I'm very alert, I can go through it. You cannot power through a day when sleep deprivation is going on. You only feel that you are able to power through the day. You are at risk for taking risky decisions, faulty decisions. Your processing time is slowed down. Your reaction time is slowed down. And finally, in high-risk jobs where the sleep deprivation is there, where you are forced to stay awake, there might not be enough stimulation for you. Let's say you're sitting, you're monitoring someone on the ventilator in the ICU. Now, you might not need to be alert and active continuously, but that state is also dangerous for you because you are staying awake, you're forcing yourself to stay awake while the stimulation is not there to get the brain functions moving. So my advice is that you must watch out for these, not only in yourself, but also in people around you, your colleagues, your peers and all, because if you can identify any of these in someone around you, then maybe you're doing that person huge service by telling him or her that, I think this is what is happening. You probably need to focus more on getting your sleep cycles in order. Next, Rohit. So simply put, what I've stated here, you have to protect your sleep. You might need to cut down on certain social engagements. The aim is to sleep. You have to work. I have to work. If we don't work, there are so many things which we would probably miss out on. But if we are running the risk of sleep deprivation, then nothing is more important than protecting your sleep. You don't have to go back. You don't have to watch Netflix or Amazon Prime or watch TV, whatever. Your sleep has to be a number one priority. You have to protect your sleep at all costs. That can happen only when you optimize your sleep environment. My advice, which I give at least 20 times a day to people who come to me, is your bed is only for sleep or for sex. Do not use your bed for any other activity. Practice good sleep hygiene. Have as much exposure to bright light as possible when you need to be alert. And if you have worked a night shift, avoid light exposure in the morning because that is suddenly going to fire your hypothalamus up, and the chemicals that need to be released, they are not going to be released. I mean, of course, melatonin has a huge role to play in this. So if there is an inappropriate secretion of chemicals inside the brain, when you actually need to sleep, you will lie down. You have only a few precious hours during which you can sleep. But if you are exposed to light, you will not get that sleep. Next. This is my last slide, then I would be happy to take questions. So sleepiness and fatigue cannot be eliminated. We have to accept that, but it can be managed. The primary way of managing it, to learn how to recognize it and to identify it, and then to accept that it is there inside you. Recognizing sleepiness and fatigue in yourself and your colleagues is the primary step in managing it. Practice these alertness management strategies, which I discussed earlier, on a regular basis, and do not overlook recovery periods. You might not eat for a few days. If there is a deficit of 1 chapati a day, if you get proper food after 10 days, you will not eat 10 extra chapatis on that day. But where sleep deprivation is concerned, if you have accumulated, let's say, a deprivation of 20 hours of REM sleep, until those 20 hours are met, your sleep will not go back to its restorative quality. Next slide, Rohit. Okay, so that's it from my side. I would be happy to take questions if we have any time. Otherwise, I can do it in the chat.
I have a question. I have a question.
Yeah.
Sir, you said 7 hours of sleep is enough throughout the day. Can we divide it into two parts? Like pediatrician clinicians, we have two shifts, clinical shift, morning and evening. And we sometimes get time for nap in the afternoon. If we sleep for 5 hours at night and 2 hours in the daytime, will it be all right? Or
The human system and biology anticipated that pediatricians would need to sleep twice during the day. That's why in that slide I showed that the sleep urge is there in the afternoon. It is not as pronounced as it is at night, but there is one phase in the afternoon when your body and brain are primed and ready for sleep. You must sleep. And you should ideally try and sleep for a minimum of 2 hours so that you get at least one full sleep cycle comprising of both NREM and REM sleep in that time. And then, I mean, it might not be as good as sleeping 7 hours at a stretch, but so be it. Sleeping 2.5 hours at night and sleeping 5 hours at night is still doing the trick.
okay, thank you.
Thank you, sir, for excellent talk. We will take question answer in the
one just last word. Sir, very nice talk for everyone. I just want to know, just last thing, I will not take much of the time. What are the long-term effects of sleep deprivation, like person in the 50, 60 clinicians who have been sleep deprived? Or does it prone to Alzheimer or the other consequences, and which are irreversible or anything?
Undoubtedly, it is shown that sleep deprivation is exactly like burning a candle from both ends. There are studies which are showing that the telomere shortening happens much faster in people who are sleep deprived. And we know that essentially that's a manifestation of the wear and tear that's taking place inside the body. So you run the risk of something like dementia. So degenerative diseases, you are increasing the risks. I mean, if I talk purely as a psychiatrist, the incidence of depression is much higher. The incidence of anxiety disorders is much higher. And then what I see very commonly is that because you are desperate to sleep, you start taking one pill and you develop tolerance to that. So the consumption of sleeping pills goes up, the consumption of alcohol goes up, and it's a very, very vicious cycle. You start taking those chemicals, they distort your sleep architecture even more, and actually you end up increasing your sleep debt.
There is no stage of reversibility at any time that at this stage we have been deprived, now we have followed this thing, not like that.
See, you can always slow down the progression of the problem. I mean, if I have done something wrong for the last 15 years of my life, I do not necessarily have to do it for the next 15 years of my life. Let me say, okay, I'm going to slow down from today and try and slow down the damage that the last 15 years of my life have caused in my life.
Thank you. Thank you.
Thank you, Chuk sir. Thank you, Dr. Pruthi. Thank you, Dr. K.K. Jani sir. Now, after this wonderful session, we will move to the other session. The session is Staphylococcus aureus invasive infection. It's a panel discussion which is based on cases. Now, I invite the chairpersons for this session, Dr. Ritabrata Kundu sir. Sir is a professor of pediatric medicine, Institute of Child Health, Kolkata. He is the past chairperson, IAP infectious disease. Dr. Dheeraj sir. Dheeraj sir is professor of at Department of Pediatric, UCMS and Associated GTB Hospital. And sir was the editor of Indian Pediatrics from 2014 to 2019. And Dr. GP Kaushal sir is a leading pediatrician of Delhi. And he is executive board member of Central IAP from Delhi. Now I invite all the chairpersons to introduce our speaker, Dr. A.K. Chitkara sir.
Yeah, welcome Dr. Chitkara. Dr. Chitkara is a very old friend of mine. He was the past chairperson of the infectious disease chapter, and he is very well known in the infectious disease field. I don't think he needs any further introduction.
Okay, do I start, Dr. Kundu?
Yes, start. I knew that I was a panelist. I never knew I was a chairperson.
I'll need to share my screen, and there I go. So, are my slides visible?
Yes.
So I'll put it on slideshow. I was supposed to have Dr. Bala Subramaniam also in the panel, but I don't think he's logged in as of now. So, as per the program, Dr. Bala Subramaniam, Dr. Kundu, Dr. Dheeraj Shah, and Dr. GP Kaushal are to be my panelists. And today what we are discussing is a staphylococcal infections, right from the superficial till the invasive diseases. And before in fact I start, एक हिंदी पिक्चर का एक बहुत बढ़िया सीन है, अगर आपने जॉली एलएलबी देखी है तो जज साहब कहते हैं कि the day one he knows who is the culprit but keeps waiting on evidence for years altogether. As far as my cases today are concerned, I have the 100% evidence, yet there are problems with decision making. So that is what in next 40-50 minutes we are going to bring it out. These problems when you practice, whether in your clinic or indoor patients, and these are the dilemmas which you are faced with in spite of the fact that you have 100% evidence. See, we talk of evidence-based medicine, but little do we realize that in this race for evidence-based medicine, our clinical acumen or a clinical sense or a decision-making based on that or experience has become probably a taboo. And these are, I think, becoming forgotten arts. So there are issues. So when we discuss staphylococcal infections, you all know it is a very notorious bug. As of other microorganisms, there is an emerging antimicrobial resistance and starts with colonization of the nasopharynx. The bug has lot of virulent factors, which we sometimes also refer to as toxins, and they are responsible for the different clinical manifestations we have of the disease, right from when toxin based, either a shock kind of a syndrome or a food poisoning. If they get localized, we have those boils, abscesses, sinusitis, etc. Once they enter into the bloodstream, you have all those invasive infections. So this was just a brief recap of the staphylococcal infections. Now, when we start with the skin and soft tissue infections, it is always based on the skin structure which gets involved and the diagnosis we give it. But peculiarly, there are only two organisms which are notorious for this, and they are the Staph aureus and the Strep pyogenes. Now, here are certain few of the recent cases of superficial infections, whether they are impetigoes, bullous lesions, lymphadenitis followed by an abscess, or a periorbital abscess, erysipelas. So these are the various conditions. And going on to a little more extensive local infection in a case which started from a nasal furuncle and went on to preseptal orbital cellulitis, and it took almost 4 weeks for the patient to recover on appropriate anti-staph treatment. Now, with this background on the recent cases, there are certain issues that emerge. So one, Dr. Dheeraj Shah, when we see these superficial infections, do you think any investigations are required, or it is certain that we are on the right clinical diagnosis and we start treating? Dr. Dheeraj. Dr. Dheeraj.
Dr. Dheeraj, sir.
Chitkara, I think, shall I?
Okay, Dr. Kundu, you can take up.
Actually, if the simple superficial skin and soft tissue infection does not require any investigation as such, we jolly well can go for the treatment itself. At times we are confused. Supposing if you have a non-bullous impetigo, it might be both due to staphylococcus and streptococcus. So when we give prescribe any medicine, we usually try to cover the both. But if you take it theoretically, it is always that one should go for this past stain, culture and other things. But if you do this extensive investigation for a simple non-bullous impetigo, your patients and the parents, they will feel that he's not a good doctor. For some such a small thing, he's going for those things.
But would culture be important for these superficial lesions, Dr. Dheeraj?
Sir, in superficial lesions, if you are not bothered about starting the oral or systemic antibiotics, it should not matter, because most of the topical treatment, it doesn't matter whether you are dealing with MSSA or MRSA. So I think a simple skin infections, soft tissue infections, where you need to treat with the topical biotic antimicrobial like mupirocin, you don't need to do any culture. But yes, if you need to start the child on oral or parenteral antibiotics because of any indication, then I think a culture or gram stain with culture is warranted because before empiric antibiotic therapy, because if you need to modify the treatment, you can take an informed decision.
Okay, so therefore, if you say you want to start oral antibiotics for these superficial infections, maybe culture becomes more important. So the next question, Dr. GP Kaushal, would you be happy treating these kind of scenarios which I have shown you with just a topical treatment, or you would really decide on oral antibiotics?
Sir, if it is just a localized infection, not very deep seated, then topical mupirocin or fusidin will do. It is only when some systemic manifestation or you suspect that it is something deep is going, then oral antibiotics are needed. In that case, we should go for culture sensitivity also. And I just want to add on a previous discussion that sensitivity pattern will also tell us about a little bit about whether it is community acquired or it is a hospital acquired infection. That thing we can go ahead.
Dr. Kundu, would my oral antibiotic therapy for these superficial lesions would depend on the how many lesions I have, any site of lesions?
Yes. When the lesions are very close to the mouth, the child might lick the topical antibiotics you are giving very close to the eyes. So those are the places where you'd like to give oral antibiotics. And also, if the lesions, as rightly pointed out, is deep-seated, serious, multiple, numerous, then also you'd like to give oral antibiotics.
What about the size of the lesion, Dr. Kundu?
Yes, if it is a big lesion, say a covering whole area, it's a cellulitis associated along with it, then definitely you don't take any risk. And there are some places where you not need that there should be scar formation and other things. So there you both give topical and oral antibiotics so that it might heal quickly, not leaving behind any scar or any mark.
Okay. In general, it is said that if you have multiple pyodermas, one, or you have lesions on the face, genitals, or the gluteal region, it makes a case for using oral antibiotics because these are the sites where rapidly pus formation occurs, and most of these purulent formations then go on to very bad consequences, especially when we are concerned with staph. So when it comes to selection of an antimicrobial, Dr. Dheeraj, are you there? Okay, so I have two panelists missing. Okay,
Dr. Dheeraj is here.
Dr. Dheeraj.
Dheeraj, sir.
Dr. Dheeraj.
Sir, just a minute, I just call him. Huh?
Okay, Dr. GP Kaushal, how do you choose an antimicrobial sitting in a clinic, in a hospital, where you get all these kinds of superficial infections?
Sir, as I previously mentioned that topical antibiotics will do for localized infections, and depending upon whether it is MSSA or MRSA, that will depend which antibiotic we need to choose. If it is methicillin sensitive strain is there, then cloxacillin, ceflexin, oral or amoxiclav will do. Even second generation cefuroxime is good enough for that. But if it is MRSA, that resistant pattern is noticed, then vancomycin, clindamycin, or even more advanced one, linezolid or daptomycin, we go for those antibiotics. And route will depend upon how quickly and how serious the child that infection is. If it is a life-threatening sort of thing is there, then IV we will go prefer the antibiotics.
But if Dr. Ritabrata Kundu.
No, I want to add only one thing. Clindamycin also gives a very good cover against streptococcus. When you're not sure whether you're dealing with a pyogenic streptococcus or staphylococcus, then clindamycin gives a very good coverage of both Strep2 and Staphylococcus, not only all types of Staphylococcus, both MSSA and MRSA.
Okay, Dr. Dheeraj, since you work in a busy OPD in your government hospital, if I don't do cultures in some of my patients which I get in my particular hospital, how do I decide whether MSSA problem is more with me, MRSA problem is me, with what we are seeing? So how do I choose an antibiotic for these without doing a culture in at least some of the cases to know what are the trends of staphylococcal resistance?
Yeah, it's a tough decision sometimes, especially if you have a local, that would be the best. If you know that in your area or in your practice you are dealing with the majority of methicillin resistant organism only, you can start with the oral antibiotics against MRSA. But empirically, starting with an oral antibiotic without knowing the oral epidemiology is a difficult choice because of the emerging resistance. So I would say that in non-serious infections, I would start with the MSSA antibiotic only to begin with. And if the child does not respond, along with definitely the local management of the wound or the aspiration of the pus, if it can be done. And if the child does not respond, I will go for a culture and the second line antibiotics against MRSA.
Okay, Dr. Kundu, what about doxycycline in children? Because it has got a good MRSA activity and is a drug which we seldom use in pediatrics.
Yes, doxycycline is a very good drug. And now scrub typhus is on the increase, and we are using doxycycline even below 8 years. You are giving it for a scrub typhus, and nothing is happening. It's quite okay. None of the children has yellow teeth or anything. So I don't think why we have a reservation of giving doxycycline below 8 years. I think it can be removed by this time.
Okay, the general consensus today in the literature is that doxycycline, see, we pediatricians are afraid of using tetracyclines in children because of staining of enamel. But it has been seen that doxy is one tetracycline which has less calcium binding.
Yes.
And probably for short courses less than 21 days, it is safe to be used in children. So
You're
there,
using it right and left for scrub.
one suggestion is that sometimes when you get exhausted by a drug for an MRSA or these infections, when you treat on an ambulatory basis, maybe doxycycline can come to help. Dheeraj already said that source control or the aspiration of the pus is very important. I would just add, in some of these cases, when you aspirate pus, we always talk of data not existing, but unless we have the habit of culturing for at least some cases in our practice, be it OPD or IPD, we don't send pus cultures. How do we get epidemiological data? So therefore, some of the cases it is important. Another question which troubles us is what should be the duration of treatment, Dr. Dheeraj Shah? I have a small abscess. I have treated with, let's say, 4 centimeters, 5 centimeters. I have treated with oral antibiotics, source control, and localized mupirocin after aspiration. How long should I be giving oral antibiotics?
Sir, I think if it's just a skin and soft tissue infection, which is well controlled in the local drainage aspiration, local management is possible. I think 5 days should be enough. But if it is more complicated disease with deep-seated infection, with maybe necrosis or any then the rule of thumb for most staphylococcal infection is a minimum 2 weeks treatment for whether it's an invasive infection. When it has invaded the deep layers of the skin, especially fascia, and if it has involved it caused more widespread invasion, then in minimum 2 weeks, but just restricted to skin and epidermis, dermis, and the local management can be done, then 5 days or maximum 7 days should be enough. So I would say 5 to 7 days for local, well-controlled infection, and 2 weeks for more deep-seated, complicated kind of infection.
Just to apprise you, there were a few studies when there's some people tried only source control and local topical antibiotics, which did not do the job. Then they also followed it up by a study on 3 days or a 5 days. 3 days fared much less than a 5 or a 7 days course. So therefore, superficial infections, I'm not talking of necrotizing infections. 5 to 7 days oral antibiotics if you have started that. Okay, Dr. Kaushal, when do you think the hospitalization would be needed for these children? Let's say children who have come with let's say an abscess. I showed you a case where there was an abscess in the periorbital region, which was good about 4 or 5 centimeters. Should I be hospitalizing and giving parental antibiotics or put them only on oral antibiotics?
Sir, if you manage source that you have properly drained it, then oral antibiotics will do. But if there are systemic manifestations in the form of that child is not able to accept oral drugs, or is having other issues, is vomiting, or he's having other systemic manifestation, then you need to admit that child and administer parental antibiotics for the duration, at least when the child is clinically stable. After that, child can be shifted to oral drugs. Plus, it also depends upon the site of infection also. Suppose there is some bone involvement or joint involvement is there, then you need to give parental antibiotics for at least 2 to 3 weeks, followed by another 2 to 3 weeks of oral drugs.
Okay, so they, if you have more of a systemic issues, constitutional signs and symptoms, then probably, or the patient not taking orally, then probably these are indications, or the vitals are not stable. That means the disease is going on to an extensive or an invasive kind of a phase. These are indications for hospitalization. So, Dr. Kulu, how common are these secondary invasive diseases from these superficial disorders?
Yes, they do occur. They do occur in, especially secondary invasive disease is more common in immunocompromised children who have extensive eczema. So you have to think of those things. Immunocompromised children with extensive eczema, and, and those children, those who have certain problem in the, especially in the leukocyte defects. Say if it is a Job syndrome, Chidak-Higashioka, there are certain groups of certain things. There the chances of secondary invasion is fairly high. So you have to be very careful about this, and you have to examine the child frequently, so to see whether it is going in a secondary invasion. I can tell this septal cellulitis, preseptal cellulitis, which you have shown, it has always a chance to go inside unless and until at least you give IV antibiotics for first few days. So also necrotizing fasciitis, it can cause a havoc if you don't manage it properly and keep a regular check. So those are the cases where you have to think of secondary invasive disease fairly high.
So therefore, extensive purulent lesions near the eyes, number one, or involving the, let's say, the nasal furuncles with a lot of cellulitis with constitutional symptoms, immunocompromised individuals, and those with already pre-existing comorbidities of the skin, whether it is atopies or eczemas, they do not fare well on just ambulatory treatment and probably should be hospitalized. Okay, Dr. Kaushal, you practice a lot of neonatology in Ambedkar Hospital. Often on a third day or a fourth day visit, we find a newborn who has just come with 1 or 2 pustules in the nape of the neck, or probably an occasional pustule in the axilla. And sometimes you have a neonate with a widespread multiple pustules, extensive disease, or something like an omphalitis or an umbilical sepsis. Are the guidelines or the treatment protocols any different from what we have discussed for older children in the previous slides?
Yes, if disease is very localized, like in the first baby, few pustules are there, then you can manage these with local treatment only. Even just muprocin, local muprocin will do. If it is extensive disease in the form of bully and then extensive areas are involved, you have to go for uh, systemic antibiotics also. Along with that, you have to see the clinic, how the clinically child is, whether the child is having some systemic manifestations of sepsis in the form of child is lethargic, not accepting, other signs of sepsis are there, then you have to go for systemic antibiotics. Like in the third, this is a typical case of omphalitis, periumbilical redness is induration is there. In this case, there are chances that the child might develop systemic manifestation, will be having systemic manifestation, then parental antibiotics should be given to this child. Like in this is a lot of abdominal distension, this abdominal wall erythema is there, then systemic antibiotics have to be given.
Okay, so you have always have a very high index of suspicion when you have a
In
new
neonates,
with the
always.
concern.
Chitkara, my time is over. Chitkara, I have a meeting. I beg you,
Okay,
please.
so I'll manage with Dheeraj and Dr. Kaushal.
Thank you,
Yeah,
organizer.
yeah.
Thank you, everybody.
I
Thank
called
you, Kundu sir.
Dr. Chitkara. I called Dr. Bala, but somehow he informed me that he did not get any communication. And he cannot join now because he's traveling. So no ways. We will take all the burden of in questions, and we will take your
Anyway, Dr. Naab से शिकायत लग गई है. Okay, so we move on to the Dr.
And
Dheeraj.
another thing, sir.
हम जब LNJP में और रूरल पोस्टिंग में होते थे, every now and then we'll have the same child. घूमड़ी होगी. These were, you know, those pyoderma.
मैंने कर दिए सर उसमें चैट में.
हैं? So recurrent pyodermas, children coming with recurrent pyodermas. What do you suggest? How can we prevent these recurrent pyodermas? I don't see very often now in clinic, but there was a time in the 1890s everyone would walk in with gomdis और हमारे पास वो नीली और लाल दवाई होती थी सबको लगा. So things have changed, but there are certain children who come with recurrent pyoderma. So what do you advise for prevention of recurrent pyoderma? Dr. Dheeraj.
Yeah, sir. Once somebody is having a recurrent pyoderma, I think the most important thing to take care of is personal hygiene. I know the colonization carrier state is quite high in Indian children. In our study, one of the studies which we have done, we have found it to the extent of 60% in children with staphylococcal infection. But the most important still thing is the good personal measures. Because anyway, even if you have the bacteria, if you take personal hygiene, it is unlikely that you are going to inoculate those bacteria into your deeper tissues. So good personal hygiene, good, especially the care of the care of axilla, care of nose, a good perineal washes, hand washing, avoiding sharing of clothes. And whenever you have skin trauma, it should be washed properly, repeatedly. Keeping your intertriginous area dry. So the personal hygiene is the most important, and followed by if you can screen the family for staphylococcus carrier, especially if the infections are troubling every time they're occurring over the face, requiring repeated course of parenteral or oral antibiotics, deep infection, then definitely family screening for carrier and treatment of the carrier state becomes important. I think the most important are personal hygiene measures.
Family screening and probably nasal application of mupirocin for the entire family members comes very handy when you have children or multiple family members with pyodermas. Okay.
Yeah, that becomes important, but that still is not the only solution, because this carrier state, even if you eradicate for once, then it tends to return. So it's not a permanent solution, and I think you still have a staph carrier, and if you have a good personal hygiene measures, you can still prevent staphylococcal infection. But definitely screening for carrier state children with recurrent infection and eradication of the carrier state, which is tough but not impossible. It is one of the measures.
It is
and periodic surveillance.
Personal hygiene. Dr. Dheeraj, you talked about your staff carriage studies. What is the pattern of resistance you found in your study or in your institution? How much is these days MSSA, MRSA, Klinger resistance, erythromycin resistance, and what do we really make out of it?
Yeah, actually, the situation in this thing is quite bad. I would, if I say, I think this paper was won the STHR award last year only. My student, we are now facing very high, almost. If you see the most of the Indian studies, about 40 to 50% are now methicillin resistant staph aureus. But in our resistant staph aureus, and not only they were methicillin resistant, about again 2/3 of these 2/3 means 68% of the 62% they were multi-drug resistant. So that was another thing, and even 100% were sensitive to vaccine. So the situation appears quite bad, especially because most of the although these are community acquired infection, the improper treatment makes this resistance scenario in Staph aureus quite bad. So I would say 2/3 MRSA, 1/3 MSSA in our institute, and along in the MRSA also again 2/3 are also multi-drug resistant. They are clindamycin resistant, and they 50% of them, although sensitive to vancomycin, but they are showing already features of intermediate sensitivity.
So therefore, going back to my earlier question, if you say 2/3 MRSA, what would be your choice of an oral antibiotic for these superficial infections in your OPD in a GTB hospital?
सर ओपीडी में तो जो दवाई फार्मेसी में आती है वो देनी पड़ती है, so that is a problem. But to dispense or write a prescription, I think we should start with the oral clindamycin, or maybe in combination of oral cotrimoxazole and especially. But definitely those infections which can be managed, antibiotics like mupirocin, I think still topical is best because you don't face the challenge of induction of resistance. But if at all we take that epidemiology into consideration, it's but one more thing I would say that this study is about to do a study in the skin and soft tissue infections alone, because these are the data of I would say Staph aureus, which were there in the hospitalized patients. So it's need to study the data for skin and soft tissue infections on outpatient treatment.
Okay, so I give you data for that. Since 2018 and 20, we have a progressive increase in MRSA and clindamycin resistance, and I am talking only of OPD cases. In my own clinic, where I have a lab, 14 samples in last 6 months, MRSA was 50% and clindamycin resistance was 7%. So therefore, most of the superficial infections we get in our clinic these days, we are really worried in using drugs which are good for MSSA but not MRSA. So I give you even a hospital data. Again, these are hospital OPDs, not indoor. I have up to 50%, almost 45% of MRSA, and emerging clindamycin resistant to the tune of 13%. So if I go by the IDSA guidelines, I need to probably revise my empirical treatment for all these superficial infections. It is, you have the evidence, yet you say ki jo dawai available hai. So these are compulsions probably we have to live with. But here बात वही
These are more, yeah.
पहले एविडेंस होता नहीं था, अब जब एविडेंस है तो हम उसको डिसीजन मेकिंग नहीं कर पाते हैं. So I leave superficial infections at that, just showing you an algorithm that ultimately your empirical treatment would depend upon how much MRSA and MSSA you are dealing in your practice, and never depend on other antibiograms for other institutions and other regions for deciding empirical treatment in your institution or in your clinic. So let's we have 21 minutes, and I'll go on to some interesting invasive staphylococcal infections. I have again evidence, but yet there were difficulties in treatment, which I think both you and Kaushal would be there to address. So this is just about 3 months back. 10 months male, fever, cough, irritability, erythematous rash, which was progressive for 4 days, was transferred from another hospital as pneumonia right side with pleural effusion. Since the child was rapidly deteriorating, was referred to us, and the patient had respiratory distress, maintaining saturations at 95% in room air. There was periorbital puffiness, rash, which you all see, and had some pedal edema and right cervical lymphadenopathy. So the X-ray which the child came had some haziness in the right lung plus effusion. And this patient at the same, so we thought since the patient has come with a rapidly progressive pneumonia and as a sepsis-like presentation with a lot of systemic signs which are there, lymphadenopathy, rash. So we thought either it is a sepsis condition where could be a strep pneumonia or a staph aureus. Also, since we are in the COVID phase and we had a lot of cases who had come with MISC COVID, which were KD-like presentation, and this child met quite a few of the criteria of Kawasaki disease, we thought MISC KD-like could be a possibility. We continued ceftriaxone and vancomycin and sent some investigations. There was leukopenia, platelets normal. The inflammatory markers were too high for a sepsis condition with ferritins, dimers, IL-6. Why we did it? Because after having had a few MIS cases in this COVID times, we invariably would do a baseline anti-inflammatory markers. This child was dengue negative, blood culture no growth, but was COVID positive. The respiratory PCRs were negative for most of the bugs. BioFire, which we use, about 18 bugs. Echo was normal. So in view of RT-PCR COVID-related Kawasaki-like features, we thought we were dealing with COVID MIS-KD type. We gave IVIG within 24 hours. The fever, rash, lymphadenopathy, and the general condition improved in this child over the next 48 hours. The day we wanted to de-escalate vancomycin, thinking that we have won over this MISC KDs and the child is improving, the child had fever again. There was an X-ray 48 hours later which had showed sign of improvement with a minimal effusion and the lungs were quite clear. So we were certain that probably we have overcome whatever inflammatory disease was there by IVIG, or we could have stopped it. Fourth day fever again, the lungs became bad. We aspirated thick pus, which showed gram-positive cocci as well as gram-negative bacilli. We did a CT scan for this child, but since we have seen GNBs and GPCs, we escalated our antibiotics to meropenem and linezolid. The pus culture, the pleural fluid came to us as MRSA, which was clindamycin resistance. So I'm talking of evidence. The CT was very bad, and if I show you this video, the entire lung was encapsulated by a thick organized effusion. We asked our pediatric surgeon to intervene, and he thought probably better than VATS with this. The CT picture was very bad, showing almost a plastic-like structure and, entrapping the lung, which was not able to expand, the child going into respiratory failure. So instead of VATS, he decided on doing a decortication, and there was a thick pleura which was encircling the lung. Decortication was done. The patient was with us for 2 weeks. From leukopenia went on to leukocytosis. Platelets kept on increasing markedly, thrombocytosis. CRP a gradual fall. Procal was at the time of admission positive. Inflammatory markers decreasing. Microbiology, except for that RT-PCR positive and the staph MRSA in the pus, we did not get anything else. And this was post decortication. Since we had suffered with a right lung organized empyema, there was effusion post decortication in the left lung. In spite of the fact that it was a thin fluid with just lymphocytes 600 cells, probably we thought reactionary, yet we put in an ICD, fibrinolytic fused. This was at discharge, only pleural thickening, and this is 6 weeks later when the lungs have almost cleared up and the child is doing absolutely fine. So the questions for my panelists: was it MISC KD type or was it staph sepsis we treated? Dr. Dheeraj Shah.
सर ये वही जवाब है कि आई थिंक द कल्प्रिट वाज देयर फ्रॉम द बिगिनिंग बट वी डिडंट recognized, and we recognized, but we, because of the COVID situation, we started treating for COVID first. So I think it's a staph sepsis to begin with, because here you are having a child with all these features which are suggestive of sepsis. Markers are raised definitely much more than what you usually get in sepsis, but still everything like edema, this redness of palms, this all can be present in staph. So staph sepsis also has vasculitis. COVID positivity will not be usually seen along with the MISC. Usually it develops after the COVID report has already become negative and you see antibodies rather than antigen positivity. So I would say that most likely the COVID here was coincidental finding, and it was staph sepsis to begin with. And or maybe the COVID might have exaggerated the manifestations of staph sepsis, so it might have resulted in more inflammation because of staph. So that is my hypothesis. I think the staph sepsis was the primary diagnosis here.
Dr. Diaz, what about the inflammatory markers so high? Because we have never, ideally, we have never done in most of our septicemic conditions all these inflammatory markers. And even
yes, the thing is that I think we don't commonly do inflammatory markers in staph infections like IL-6 and even procalcitonin being done, but IL-6 and other inflammatory markers we are not doing. So I think we need to see what happens with the staph. We need to see the data, whether it doesn't reach, especially in children who show manifestations of vasculitis because of staph. So I think if the staph is causing vasculitis, the inflammatory markers could have also been raised. But as I said, that COVID definitely might have complicated the disease, and it might have caused more inflammation as compared to a child with isolated sepsis.
Okay, so you say it was staph right from the beginning, but how do we explain the improvement in symptoms for next 2 to 3 days after IVIG with the same antibiotics being continued? Even the lung shadows seem to improve and the inflammatory markers decreasing without any change in the antibiotics, and yet after 4th day there was a deterioration. So was it a staph nosocomial or staph right to start with, like you put it?
I think the labeling it as nosocomial will depend on after which day of hospitalization you could isolate the staph, as to define whether you could, it fits it into the definition of healthcare associated infections or not. Talking of response to the anti-inflammatory treatment, we must understand that all inflammations, whether it is because of infection associated inflammation or it is because of a non-infectious cause, they usually respond to seem to respond, don't respond, they seem to respond to anti-inflammatory therapy, like maybe even steroids, maybe IVIG or other treatments. So their fever may go down initially, their manifestations of inflammation may go down, but definitely without any concomitant control of infection, they again show up the symptoms. So it's like that even the CNS tuberculosis patients initially responding to decongestive therapy, and later on they manifest again with the TBM. So it's something like that. I think that it might have responded to inflammatory treatment transiently.
Anybody's guess whether to say MISCKD or staph sepsis, because earlier on in all these septicemic conditions, we have never done these inflammatory markers. And even if we have done it, but unfortunately, they were very high. So then after that, we made it an exercise to do it in dengue, do it in sepsis. We do find that the inflammatory markers are high, but not to the proportions which we were seeing in this particular patients whom we thought was a KD-like infections. You have already mentioned there is impact of most of the COVID. When we say MISC, it is most of them have antibody positive, but COVID RT-PCR negative. But the series which has been reported across the world for MISC, there were about 10 to 13% which also had RT-PCR positive. So therefore, it is very difficult to differentiate these two. The only thing we were wondering is if the child was already on MRSA cover from day one, showed an improvement after IVIG, which you think maybe because of the anti-inflammatory or a kind of an antibody blockage by the IVIG. We have seen so many staph empymas over the years, proven staph, they don't organize so rapidly so as to kind of become literally like a plastic bag which is encircling. And I'm sure you have also seen a lot of staph empymas, which never organized so rapidly, but did COVID influence this organization of the empyema which occurred so as to active intervention was required. So finally, a word on you on fibrinolysis, VATS or decortication. What is your take on, let's say, organizing staph empymas?
In empyema, the data usually vary a lot. Maybe in the probably it is because of the expertise. I think if you have the expertise of very good pediatric surgery backup, people who are very much trained in VATS and maybe decortication, then early most of the centers with very good support, pediatric surgical support and experienced people doing VATS, they have shown very good results. But unfortunately, what happens if you just refer them to a pediatric surgeon forcefully that do VATS, then the ultimate outcome is not good, and sometimes deaths also occur. So I would say that if you have expertise and if your pediatric surgeon is confident, and then I think you should just seek a pediatric surgery referral and go for VATS early. But most of the situations you don't have that expertise, you don't have that facilities, and children do quite well even without VATS and without decortication. Most of the children will do well, although it will lead to some prolonged morbidity. It will lead to need some long-term antibiotics, about 4 to 6 weeks of antibiotics followed by a lot of chest physiotherapy and exercises, but most of them recover without any complication. So I would say that when the answer is depends on what expertise you available. If you have confident pediatric surgeon, you go early.
My aim of showing this particular case was that I have evidence, COVID positive, I have evidence, staph MRSA, yet there were so many issues warranting intervention, rapidly organizing empyema, a kind of an intervening improvement period, multiple signs which would have gone either way, staph sepsis or a KD-like presentation and the typical age with a very high inflammatory markers and IL-6. So therefore, even when there is an evidence, I would still say the clinical sense, the individual patient care or bedside decision making becomes very important.
Agreed.
I have 7 minutes. I will just show one case and ask the Kaushal from this. Many a times we see in patients in clinic with some cellulitis which is not very angry looking, but next 24 48 hours it spreads so rapidly so as to make the limb almost a woody kind of a structure with a lot of induration, constitutional symptoms like pain and toxemia. So it is always there. It is said that suspect these are necrotizing soft tissue infections, which are not very common, but yet again not infrequently seen. And the two bugs which are important are strep pyogenes and staph aureus, which are notorious for these. So I'm just showing you a case, 14-year boy who was in fact admitted in a hospital with dengue, recovered from dengue, came back to us after 6 days of absolutely normal period, except for that thrombophlebitis, came with fever, respiratory distress, and multiple joints involved. So that we had a pneumonia right lung with empyema, with effusion, septic arthritis right hip, multiple angry looking thrombophlebitis, and sick looking child of a kind of a sepsis condition. We thought the patient was in hospital for treatment of dengue. We thought it was HA, health care associated MRSA, treated for ceftriaxone, fluoxetine, vancomycin covering both MSSA and MRSA. Investigation supported a pyogenic infection, and this shows the osteomyelitis, femur head, multiple kind of pus across the facial and the muscular planes, lungs going bad, and an empyema or effusion which was there in the right lung. All these pus cultures from various sites, two joints, blood, as well as an the pleural fluid, grew MSSA, erythromycin resistant but clindamycin sensitive, where we expected that the child probably would have an HAMRSA. And this is a child who was admitted to us 5 years back. Today is applied for Delhi police training and is about 18 plus now. So the question, 2 weeks of anti-staph treatment for a culture-proved MSSA with cloxacillin, vancomycin, and ceftriaxone, yet the patient did not respond. Any takes? Kaushal, your opinion, or Dheeraj, whosoever wants to be. Why? We have an evidence, MSSA, appropriate drug, appropriate use, appropriate supportive care, appropriate debridement. Yet the patient did not respond. Any explanation? Okay, we had no explanation. We used daptomycin. Clearly knowing daptomycin is not a very good drug for lungs. And the lung was also mainly involved in this. But the patient gradually improved. Overclocks, linezolid and dapto. 2 weeks later, we discharged. There were residual lesions, and I've shown you the picture, ready to join Delhi police, and the guidelines, which say daptomycin not very good for lung, and the treatment protocols, which are IDSA guidelines 2011, continuously updated, yet the patient not responding. So what do we make of the evidence? Any takes, any opinions?
Regarding daptomycin, I would just comment, because daptomycin, what happens is that it gets deactivated by the surfactant. So if that's the only concern, but if it is like because of a, say, pulmonary, it's because of seedings of, say, bacteria or microabscesses into the lung, and your patient had lots of other site infections also. So daptomycin definitely can be offered. So it should not be offered in patients who have primarily pneumonia, but if they have multiple sites infections and it's a disseminated infection, and lung infection is also, it's because of seeding rather than just isolated consolidation, then daptomycin can be used. But regarding why this patient did not respond and why the culture remained positive, very difficult to answer. Sometimes the culture what we get is only positive or negative. Sometimes getting the MIC also helps. So it is possible that although the culture showed sensitivity to the MIC to say methicillin or even vancomycin. Vancomycin, I think you didn't use it earlier.
So we used vanco.
Yeah. So it is possible that you might be dealing with a resistant organism and a vancomycin intermediate sensitive organism, and which was not like, even for methicillin, it was a sort of.
Dheeraj, I had 5 culture reports from different sites, similar sensitivity, similar antibiogram. So where was the room for doubt? So we only thought probably that was a guess in the wild that maybe a PVL producing staph, which is typical for MSSA. But still, even a PVL producing staph, could we have done better? We used Vanco, we used an MSSA drug, we used an MRSA drug. So still, the patients do not respond. And in spite of the fact the source control was very adequate, and I have shown you multiple sites of debridement in this child. The child made through, but I have no explanation why daptomycin, and we had no other choice also if you go by these guidelines. So these are the vagaries of bedside treatment, bedside decision making, because we may be full of protocols and guidelines, but I am sure the bugs and the diseases don't read these guidelines or the textbooks. So therefore, individual decision making on an individual patient always helps. And thank you, Dr. Nav. I am right in time with 40 seconds to spare.
Wonderful, sir. Thank you so much. You carried on very well. It was a very fruitful discussion we had. Thank you.
Thank you, sir. I also thank Dr. Dheeraj Sir, sir, and Dr. G.P. Kaushal, sir. And we also thank Dr. Kundu, sir. Now, moving on to the next topic, The next topic is COVID-19 pandemic, Letic Feluda after SARS-CoV-2. For this, I invite our chairpersons, Dr. Hema Mittal ma'am. Hema ma'am is assistant professor at RML Hospital with special area of interest in pediatric pulmonology, and Dr. Seema ma'am. Seema ma'am is senior consultant genetic and fetal diagnosis. She is consultant at Fortis Hospital and Rainbow Children Hospital, Delhi. I hand over session to Dr. Hema ma'am and to Dr. Seema ma'am to introduce our speaker, Dr. Debojyoti Chakrabarti. Dr. Hema ma'am, please.
Dr. Hema, are you there? Nirupma, you can introduce the speaker and we can start.
Dr. Debojyoti Chakrabarti is a senior scientist at CSRI Institute of Genomics and Integrative Biology, New Delhi. And he is also a faculty of Biology Sciences, Academy of Scientific and Innovative Research, assistant professor. Dr. Chakrabarti, sir.
Dr. Deb Jyoti
Chakrabarti. Hi. Good afternoon, everyone.
Good afternoon.
Am I audible?
Yeah.
Yes, sir.
Okay, so I can just quickly start. I think this is. So just let me know if you can see my screen.
Yes.
Yes, you are visible.
Okay, great. So thank you very much for this invitation. And I think I'm an outlier in one of your p-value graphs because I'm not a physician, not a medical doctor. I am coming from CSIR Institute of Genomics and Integrative Biology, where I'm working as a scientist. And I've been invited to share a little bit about our work in the field of genome editing and CRISPR-Cas9 technology, a little bit of work what we have been doing also during the COVID pandemic. So I'll just introduce a little bit on those lines. And in the long term also, because I think this the audience today is probably exclusively consisting of physicians and doctors, I would also introduce a little bit about what genome editing is and why it has got such an impact probably in the years to come. It is already there pretty much in a lot of countries, but what it can possibly do. So I think this is a good place to introduce. It's I think CRISPR has become kind of a household name now for different reasons. One of the major reasons is that the Nobel Prize in Chemistry this year actually went to two outstanding female scientists, Jennifer Doudna and Emmanuel Charpentier, for the development of a method for genome editing. So their landmark paper on CRISPR actually came in 2012, and they won a Nobel Prize in 2020. So that's 8 years, which the committee actually took to give a Nobel Prize. That's considered extremely rapid or fast in terms of getting this prize. Which also tells a little bit about the impact that this technology has on almost every field that you can think about. And to really say that the field of CRISPR has just two heroes, that's a little bit of a misnomer, because this was actually a kind of a Twitter picture that some user had shared after the Nobel Prize was announced. And it really shows that the field of CRISPR has been standing on the shoulders of giants who have been working on similar kind of technologies, or the entire basic principle of genome editing for the last 30 years or so. So it's a list of people who have actually contributed to this. And right on the top, on the horizontal row, you can see that there is a bacteriophage, which is a virus, There is Archie, and there is, of course, the bacteria's picture is written. So they are as well heroes, because before CRISPR came in, scientists had no clue at all about how the bacteria itself, or even archaea for that matter, have a type of immune system. So we were very happily thinking that humans are the smartest. Of course, now we know we are not, because a virus has completely shattered those ambitions. But the fact that a bacteria could have an entire immune system which is highly sophisticated was unknown. And this is what is shown here in this next slide, which I kind of borrowed from a talk from Jennifer Doudna, which shows that when a virus attacks a virus attacking a bacteria is called a bacteriophage. It generally puts its DNA inside the bacteria, and this DNA gets acquired in the bacterial genome, so that there are more virions that are made, and the virus replicates, and then it destroys the bacterial cell, and then it goes out. So, sometimes what bacteria do is that when they have a bacteriophage or a virus which attacks it takes a small piece of this viral DNA, and it introduces its own DNA in a kind of almost like a librarian who kind of catalogs every incoming book that comes to the library. So it kind of tells the bacteria that, okay, look, a bacteriophage A or a virus A had previously come inside, and it had attacked you. And what happens is that the next time the same virus comes in and it tries to attack the same bacteria, this bacteria takes information from that previous DNA that it had stored. It quickly complexes a very interesting complex of protein and RNAs, which is called the CRISPR proteins. And then it goes and attacks the incoming bacteriophage once again. And now, using the information that this that it had, that I am now getting another attack of the same bacteria, same virus that had previously come, it destroys that DNA of that incoming bacteriophage. So highly sophisticated kind of immune system, almost similar to the type of immunity that we develop against pathogenic organisms, is also present in bacteria. And this was a landmark kind of discovery. Nobody expected that bacteria would have such kind of a system to evade foreign organisms. Now, the important thing over here is that if you look at the lower part, here we are talking about a protein and an RNA, which is going and specifically chopping off a DNA of a virus. And this is the fact which was taken from the prokaryotic cell and adapted in case of human cells. And that's where the applications in human cells actually come out. In the field of genome editing. So I'll come back to what I showed before, but just maybe a stop here and try to understand what genome editing actually means. So genome editing principally involves there are three steps of genome editing that you can consider as the basic blueprint. So if you want to make a heritable change in the DNA, and mind you, this was also often for a long period of time thought impossible, that we are a product of our own genes. We come with a set of alphabet, whatever billions of alphabet, which is present in the DNA. And then we have no way to change this, and whatever we are born with, we go ahead with it. But it seems that there is a possibility of doing changes, and hence I had written rewriting the code of life. But making such a change has basically three processes. Number one, you need to home into that part of DNA that you want to make a change. You need to add a modification there, and then you want to save that information. So if you imagine, it's like a typewriter, and you have to, or a typewriter is probably a bit old. You can think of it as a word processing file, a doc file, or a MS Word file, and you have written a letter, and somewhere along that letter you have, instead of writing THE, you have written AHE, and you need to correct that. So what you would do is you would take your cursor up there to that same word, you press a backspace, you delete the A and introduce a T, and then you save the file. So imagine if you had to do this thing in your DNA, you would first need to take something out into the DNA exactly where that mutation for a disease is, break open the DNA, cut out that base or an alphabet, and then add a new base. And because the DNA is replicating, there is a cell which produces daughter cells and progeny cells, then the information is heritably passed on to the next cell. This is what CRISPR-Cas9 allows us to do. However, the questions are actually, more in terms of where do you want to do this? Are you thinking about doing this in cells, from the body? You take it out and remove and correct it and give it back. Are you thinking about doing it in the germline, in the ovum or the sperm, so then the next generation can get affected? Or are you actually doing embryonic genome editing, where the baby who is going to be born would actually have editing in the DNA? How you want to do this? Is it outside the body? Is it inside the body? In outside the body here means that you take cells outside the body and then return them. And of course, the most important question is, why are you doing these changes? Are you thinking of actually correcting a disease? That's a very valid reason to do such a experiment. Are you trying to prevent a disease? That's what the Chinese scientists had done in terms of genome editing, preventing AIDS. But then in the process of preventing something from happening, you can actually make it, amenable to something else, which are the questions. And the last two things, improvement and design, are the really, really problematic areas. Are we trying to improve the human race, or are we trying to make designer, organisms, say, let's say, who would have higher IQ, for example, or let's say who would have lost the sense of pain, and almost sounding like science fiction, but in reality this is all practically possible. And I'll tell you how this is done. So to understand that, this is the basic blueprint of how CRISPR works. What you see here in golden is a Cas9 protein, or a Cas protein, which is the fundamental building block of CRISPR technology. And this Cas protein can be directed with an RNA molecule, which is shown in blue, to go and specifically interact with a double-stranded DNA of your choice. And you can very specifically tell this protein using 20 bases or 20 nucleotides that this is the region, or this is the part of DNA that I want my Cas protein to go and interact with. Once it does that, it goes and binds to DNA using base pairing with the RNA guide. It breaks the DNA, or a double-stranded break happens. And when the double-stranded break happens, then the cell automatically tries to repair this break. And how it tries to repair it is either doing a quick and dirty job, where it tries to bring the two chromosomes together, broken parts, and tries to repair it. Alternately, if there is a very tiny piece of DNA which has got some amount of similarity with that site where the break had happened, then this tiny piece of DNA can be integrated. Now, this is really the interesting part. This tiny piece of DNA can actually be integrated to replace a disease-causing mutation. Say, for example, if you have a BRCA1 mutation, or if you have a mutation in a gene which causes peptic ulcer, let's say, you want to replace it, then what you have to provide is a very tiny piece of what is called as a donor DNA, which can then integrate it into that site. Now, it's all easier said than done, because in order to have these things happening, you would need to have number one, the Cas9 protein present, the break to happen, the homology repair pathway proteins to be expressed, the donor DNA to be present exactly at the same time, and everything happening in a way such that the Cas only specifically and very specifically goes to BRCA1 if you want to correct BRCA1. Now, imagine all this hinges upon the fact that we are relying on this protein to specifically go to the BRCA1 site. If, due to some error, which could be due to some mismatches or some kind of changes in that RNA sequence, it goes, let's say, to the p53 site, you can imagine what havoc it will have, because it's going to cut there. So specificity is probably a big issue in terms of gene editing trials. And yet we are at a stage here where the first trials have already begun. And this is from last year, where the doctors gave Victoria Gray, who was an American lady, the first genome editing shot for sickle cell anemia. And this year itself, the patient has actually shown no symptoms of the disease yet, and is doing pretty well. Of course, that's very early still, but this was one of the first trials in the US to actually use genome editing to alter the DNA of some of a patient. And it shows that it's so far it has been pretty safely accepted. However, these things require much longer periods of follow-up and to understand what happens. So we talked about sickle cell here. One of the reasons is that sickle cell is a blood disorder, which means that if you can correct something in the hematopoietic stem cells, you have a pretty high chance that such kind of changes would be passed on to almost every blood cell that comes, because they are the sources of other cells. And unfortunately, sickle cell is of course not a disease of the US. It is a very, very strong Indian presence. And in fact, if you look here, the countries which are the most red in terms of sickle cell carrier population, India stands pretty high. And when we started working this, I started working this in 2017 as a part of something called a CSI sickle cell anemia mission under the aegis of this is a Prime Minister's Office Control Project. We were actually looking at the possibility of using CRISPR-Cas9 to correct the sickle cell anemia in Indian patient-derived stem cells. It's a point mutation in the beta globin chain which causes the glutamic acid to get changed into valine, A to T change, and the idea was that can we replace that, back from T to A, and we wanted to use CRISPR-Cas9 for this kind of work. And to cut a long story short, what we did was actually we identified an orthogonal protein from a different bacteria than what is being used for trials and for all possible practical purposes. And this Cas protein from a bacteria called Francisella novicida had certain interesting properties which made it a very, very how to say attractive option for doing genome editing. One of these properties that it had is that it has a very, very strong off-target sensing mechanism, that it is very able, quickly and very efficiently able to distinguish between what is a target versus an off-target. And not only that, we could also make sure that it can correct the DNA. And as a proof of principle, we took an Indian patient, we converted the blood cells into induced pluripotent stem cells, iPSCs, and then we corrected the sickle cell anemia mutation using FN-Cas9. And I mean, this was more of an academic exercise, because you can always correct cells in the lab. It doesn't really say much about how you can really take it for therapy, because such kind of experiments or such kind of things to go into trials can often take several years, to say the least. And yet at that same point of time, I always present this study that came in New England Journal of Medicine, which showed that in this case a particular boy who was given a dosing of a customized oligonucleotide therapy was diagnosed in late 2016, and within a year almost all the clinical, preclinical trials and safety and toxicity studies were done. Customized oligonucleotides were made and then delivered in an N of 1 trial, and that gave us a lot of hope. There was a lot of support from there is still a lot of support from different sources and the government as well. So what we figured out that if we had to push for such a kind of clinical translation of genome editing at some point, what we would need is that we would need appropriate vectors which could be used to deliver these CRISPR complexes inside patient cells. We would of course need a higher efficiency and safe variant, because we were looking at a wild type Cas protein from bacteria, so we needed to engineer it in a way. And of course, in order to convince the regulators, we would need very robust preclinical data to make sure that it can go to the next step. So of course all these things cannot be done by us at where we are working at AGIB. So we forged very important collaborations here with Osamu Nureki at the University of Tokyo. We started engineering the CRISPR complex of the Cas protein to make it more efficient. He's one of the pioneers of solving the structure of CRISPR-Cas9. With Mark Walters and David Martin at UC, who actually did the first clinical trials for beta thalassemia using CRISPR, we started doing looking at models for preclinical data. With Anand Swarup at National Eye Institute, NIH, we started making adeno-associated vectors. And what I have not shown over here is with Andre Lieber at University of Washington, Seattle. We started making adenovector delivery vectors where we can actually complex this Cas protein. So I will show you very little data. These are all under IP, so I will not show you the details, but effectively we have been able to engineer this Cas protein into much higher efficiency variants, which can now, these are all done using very, very hardcore protein engineering to make this amenable to much more wider targeting and efficiency. So I would, just shift a little bit focus and tell you a little story about how all this led to what has been, I think, this has received, I mean, it has received a lot of media attention now, more as a distraction than anything else. But yeah, so this actually is the backbone of what we call as Feluda, which is a Fincastlin editor linked uniform detection assay. This is something that came out of a lab work done with Dr. Shovik Maiti. I put this thing that came last month actually. Dr. Shomita Chatterjee passed away in Calcutta. He was the original fellow that is, there's years of service to Indian to films, and one of the things that was very coincidental is that this was also the year that we came up with this test for COVID-19, and we decided to call it Feluda. So why Feluda? I think if there are Bengalis in the group, they would probably know that he's a main character of Satyajit Ray novels. He's an Indian detective, and the reason we gave it that name was because CRISPR diagnostics is something that MIT and University of California, Berkeley have actually popularized with their techniques, which are called Sherlock and Detector. And Chinese people have come with something called Holmes. So when we decided to work on something very, very similar in terms of application, we wanted to give it a name which was very, very desi, if you might call it. And we had two Bengalis in the group, so that's immediately became the first name of choice. So I mean, I would go into details of how we came up with it, but just suffice to understand that here we are using a CRISPR complex, which includes a bacterial protein that is highly specific in binding to a piece of DNA, which is different by one mismatch from another DNA. So and that's a specialty of this enzyme, this FN-Cas9 enzyme, is that if you tell that you have to specifically go and interact with COVID-19 DNA, let's say SARS-CoV-2, and even if it has 19 bases of similarity with SARS-CoV-1 and one base of mismatch, this Cas9 protein can actually distinguish between them. That's the high specificity of the protein. So what we were working on earlier was that how we could use this Cas protein as a point of care diagnostics for all the possible genetic disorders that we have. And you can pick up the genetic disorder because it doesn't matter which is the DNA or the RNA mutation. It for us, it is only about changing how this Cas protein is going to bind to it, and it's a very simple design. So we figured that out, and that it can do that very efficiently, and it could be a point of care genotyping, which would otherwise take 20,000 rupees for sequencing, or sending it to the local the nearest sequencing lab, which would be several thousand kilometers away sometimes. If we could make all this happen on the field, it could be in the form of a gel, it could be in the form of a fluorescence, or as I will show you, this can also be done as a lateral flow in the form of a paper strip. And at the beginning of the pandemic, we were actually in Raipur testing this out in a village where sickle cell anemia is generally tested using a very crude solubility test, where you look at the solubility of the blood. What we saw was that this was a tertiary care healthcare center in a village, and you can see the children are lined up waiting for their blood to be taken. And if you look at this young kid who looks with not so much eagerness to have her finger pricked, she doesn't have shoes on as well. We understood that this, and of course this kind of a solubility test is a very crude test. It doesn't tell us about, let's say, whether it's a carrier of the mutation. Is it having 50% of the alleles mutated? Is it a real trait, or so on? So we came up with the idea that we could actually ask the kids to simply, spit into a small tube, and using molecular biology 101 techniques, have a buffer that lyses the cells, releases the DNA, and Feluda can be done within 30 minutes and tells you whether you have that mutation or not. It is not limited to sickle cell anemia. It can do it with any kind of mutation that one can think of, and effectively can be adapted almost to point of care settings. So this was where we were, like I said, at the beginning of the pandemic, and of course then COVID-19 struck, and so we realized that you could very nicely adapt this for COVID-19 detection if we could find a way by which we can do this in a even more simplified form in a paper strip. So to cut this whole thing short, what it works with is that if you have the swab taken, or the it can be done from saliva as well, and the RNA extracted, you can actually put a single reaction where we do something called an RT-PCR, not to be confused with real-time PCR, which is being done for COVID test gold standard, but rather reverse transcription PCR, in which you have the RNA is converted to DNA and tagged with specific type of primers, which are biotin labeled. And then in a single step, we are actually combining the paper strip chemistry and the CRISPR biology to give a readout on a paper strip. This happens pretty fast, less than an hour to do. It's economical because it doesn't require a qPCR machine, quantitative real-time PCR machine, where the capex is almost close to 20 lakhs, plus minus 15. It can be done in a normal PCR machine, and as I will show you, it doesn't even require a PCR machine in the new versions. Of course, it's it has very highly specific because of the specificity of the protein coming in. So I won't go into details how we designed all this chemistry and biology, but just to understand that it involves a little bit of gold nanoparticle binding to Cas complex, and then streptavidin and biotin interaction, and the final readout comes up like this. So you have a positive sample which will have two bands. One is the control band and the test band. The test band basically tells you that a sample is positive. Control band comes up in every assay, so which basically tells that the assay has worked fine, and the negative controls and the samples do not have these bands. And if again, just for the benefit of the Bengalis, Feluda is never alone. He's in the stories there is a cousin who is called Topshe, and there is also his friend called Jatayu, who writes the novels, Feluda, the stories about their exploits. So we also developed with the Chennai-based startup Eduvo a smartphone app which can simply take a picture of the strip, and it has been machine language trained over hundreds and hundreds of samples to actually tell you whether you have a positive or a negative signal. It's highly sensitive, goes down to a few copies of the viral RNA, and the Jatayu is kind of a junction for the target design analysis and target design for your Feluda assay. Allows you to put in any nucleotide sequence that you want, and you can get a Feluda design for that. It could be not just, for example, I can already tell you we have done this very very nicely with Dr. Govind Makhari at AIIMS, where we were looking at Helicobacter pylori samples which are rifampicin resistance, which have a single point mutation. Normally, if you would do this, and I was hearing some talks earlier about Staphylococcus aureus infections. Normally, for such kind of things, it would take about 3 days to culture them and then get the antibiotic resistance status. With Feluda at the OPD, you can do all this within an hour. And like I said, that we have more advanced versions where we do not need the PCR machine at all, using a technology called isothermal PCR, or isothermal polymerase chain reaction, where everything happens at a single temperature. You can use a simple heating block or a dry bath to do this test.
Debajyoti ji,
So like I
last 2
said,
minutes.
that this was, yeah, I'm done. This is the last one. So this received the ICMR approval, DCJ approval rather. So this was licensed to Tata Sons, and then they actually started a new company called Tata Medical and Diagnostics, and they have got the approval for being replacing the RT-PCR. So that was a big thing, because it basically means that if you do the Feluda test, which they call as Tata MD check, you would not require to do an RT-PCR test in itself. And it's also one, if not the first one, but one of the world's first paper strip based COVID-19 detection, CRISPR based detection. And this is just to tell you, it all went from an idea on 28th of January when we, started working on it, which was even before the first case was reported in India, to the final approval. And this is just to tell you how it works. Within 2 minutes, you have the movement from the tube, which contains the CRISPR complex and the PCR product. And then first the control band develops, and then later on you can actually see the test band developing in a positive sample. So yeah, I think that's the last slide. So there's a lot of people to thank. You can see them all here. There's a big lab which works on this, very generously funded by a lot of different funding agencies. And of course now Tata MD is working with us to make this even better, more. The idea is to make COVID testing if possible, closer to home. So that's the second prototype that we are working on in terms of, return to schools, return to colleges, in airports, and so on, where you would not need to go and give your samples, let's say, or somebody has to come and take your samples and do it RT-PCR test in a lab. What about bringing this all at, the local dispensary or the local doctor's dispensary, or even at home? So that's where we are currently focused on, and we'll see what we can do. Thank you very much.
Thank you.
Thank you very much, Dr. Devajyoti, for accepting this invitation. And I can say we are not Bengali, but we are fond of Feluda.
Feluda.
We all know Feluda, and it was a really wonderful lecture. Please, Chairperson, please carry on.
Can I ask a question, Smita?
Oh, why not, sir?
Devajyoti, 2 months of licensing of this product. What about the field operations? How do you compare it with RT-PCR for COVID? You said good sensitivity and specificity, but in field operations, with whatever trials you have done, how does it relate with our RT-PCR, which is a gold standard, yet 70% only sensitivity?
So that was one of the reasons why we had actually all the time that it took for in terms of regulatory going through the entire regulatory process, is because what we consider as a gold standard is not even close to bronze standard. And the reason for that is that RT-PCR is a technology, but there are probably 100 RT-PCR kits which are available in the market, some made in India, some made in the US, and all of them differ in their sensitivities anywhere ranging from 50% to 90%. So on the day of your evaluation, if you are just unlucky to be doing this with a kit which is subpar, then you can imagine how these numbers can be screwed up. So we had to really, and we figured that out, because the possibility of doing whole genome sequencing and whole sequencing in IGIV made sure that each and every sample that came to us, we actually sequenced it. So even if an RT-PCR missed it, we would get sequencing reads for the virus. And we saw that, that told us that, even a RT-PCR positive sample or a RT-PCR negative sample, if you do it 5 times, you might get it positive at some point. Just if you simply change it to a better kit or whatever. Anyway, we won't go into details. I can only tell you about the DCGI trial kind of evaluation. When they did this, that was that they came up with a figure of 96% sensitivity and 98% specificity. So that was the values that they got. In our hands in the lab, we have reached 98% sensitivity, 100% specificity. So it hovers around that. I mean, in the end, as all of you know, that these numbers are all relative. They don't mean anything if it is above a particular threshold, because it can be one day 99, it can be 96 on another day. So it really doesn't mean much in terms of absolute numbers. But we had a very good learning experience when we compared these with RT-PCRs, and we still are. So we are continuously doing R&D on this to understand how variations appear, and we are very surprised to see some of the variations with approved RT-PCR kits.
I don't understand.
Welcome, Bakul Parikh, sir.
Just
And Seema, Dr. Seema, if you want to ask anything.
Yes. So, no, I would just like to add some comments that, these molecular scissors, they are, they are very thrilling in the field of medical genetics or in the genetics, that, they are already being used for the therapeutic.
You're
Ma'am,
muted.
please unmute.
Mute yourself.
Seema, ma'am, please unmute yourself.
Very much cost effective. And, this is going to change the way we are doing the genetic testing for the inherited genetic disorder, and of course for the infectious diseases. So
yeah, I might just add here one bit that we are a research lab, so we are not the ones who actually makes the kit and produces it and then does the commercial whatever it is. So to be very honest, we are ourselves we are getting all the information from the media regarding the launch and when what is the cost and so on. So I am also still not yet sure what is the model in which Tata wants to take this ahead. I was told that they have already started this in Hyderabad this week with Apollo Hospitals, and I'm still waiting for things that are going to happen in Delhi, which is also happening this week, is what I was told. But yes, I can tell you this much, that it requires a tremendous effort also on the part of the commercial person, because it's a new test. Whenever a new technology has to be barcoded in terms of, or let's say compared with existing technologies, you need so many decisions to be taken at the level of policy making, because it's a CRISPR test which has never come across before. And in fact, if you look at the US as well, they are giving emergency usage authorizations, FDA. They are not actually giving approval completely. So it's an EUA for COVID-19. So a lot of different things, which I think the Tata MD guys are probably looking at it. We are really focused on getting a second version of this out, which would be allowing it to make it even more closer to home. That's where we are focused on.
Chakravarti, only one word to describe your talk, and your topic was excellent. That's all.
Thank you, sir.
Thank you. Thank you. Yes.
Our aim of bringing you here was to hear from the source. The Firuza has come. That was the basic aim. We wanted to bring this conference.
I think Dr. Chitkara had one question. We just cut him short. Probably if he could complete that.
Sir, please come back with the question.
Figures of 96% and 98% against a reference standard of what?
Of an RT-PCR.
Of an RT-PCR, which itself is 70%.
Yeah, so you can understand it will be a floating error anywhere. So that's why you have a kind of, it's never going to be an accurate. So the error in biology, it would be a kind of your thresholds will keep on moving. So if you imagine on the day in which an RT-PCR of 70% sensitivity was used, your error would be very high. If on a day when you would have an RT-PCR sensitivity of 100%, close to 100%, then your error will be low. So if to be very honest, we are trying to use sequencing more and more to be used as a reference, but unfortunately, probably our regulatory authorities would not be able to do that, because that's expensive and that's also difficult to do.
But error is 20% to 30%. That means depending upon the sensitivity of the RT-PCR. So therefore, isn't it a false claim of 96% and 98% when there is such a wide error limit?
So how do you define the error then?
No, I would say then you should restrict your sensitivity and specificity to somewhere about 60 to 70%, as good as RT-PCR.
But
so
then probably you would have to do this test with 50, 60 different types of RT-PCR kits, and then plot them across a kind of a curve, Kaplan-Meier curve, and try to see where your things appear. If our regulatory agencies are okay to do that, and if they are happy to do that, I would be more than happy to participate in such kind of.
Dr. Chakravarti, very good, very fantastic talk. I think you raised the bar of the conference. And I wanted to ask one question: how your test compares with the Sherlock test of US?
So the Sherlock test of the US, I think the commercially available Sherlock one, which is FDA EUA, is actually a fluorescence-based test. So they haven't yet released a version which is paper strip test. I think it would be similar, because they have only released academic data from different experiments, which compares pretty much similar. So around 97-98% sensitivity. So that would probably mean that they are in the same range. Yeah.
So I would just
They use some other Cas 9. They use some other.
Oh yes. Oh, so yeah. So the Sherlock and the detector technology use a different Cas system, which is Cas 12 and Cas 13, and they also have a different mode of reporter cleavage based chemistry, which is basically a post cleavage reporter signal. In the case of Feluda, we are trying to detect the direct binding. So it's a stoichiometric binding of a Cas protein with the target.
Mm-hmm. It seems that the specificity sensitivity is around 95 to 94% of 70% of RT-PCR.
Well, what here when you are reporting a sensitivity specificity, the best.
I'm really sorry, sir. Due to time constraint, we'll have to move to the next session. Please, sir. It's already 15 minutes late. I'm really very sorry, sir.
No problem. Thank you so much. Discussion with the sensitivity specificity questions later on.
Thank you very much, sir. Thank you, Seema ma'am.
I request Mr. Chakravarti to please, in the chat box, you may answer the questions. Please.
Thank you very much, sir. Thank you.
After this excellent discussion and excellent topic, I will proceed to the next topic. The topic is male gynecomastia, the diagnostic approach. For this, I invite Dr. Rakesh Dogra sir, who is a senior specialist in charge pediatric asthma and child clinic and bronchoscopy center at Hindurao Hospital and NDMC Medical College. The second panelist will be Dr. Hema Gupta, who is a senior specialist and assistant professor at RML Hospital, and Dr. T.R. Dangwal sir. Dr. Dangwal sir is a practicing pediatrician consultant at Max Patpatganj. He was a vice president Pediatric Respiratory Society, and he was also the past president IAP East Delhi. I invite all the chairpersons to introduce our speaker for the session, Dr. Vaishaki Rostegi ma'am.
I'll take a minute. I welcome Dr. Bakul Parekh and Dr. Baswaraj, who are there in the panel now. Thank you for joining us.
Thank you, sir. Thank you, now, sir.
Thank you. Yeah, please continue, Dr. Vaishaki.
Chairperson, please take over. Yeah.
The share
Chairperson. Dr. Hema, please continue.
I'd like to welcome Dr. Vaishaki, who's a senior pediatric endocrinologist at Max Hospital, Shalimar Bagh. So I would like her to please take over the session on this important topic of male gynecomastia. Dr. Vaishaki, please continue.
Thank you so much. I'll just share the screen.
Can you please make it full screen? Yeah.
Yes. Okay, thank you everybody for giving me the opportunity today to speak on this topic. So I'm going to mainly take gynecomastia, what are the diagnostic approaches, and when do we need to get alert regarding male gynecomastia. So first of all, before going into the details, first we must know that what is not gynecomastia. So breast enlargement in a girl child is not called as gynecomastia, and pseudo-gynecomastia is a terminology which is used for fat accumulation in the breast of boys as well as girls. This is called as adipomastia. So again, this is not gynecomastia. What is gynecomastia? So gynecomastia is when there is a palpable fibroglandular mass of at least 0.5 centimeters beneath the nipple and the areolar region, and it is also rubbery in consistency. Then it is called as gynecomastia. Now, what is the pathogenesis of gynecomastia is one, what are the reasons? So one is a high prolactin. A high prolactin level can cause gynecomastia with milk secretion from the nipples. And this is seen when, because the prolactin levels suppress the LH at the pituitary level, and they suppress the production of testosterone at the testes. Then there can be a low androgen condition where the testosterone levels are low because of any type of hypogonadism, which could be a hypergonadotropic hypogonadism, or it could be a hypogonadotropic hypogonadism. At the same time, if the estrogen levels are high, then there is a ductular hyperplasia which causes gynecomastia. So basically in gynecomastia, the ducts, they proliferate, but the lobules, they do not proliferate. So the proliferation of ducts causes the painful gynecomastia, and they are governed by the hormones like the estrogen and the testosterone. Excess thyroid hormone can also cause gynecomastia by increasing the sex hormone binding globulin and increasing the estrogen to testosterone ratio. And progesterone and prolactin together both cause tubulo-alveolar unit development, and thereby they cause gynecomastia. So if the progesterone levels are high and the prolactin levels are high, then they also cause gynecomastia. Now, just to show you all a case, this is a boy A who came with gynecomastia at 14 years, and he was evaluated by the doctor and reassured. And then after a few years, things worsened and he was diagnosed to have a testicular tumor. There was boy B at the same age who came with gynecomastia, again investigated, reassured, and this boy gynecomastia disappeared. So basically, gynecomastia could present in all situations very similarly. Means gynecomastia per se cannot be used to differentiate that which type of gynecomastia is because of what reason, but we need to figure out from the other parameters that what is the cause of that gynecomastia and whether that's an alarm or no. So this boy with a testicular tumor or the boy who just had a pubertal gynecomastia, they both presented at the same age with a similar type of a gynecomastia. So gynecomastia in physiological and pathological causes are similar. So this is one message that we need to take home, that both the causes of gynecomastia, they look similar. So there is no way by just examining the gynecomastia that you can say what is the reason for the gynecomastia. Now, how do you first check for gynecomastia? So the patient has to lie supine, then the hands have to be locked behind the back of the head. The examiner has to test the opposite breast of the child. So the opposite side with the thumb and the forefinger, and he has to press the glandular tissue below the nipple. So from the sides, he has to come towards the center, and just below the nipple and below the areola will you feel the glandular rubbery feeling of gynecomastia. True gynecomastia, it is like a ridge which is more than 0.5 centimeters and it is symmetrical and below the nipple and the areola. So anywhere else in the breast tissue, if you are able to feel any mass, that is not called gynecomastia. It has to be below the nipple and the areola. Now, this boy A had a, so when you do the genital examination, which is an important examination finding that you have to always do in a case of gynecomastia. So we found that in boy A, there was a unilateral testicular enlargement. However, boy B, he was in Tanner stage 2 pubic hair and his testicular volume was 4 ml. So basically, genital examination is extremely important in a case of gynecomastia. And what are the genital findings that you need to look for? So what are you looking for in the genitals? One is a hypoplastic genitalia, any genital ambiguity, any asymmetry. So asymmetry will take you towards any testicular tumors or masses. So all these are pathological causes of gynecomastia. The second information that we always need to take in a case of gynecomastia is you have to take the auxological criteria. So when you put these children on growth chart, you will find that this boy, who was the case of a testicular tumor, was very tall. He was on the 97th centile. However, the pubertal gynecomastia boy was on the 25th centile. Okay, and also if you check their weights, you will find that the boy who had a testicular tumor was on the 25th centile on weight, but the boy with a pubertal gynecomastia was on the obesity side. So he had a higher weight. So growth charts give you vital clues to the etiology of gynecomastia. So number one is gynecomastia can look similar in any of the pathological as well as physiological conditions. Second is genital examination is important before determining the cause of gynecomastia. Third is growth charts give you important clues for types of gynecomastia. Then this boy with a testicular tumor and the boy with the pubertal gynecomastia, what was it that we missed and what was it that you always ask on a history? So what you ask the parents is, what is the onset duration of the gynecomastia? Is there any discharge from the nipples, which gives you a clue towards prolactinoma? Is it unilateral or it's bilateral? Okay. Is it associated with pain and is it rapidly enlarging? In etiology, you have to ask for any drug intake, any cream application, so estrogen creams, and sometimes these herbal creams contain estrogen. So if the baby is in contact with these herbal creams from the mother, even then they can get gynecomastia, because estrogen is a fat soluble, it's a hormone which can be absorbed from the skin. Then any systemic diseases like chronic kidney disease, chronic liver disease, any family history of gynecomastia. So if the father, uncle has gynecomastia, it is autosomal dominant. So aromatase excess can cause gynecomastia in the boys of the disorders of sexual development. Any behavioral problems will give you a clue towards cluster Klinefelter syndrome, and the pubertal process. So if he has not achieved any sign of puberty till 14, 15, 16, and he comes to you with gynecomastia, then it could probably be hypogonadism that is causing the gynecomastia. Now, what are the subtle clues that we missed, that we should not miss? One is the red flag sign. So the red flag signs are if there is any abdominal mass, if there is thyromegaly, which means if there is hyperthyroidism and there is a goiter, if there are signs of chronic liver or kidney disease, if there is a nipple discharge on fundus examination, if you find signs of any raised ICT, which will give you a clue towards a prolactinoma, and if there is anosmia, which moves towards Kallmann syndrome and hypogonadism. The red flag signs in the genitalia, as I told you, there could be a genital ambiguity, it could be cryptorchidism, testicular swelling, asymmetry of the genitalia, and hypogonadism. So presence, and another thing is if there is any presence of overlying skin fixation or there are local lymph nodes, then you have to rule out a malignancy aggressively. So we should never miss these red flag signs in history and physical examination. Now, the causes of gynecomastia, common causes are generally, it could be idiopathic or it could be a genuine endocrinopathy. In pubertal gynecomastia, the commonest cause is puberty gynecomastia, or it is a hypogonadism, which is an endocrinopathy, which is causing gynecomastia. Common to both the groups, that is prepubertal as well as pubertal, are drugs and systemic disease. And obviously, we never need to forget the tumors causing gynecomastia. So now something about pubertal gynecomastia, that it is seen in early puberty up to 70%. Generally, it peaks at about 14 years, and Tanner stage 3 is when it is seen with a testicular volume of 8 to 10 ml. There is tenderness, not always though, but there could be tenderness because when it is active, it is the nerve endings are sensitive. There could be psychological distress with pubertal gynecomastia, and it resolves within a few months. This is generally because of the increased insulin-like growth factor and the deranged estrogen to testosterone ratio. So the systemic diseases do what? They generally cause the functional axis suppression of the hypothalamo-pituitary gonadal axis, and thereby they alter the estrogen-testosterone ratio. As in pubertal gynecomastia, I told you that it is generally the high IGF-1 and the high estrogen to testosterone ratio. And in obesity, so you will find that many obese children also have gynecomastia. So that is because of the high aromatase which is present in the lipid cells. So these convert the testosterone and the androstenedione into estrogen. And since the breast tissue of a boy and a girl are the same, if you give them estrogen, even a boy's breast will become like a girl. So that is the reason that in fatty children, they have gynecomastia because of the high aromatase activity. Now, pathological gynecomastias are generally monogenic causes, which I told you, autosomal dominant aromatase excess. There could be exogenous agents like a lot of drugs that cause gynecomastia. Endocrinopathy is related to sex hormone axis. So it could be either, as I told you, hypergonadotropic hypogonadism or hypogonadotropic hypogonadism. Endocrinopathy unrelated to both of them can cause gynecomastia. And systemic diseases are the reason for pathological gynecomastia. Now, the abnormal testosterone levels are seen in hypogonadism, androgen insensitivity syndrome, 17-alpha hydroxylase, and 3-beta-HSD deficiency. High estradiol causing gynecomastia are generally beta-HCG producing tumors from the Sertoli cells, aromatase excess, and over-testicular DSDs. High prolactin can cause gynecomastia, and thyrotoxicosis can also cause a pathological gynecomastia. So any tumor could be either a testicular tumor or an tumor could be an adrenal tumor or a testicular tumor. So adrenal tumor could directly produce estrogen. Testicular tumor, Sertoli cells will produce estrogen. Leydig cells will produce the aromatase, and germ cells would make HCG, which make estrogen from the testes. So this is how tumors can cause gynecomastia. Now, you would be working up depending on the individual case. Especially prepubertal cases, you will always work up, and pubertal cases with red flag signs, you need to work up. When do we treat? So you will treat in a pubertal and idiopathic cause. You will observe if it is not getting resolved and there are psychological issues, pain can be given to long-standing gynecomastia. After 24 months, it's not getting resolved with medical treatment. If it is large in size, more than 4 centimeters, and if there is no response to medical treatment after stage 4, it is unlikely to disappear. The pathological causes, you always treat the underlying etiology, obesity, tumors, you do a surgical referral, sex hormone replacement for hypogonadism, and if it's a drug-causing gynecomastia, you will withdraw the drug. So with this, the 3-4 take-home messages is, in a case of gynecomastia, always plot the child on the growth chart, do a Tanner staging examination. If it's a prepubertal child, you have to aggressively evaluate and always look at the genitalia for these pathological conditions. And hormonal test would be the last to confirm your diagnosis. With this, I think I come to an end of my session. Thank you.
Thank you, ma'am.
Can I give some comments?
Yes, ma'am.
It was wonderful presentation by Vaishakhi. That's why she's smiling. It is very crystal clear and very much
Thank you, ma'am.
for
Thank
the pediatrician how to address. I just wanted to add one or two things. She has very much highlighted the fact that there is lipomastia in the boys when they are obese. So that is not to be taken as gynecomastia. So that is one key message. The other is that the adolescent age group, one must take history of drug history, because marijuana and all also lead to breast development. And especially if there is any history of delayed puberty, one must take, because Klinefelter also presents with gynecomastia. So maybe I'm repeating the message. So, and if there is a testicular tumor, which she was highlighting, again, one has to take it with a pinch of salt, because if there is so much of testosterone, they are not likely to develop gynecomastia. They only develop gynecomastia because of the pathology, because of the generally why the pubertal gynecomastia is there, because of the daytime aromatization of their testosterone. That is why, which gets converted into estrogen. That's why it happens. So once there is a testicular tumor, there is large amount of testosterone, less likely to happen. So that was the other thing from the clinical experience. And this is what I wanted to add. So testicular tumors are rare and very rare. In my 30 years of practice, I have actually not come across, even though I've been running the endo clinic, and I really appreciate the fact that you have also done your fellowship at CHOP.
Yes, ma'am.
Exactly. That's what I wanted to say. I noticed that.
Dr. Vaishakhi, we have one question in the chat box. If you could like to answer that. What is the incidence of pathological gynecomastia in Indian boys?
So, frankly speaking, I have been practicing endocrinology since 12 years, but I haven't seen a single case of pathological gynecomastia. Per se, the patient has never come to me with gynecomastia as a primary complaint. So mostly I only see pubertal gynecomastia, and pathological gynecomastia I've only seen in 2 or 3 Klinefelter cases that have come to me, and hypogonadism. But tumors I have yet to see.
And DSD.
I haven't seen any tumors up
and
till
in
now.
DSD also.
And DSD. So hypogonadism. Basically, any hypogonadism is the one where I've seen them.
Present as gynecomastia type thing later on.
But still, they haven't come with gynecomastia as a primary complaint. That's what we found on examination. but they came with delayed puberty as a primary complaint, and gynecomastia was a examination finding that we picked up.
Good.
So I
Thank
think
you very much.
I hope that answers my. Thank you.
Thank you. Thank you, Vaishakhi ma'am. Now we move on to the next session.
Thank you.
Wheezy infant, when to worry. I invite our speaker for the session, Vineet Sehgal sir, and I ask our chairpersons to introduce our speaker.
Dr. Vineet sir requires no introduction. He is the president for Pediatric Respiratory Society for Delhi, and he is a well-known pulmonologist and a practicing consultant. So I would request sir to please take over the session on when to worry for a wheezy infant.
Also, Dr. Nirupma, please introduce other chairperson for the session.
Chairpersons are same, Dr. Rakesh Dogra sir and Dr. T.R. Dagwal sir.
So all the chairpersons today, I cannot start my screen sharing. Okay.
Now we can see your. Achha.
I still can't share my screen.
Now you can share.
Now you can share, sir.
Yes.
Is my screen visible now?
Yes.
So I have Manish there, I have Hema there, I have Tilak there, I have Rakesh there, all pulmonologists who probably...
You have Dr. Naab also there. Who is
Dr.
helping?
Naab also, sir. Yes, you are also a pulmonologist, sir, absolutely.
No, not pulmonologist, so, friend.
Yes, thank you. And thank you, Nirupma, for that cup of virtual tea. I'll start now.
Thank you, sir.
Wheezy infant, when to worry. By nature, I would worry for every child who's wheezing, because wheezings can go bad and wheezy child can land up in the ICU. They can land up with myocarditis. So I think all of us, when faced with a wheezy infant, do worry. But then there are certain typical wheezers which would go through a course which might be slightly stormy, but then they settle down ultimately within a few days to weeks, which are our usual viral induced wheezing. So infantile wheezing is basically defined in children less than 2 years of age. So children less than 2 years of age qualify to fall under the number of infantile wheezing. Usually wheezing in these children starts after about 4 to 6 months of age and is by and large virus triggered. Then that is what all of us see. They can be recurrent, but remarkably, the child is absolutely well between these distinct episodes of wheezing and is thriving well. Usually it starts off with a URI prodrome. They have a coryza, they have a mild cough, and then as they say, it goes down to the chest, and then they start wheezing. But usually it's a happy looking child. If not happy, at least it's not a sick looking child. They do breathe fast and might have a mild distress, or it might actually go to severe. You hear a generalized wheezing, and response to pharmacotherapy is again variable, because you have an element of bronchospasm which might respond to your bronchodilators, but the inflammation obviously doesn't. So though you have some response, but it's not a very satisfactory response. So that is what your typical wheezer looks like, and all of us see it day in, day out, and this is the season when it's going to start or has already started. Now, our concern is the atypical or the unusual child. So which wheezer do you consider unusual? So you have certain red flags in history and you have certain red flags in the examination. So if a child starts wheezing soon after birth in the neonatal age, or very soon after, within the first couple of months, and especially starts having recurrent wheezing, that's a red flag. If there is no association of these typical triggers, such as a viral infection or exercise or cold, which causes the wheezing, then sudden catastrophic onset of wheezing, a child who's never had a wheezing episode and suddenly comes to you with a severe wheezing, or if the child has persistent wheezing. Most of our viral wheezers, as you all know by experience, the wheezing would settle within 10 to 14 days with treatment, without treatment, but generally the wheezing tends to die down. But if the wheezing is persisting beyond 2 to 3 weeks, then your antennae should be up for something unusual happening. If the mother reports feeding difficulties, especially associated choking or regurgitation of feed, that also again then points you towards micro aspirations going on, and that be the cause of wheezing rather than a virus. And of course, no response or very poor response to bronchodilators would again be a red flag. When you examine the child, if the child has failure to thrive, if there is presence of stridor, and remember very often what parents or a general practitioner might describe as wheezing is actually a noisy breathing of some other sorts, commonly a stridor. If there is presence of clubbing, if the child has hypoxemia, which is beyond what you would expect with a child with respiratory distress. So either there is some sort of a chronic lung issue going on, or there is some sort of a right to left shunt happening. So again, that alerts you to the possibility of something unusual. Persistent wet cough. All parents will tell you कि इसको बलगम वाली खांसी, and you hear that balgam wali khansi. But our wheezy child, the wet cough will again settle within a few days. But if it's a persistent cough going on for weeks, or if there is a persistent localized, one part of the chest is showing you the wheezing and rest of the chest is clear, or you have a monophonic sort of a wheezing, or again there are focal signs on radiology, or if you culture unusual or bacterial organism, because like I mentioned, most of these are viral infections. So if you culture bacterial or unusual organism, again this alerts you, it's a red flag that it's a cause for worry. So just to take you through a few illustrative cases, this was a 12-month-old child, girl child, who had history of recurrent wheezing and cough. Parents also complained that she would have noisy breathing at other times, would frequently vomit, and after feeding would be uncomfortable and cry for quite a long period of time before settling down. There was no family history or personal history of atopy. The routine investigations and chest x-ray were normal. So in view of this difficulty after feeding, crying after feeding, frequent vomits, we did a barium swallow, and it showed a major reflux. So this was a child who had a gastroesophageal reflux disease with wheezing. Another child was a 10-month-old male who was brought to the emergency with breathing difficulty. And again, this child had past history of noisy breathing, was admitted at a nursing home for this episode, was given the whole gamut, as we know, IV fluids, antibiotics, hydrocort, saline nebulization, budesonide nebulizations. In the emergency, he had oxygen requirement, needed oxygen by nasal cannula by about at the rate of 3 liters per minute, but was maintaining saturations, was active and responsive. But he had tachypnea, significant suprasternal and sternal recessions, and subcostal. And apart from the rhonchi, you could also hear a biphasic stridor. So this child, looking at the history and the presentation with the stridor and sternal suprasternal recessions, we were quite sure that there was some airway problem and likely a airway malacia. So we did a bronchoscopy and it did show tracheobronchomalacia. So the first set of patients where you would worry is children who start their symptoms below 6 months of age and typically have noisy breathing apart from wheezing. And even during the intercurrent period, they are not completely well. Some amount of noisy breathing, some amount of distress, some amount of cough goes on. You would think of micro aspirations or other aspirations happening. You would think of congenital airway anomalies. Airway malicias are very common. Vascular airway compression happening. And also you would want to rule out a congenital heart disease. So this would be one of the worries. Then another set, we saw a child who was 4 months old, product of a non-consanguineous marriage, had persistent cough and wheezing since 2 months of age. So it came with almost 2 months history of persistent cough and wheezing. Also had loose stools off and on, had a significant failure to thrive, but there was no history of delayed passage of meconium, no respiratory symptoms in the neonatal period. We treated her, but she had poor response to bronchodilators and antibiotics. That's usually the standard, treatment when children come to us in private practice. The TLC was normal, though the differential was neutrophilic. The blood cultures were sterile. The chest X-ray was unremarkable. We still suspected that something significant is going on in the chest. So though the chest X-ray was normal, we did a CT chest to be sure that we were not missing anything. Apart from some amount of bronchial thickening reported, the CT chest was also non-contributory. So we went ahead and did a bronchoscopy with a lavage, and that grew a pseudomonas, and that set our alarm bells ringing. And that is when we did genetic testing for this child, and it showed as a gene mutation consistent with cystic fibrosis. So another set of children where you would worry, infants who are wheezing, who have persistent wet or productive cough, and the operative word is persistent cough. If they also have failure to thrive, multisystem or multifocal involvement, or you grow some unusual organism, then you have to consider conditions like cystic fibrosis, primary ciliary dyskinesia, or some sort of an immune deficiency. So that's another set when you worry. Then just a final case, we had a 3-year-old with history of cough and fever for 5 days who had no response to oral antibiotics and bronchodilators when treated on an outpatient basis. She also had history of wheezing in the past. She came to the emergency, was febrile, had rhonchi on both sides, but also had bronchial breathing at the right base posteriorly and crepitation, and it looked like a consolidation. We did a chest X-ray and it showed a collapse consolidation on the right side. And we put her on appropriate antibiotics as is the norm for the hospital. But the collapse consolidation did not improve after 7 days of antibiotics, bronchodilators, and chest physiotherapy. In this child, we thought that the collapse is probably persisting because of a mucus plug. So let's do a bronchoscopy and clear the airway. But we were in for a surprise when we did the bronchoscopy. We actually found a forgotten peanut or a foreign body, which we really don't know when the child had aspirated because there was no history. However, we managed to remove the peanut, and this is the X-ray 2 days later after the bronchoscopy. The collapse consolidation had resolved. So this is another set of patients you would worry, small children who are wheezing, when there are localizing signs such as an unequal air entry, or on X-ray you see a unilateral emphysema or a collapse consolidation which is not resolving, or there are other signs on imaging. So in this set of children, you consider a foreign body aspiration or congenital anomalies such as a sequestration of a lung or some sort of a cyst which is lying there and getting infected again. So this is the third set of children you would worry about. So this kind of is what I wanted to briefly, highlight infantile wheezing situations when you really start worrying and think this is not your usual garden variety of wheezing. So it is important to remember that first, I always like to stress that all noisy breathing is not wheezing. Every parent will come to you and say कि सीटियां बज रही हैं और wheezing हो रही है, but then you have to hear the wheezing for yourself and make sure it's not some sort of a stridor or a stertor or some sort of other sound. All that wheezes is not your usual garden variety of bronchiolitis or Walry or asthma as we know it. And so intuitively, it also means that all wheezing is not benign. There will be a few cases of wheezing that you will see will turn out to be something more sinister. And it is important to remember that younger the age of onset of this recurrent wheezing, so smaller the child, more likely it is to have, the child is likely to have an alternate diagnosis, and the more you worry. Smaller the child, the more to worry. And this last statement, of course, is just coming from a pediatric respiratory specialist, that do remember that all asthma does not wheeze. So I would, stop here and hope that, from worrying about an infantile wheezing, I've been able to help you and make you slightly more relaxed while you are handling your usual wheezing and not worry too much. Thank you so much.
Thank you, Dr. Vini. You have covered the topic in a very excellent manner. You have covered almost all the variety of wheezing, the atypical as well as typical. And we have few seconds left for the question and answers. If somebody wants to raise any query or any comment, you're welcome.
We are already getting late, so can we move on to the questions can be answered in chat box?
Sure enough, sir. Sure enough. Thank you so much.
Thank you. Dr.
Hema, one thing I would say, all these cases belong to a pediatric pulmonologist.
Dr. Hema,
हमारा काम नहीं है इसमें. मेरे को चारों पांचों में लगा कि as a general pediatrician you have to just think and ultimately the child will go to you.
नहीं सर, ऐसा नहीं है. I am sure
you. आपने सारे इन्वेस्टिगेशन ऐसे किए कि that we can't do.
No, no.
Recognize, I think, right?
You can
That is the
make-
most important part, right? Thank you.
You can have a clinical suspicion. You can make a
Yes,
clinical
yes, yes.
diagnosis, and then.
But ultimately, referral goes to you.
No, referral goes to Hema and Rakesh, who are the ones who do bronchoscopy. Have stopped doing.
I think one word from Dr. Rakesh also. He didn't spoke, and Dr. Tilak. One sentence.
Tilak spoke right now. Dr. Rakesh, if he wants to comment.
Sir, unmute yourself.
See a lot of VZ patients, and we are doing regular bronchoscopies at our place. Dr. Vineet ne jo bhi cases bataye hain, they all are familiar for pulmonologist, and I hope other participants also got benefited from this. Referral to sir hamare paas hi aayega.
Okay. Our job is early detection, right?
It's a primer to, set you
Yes,
on the right path.
Thank you for planning.
Dr. Vineet, I am so proud person because Rakesh has been my registrar. So we work together and I'm always proud of him.
And I'm proud he's my good friend.
Thank you so much.
We're a small group, but all of us get along well and help each other as and when, we get stuck. So
You should add more people into pulmonologist group. हमारे इतने pediatrician बैठे हैं. You should call.
आप all-rounder हो आपको.
नहीं, we should learn कि pulmonologist किसने सीखनी है, आओ हमारे पास. We will be ready.
वैसे भी सर आप भावी प्रेसिडेंट हो, जो आप बोलोगे हम हाँ कर देंगे.
Oh, thank you very much. Thank you.
Dr. Vineet, now we move on to the next talk, next session.
Yes.
Next session is on how not to miss chronic liver disease in office practice. The speaker for this is Dr. Neelam Mohan. The chairperson for this session are Dr. Shishir Pal and Dr. Vidyut Bhatia. Dr. Shishir Pal is Clinical Director, Pediatrics, Rainbow Children Hospital, New Delhi. And Dr. Vidyut Bhatia is Senior Consultant, Pediatric Gastroenterologist at Max Hospital, Saket, Patpadan in Vaishali. I request persons to please introduce the speaker.
Well, Dr. Neelam is known to all of us. I have heard her very often. She always makes the topic very interesting, and she is very thorough in her subject. Chronic liver disease is not easy to diagnose, and it is diagnosed very late normally. I think she will enlighten us how to diagnose early and prevent liver damage. Dr. Neelam, please.
Right. Thank you so much. I thought I'm going to give the talk when there is enough daylight, because in my office there is daylight is there. But sadly, by the time the talk came, the lights are very bad, and I'm just about to buy a new laptop. So bear with this darkness. And it's my pleasure to be able to, the speaker was unfortunately not well. So I was given just a day or two to get into this. So I will do my justice. And I appreciated the talk, the message which Lalit gave. Lalit, you have a very good point, but what happens is that the common things everybody know. So your point is just to make you realize when not to miss. That's what in Visa he ended up taking you to a specialist, and I really appreciate that point which you said. So first of all, chronic liver disease, even in the definition, a lot of people think, what exactly it is. What I would say is that it's a wide spectrum, but it's not necessarily 6 months. We say more than 3 to 6 months duration. So that is one point, because as a student, I've always seen people say 6 months, 6 months. Second, I want to say that even a patient who comes to you for the first time may have a chronic liver disease, and not necessarily that, you are not able to get a 6 months history. So this is the opening statement of my talk, that it will go. So I'll give you a little clues of different interesting cases where I'm just trying to highlight that do not delay. So that's the purpose of saying in office practice, but ultimately what comes in office might get admitted, etc. This was a girl who presented with just jaundice for a day with fever and URI. But in the history, she did have 2 episodes of jaundice in the last 2 years, and her liver was just 2, but her spleen was 3 centimeter. And so her weight centile and all based on her parents' height, she was okay for her height, and her weight looked okay. And her bilirubin was 103, 150, 190 INR normal. So it is like an OPD practice, this patient comes to you. But what I would like to highlight is that in the past, this patient had 2 episodes and the same pediatrician had seen. First time the pediatrician made a diagnosis of paracetamol-induced liver disease. And the next time he thought it is non-viral, some viral-induced liver disease. So that is the message, that your history is very important. If you think the patient came to you even with such small enzymes and you had a past history, you should start thinking, is there an underlying liver disease? So the message is, family history of liver disease or death in the family, history of consanguinity, past history of jaundice. So this is my key slide that I want to enlighten. Examination, I normally spleen in a viral should be, can be 1 to 3. This was around 3. You should start getting worried. This looks a little more. Is there an underlying liver disease? I'm not saying that you cannot get a 3 centimeter in acute viral hepatitis. Please, I'm not saying that. Or when you get significant ascites, I'm going to take you to through various cases, and this is a very important slide to remember. Or when you saw the patient had clubbing, or when you saw the patient had palmar erythema, or when you saw the patient had testicular atrophy, or when you saw the patient had spider nevi, or you thought they were joint issues, or you thought there was severe history of, rashes, etc. So this is just telling you what you need to see. And in this patient, my viral markers were negative because it was just 150 enzyme, but the autoimmune test came positive and turned out to be. So now, of course, I'm not saying for a pediatrician, but yes, in a higher center, you do biopsy, etc., and treat them, steroids, etc. But the message is the pediatrician should not have missed it in the second time. When the patient came second time, he thought it is non-viral hepatitis, non-hepi, which was wrong. That was a key message. Another child, a 6-year-old child who was born to 3rd-degree consanguinity, and there was jaundice for 3 months with abdominal distension for 1 month and fever for 15 days. So normally I said chronic liver disease should be more than 3 to 6 months. Now let us see. There was no history of GI bleed, was going to school before there, no family history. Yes, the 2 siblings, they are normal. But when you examine this patient, besides the icterus, the palm, there was a bit of atrophy here, and there is palmar erythema in this patient. So this should alert you. Now, though this patient's liver enzyme, if you see carefully, June, the liver enzyme was 72, 658 this time. But earlier I said in the earlier period, the liver enzymes were higher. In the July, SGOT became more than PT. But in the first time, SGPT was 658. So again, I want to bring to your notice that in June, it was PT which was more, but in July, SGOT is starting getting to more, and the INR is high. So, a panel of tests for fever, like lepto and ferritin and this and that test is being done. But the key thing, what you see is hepatitis E was positive. So is it just hepatitis E with this? But because of palmar erythema, I should start thinking, is there something more? Yes, of course, you may be overdoing it. I totally agree with you. But at least see more. We did a KF ring, ceruloplasmin borderline 20 is normal. This came 17. KF ring was not there. Urinary copper was high. Now 82 urinary copper. So the recommendation now from the Wilson's ASLD guideline is earlier we used to say 100, But now we say 50, 60 if it is more. So this is something which should alert you that is there anything going wrong. Immunoglobulins were also on the higher side. Now, when immunoglobulin is high, you think is it autoimmune or it could be sometimes related to. So just to sum up, this child had jaundice, this child had hepatomegaly, this child had liver enzyme raised, immunoglobulin was raised, prothrombin was prolonged, SMA was also positive, hepatitis E is positive, and urinary copper is there. So now it is a big khichdi. You don't know how to go about because autoimmune is also coming, Wilson's is also coming, Hep B is also coming. Moral of the story is no, you need to involve a specialist because this is not just hepatitis E. So Lalitji, that is my key message. Here you should start saying कि यार कुछ तो गड़बड़ जलेबी है, दो तीन चीजें लग रहे हैं, मुझे कुछ और rule out करना है. So in this we started thinking acute on chronic liver failure, all these things, but because albumin was low, is there an underlying CLD, etc. Ultrasound showed some coarse texture. And this is the definition of acute on chronic liver failure, where there is jaundice, where there is coagulopathy, but the patient did not have any previous history of CLD, but now there is ascites. And we've talked to you about Wilson's. It can present you at any age. People generally say more than 3 years. And the classical triad is ceruloplasmin, KF, and urinary copper. But second message I want to give the pediatrician, you will not get the classical triad every time. In this patient, KF was normal, ceruloplasmin was below urinary. So we ultimately did a liver biopsy because these are the pitfalls in the diagnosis. Though is not char in medicine, you can have other things. So these are the issues that you see. We did a biopsy, we diagnosed it. So somebody can ask me, Neelam, why was the SMA positive? Yes, you can have autoantibodies also positive in Wilson's. Coming to another case. This was a patient who had seen by me 15 or 17 years back, but I would love to share it with you. That this child had jaundice, was at that time admitted in PSRI, and I got a call that the child is irritable and sleepy. And so you will start thinking the clue whenever the child is got jaundice and irritable and sleepy, you will start thinking of an acute liver failure. But this child had a liver test derange and INR was prolonged to 4. So there was liver failure. But what I want to highlight, the hepatitis E was positive, but it is always better to do the other test too. And this patient had the KF ring positive along with high urinary copper. So sometimes don't get blind to one report in liver. Sometimes there is something which you see, but below that there may be an underlying liver disease, chronic liver disease, which you should not miss. So this patient we diagnosed as hepatitis E, triggering the Wilson's disease with liver failure. And remember, Wilson's patient without transplant, you cannot save. Hepatitis E, you could have, but not Wilson. So you look for a score. We looked at that scoring and it was high, and normally 11 you should suggest. But I'm talking about those days 15 years back. And 15 years back, you don't get cadaver in that. You need somebody to donate a liver to do. And so it has to be a family member who's happy to donate between 18 to 55 years, should not be very fat, should be not having hepatitis B, C, HIV, and then you can take. So this was the first transplant for a liver failure due to Wilson's in India, first liver failure. That was 2004. And this is a handsome young man today. So one has to be observant. The pediatrician at that time in PSRI, or it was an adult as well as that, They decided that there was something more to this child and they gave the benefit of doubt. And we have done now 300 transplants, of which majority of our patients, 1/3 are small babies that we do. And the world's smallest 2 kg was by the grace of God done by our team. Those interested can read the paper that has been coming in Indian Pediatrics. We can also do a blood group mismatch transplant nowadays. Coming to another message. So the first messages were that though your history was important, second, the next message was you had something shouting at you, but your examination was palmar erythema, or you thought beyond it and you did a test. So this was the key message. This is another beautiful message if somebody picks up. This was a 7-year-old girl, a case of epidermolysis bullosa, who had pain, vomiting, and sudden abdominal distension for 10 days. They, the liver tests were deranged. The outside pediatrician had done serology for TB. At that time, this no test. That time, gene expert, they were not doing much. And he decided that based on the CT scan, there is ascites, there is lymph node, they started with ATT. Then the patient came for concern. Now, message is key. I said history is very important. And case, epidermolysis bullosa case, go to the history. What did I do? I took a very careful history. And when I examined, the liver was 3, not great, can be in TB. But despite doing a tap, the next morning, the ascites is accumulated. So you should think, is there any outflow tract? And what was the history? Epidermolysis में sometimes ये लोग Ayurvedic treatment ले लेते हैं. So we talk, this patient was taking some special tea given to him. And these tea and all those things can block your hepatic vein. But it was a good history that made us think, though outside CT scan was also available, but we still carefully asked the sonologist to look for the veins, and actually the hepatic vein 2-way blocked, which was missed outside in ultrasound and CT, but it was a good history. It was a Budd-Chiari syndrome. And so we did stenting for the hepatic vein. So that was another history. Look, skin disorder, epidermolysis, these people take both idhar-udhar ki treatment, and you should have got alert with that and not just started ATT. It was an underlying liver disease. This was a young boy, 5 years, who had fever, was given paracetamol, came to me with some blood in vomit and hemoglobin C, liver test is normal, SGPT. This child earlier also had some vomit, and the doctor had thought drug-induced gastritis. But I would like to bring to your notice that whenever there is some hemoglobin which is low, and even if you're thinking a drug-induced gastritis, please do an endoscopy. Because when I did the endoscopy, it was actually varices. And if there is varices, this turned out to be an EHPVO. So what was the message? The first pediatrician missed it. He called it as drug-induced gastritis. He should not have done it. He should have thought that this could have been anything more and been vigilant on that. This is another case which came to me day before yesterday in the night at midnight, 11 p.m. was admitted 2 days back. Look at this. This patient is just jaundice for, 3 days. Jaundice is 3 days, but there is ascites. You can see fullness clinical examination. That's all. There is ascites in this patient. And when there is ascites, I should not just get carried off with hepatitis A. I should investigate. So I'm investigating. I just did a fibroscan some time back, and it is suggestive of very high CAP, which means there is extensive fibrosis in the liver. I've yet not investigated, came 2 days back. But just saying that, look at the tummy was quite full and it should have alerted you. Small baby goes to a doctor with jaundice. The doctor is a very hi-fi doctor from South Delhi. So what does the doctor do? Uses a bilirubinometer and the bilirubin is 9. The key message to you is, if the jaundice is beyond 2 weeks, just at least do once a total and a direct bilirubin. Don't use just bilirubinometer, because bilirubinometer will not give you direct bilirubin. This patient came to me because they live in Gurgaon, and what did I open the stool? I saw it clay. So I'm worried. Why am I worried? Because clay stool means cholestasis. So this is another clue to the pediatrician. Look at the diaper. Is it clay stool or is it dark urine? And as you would have thought, yes, this child turned out to be on biopsy biliary atresia and had to undergo Kasai potoenterostomy. So the earlier you diagnose, the better it is. So the key message here is, do a total and direct and not use bilirubinometer and not miss a small child with cholestasis, and look for the urine and stool. Don't forget to miss the urine. Even if you don't see the stool, even if the urine is dark color, please get worried that this could be cholestasis. You can avoid a transplant by doing a right timely that. This is another child just admitted under me 3 days back. What is it? The key message here, the patient had jaundice and there is ascites. Whenever you see a 2 months old baby with ascites and jaundice, you should think of metabolic liver disease. Because metabolic liver disease, other clues, family history concern. This child did not have any family history, any consanguinity, nothing. But you can have other features. Just a slide I'm showing. Hypotonia, hypoglycemia. This, my child had severe coagulopathy. PT-PTTK were more than 200. So this child needs a transplant. We are proceeding tomorrow at morning with a transplant for this patient. So the clue was, in metabolic, they may not give you time. He will die with a PT-PTTK of 200. And luckily, they've been giving blood support and outside the city, and just got transferred to me day before yesterday. So think of the conditions less than 1 year. These are the conditions which can give rise. And another thing is galactosemia. This patient was on breastfeed, or I would loved to, if in doubt, stop the breastfeed, look for the urine reducing substance so that you don't miss. So I would sum up now. I was given 25 minutes. I'm just giving you 2-3 spotters that in your clinic, when you get a child with some jaundice, please look at the eyes also. This child had a KF ring. So you can look in the clinic also as a spotter, and you can think of Wilson's disease in that patient. This was a child who presented with rickets, as you can see, and had LFT deranged. What you should see, rickets, and sometimes alpha fetoprotein is raised. This turned out to be tyrosonemia. Just a good clinical examination. This baby coming to you with jaundice, look at the face. Don't think I'm showing you chubby face. You are mistaken. I'm showing you cataract in the eye. So cataract in the eye, it is galactosemia, and you could have changed the milk and saved the patient. So these were the clues. To sum up, my dear, if you find thickened skin, start thinking of familial intrahepatic cholestasis. That could be the cause. So, my dear colleagues, look for the clues in history, examination, and evaluate the test before you analyze and diagnose the patient. Thank you for calling me over.
Thank you.
Thank you so
Thank
much,
you, ma'am.
Dr. Neelam, madam. Thank you so much for helping us at the last moment. Thank you so much.
I appreciate.
Thank you, and giving us a very good clinical alerts. Right. Thank you.
अगर ललित को खुश कर दिया तो I will get a chocolate.
Much more than that.
So मेरी chocolate due है.
ड्यू है मैम, पहले की भी ड्यू है। थैंक यू।
Thank you, Neela ma'am. Thank you, our eminent chairpersons, Dr. Shishir Paul sir and Dr. Vidyut Bhatia sir. Now we move on to our next session, that is expert talk on antimicrobial stewardship. For this session, I invite Dr. Ramesh Kumar sir, President-elect 2022.
Can anybody take a picture? I don't have a thing before I wind up.
Rohit, please.
Sir, can you take a picture with you and Lalit, please?
I have taken, ma'am.
Rohit,
रोहित एक बार ले लो, एक बार ले लो। रोहित एक बार।
Yes, ma'am.
Yeah, please continue.
Now I invite Dr. Ramesh Kumar sir, President-elect 2022, past Secretary, Central IAP 2018-2019. I invite Dr. G.V. Basavaraja sir, Honorable Secretary General, Dr. Shyam Kukreja sir, who is Director and Head of Department Pediatrics, Max Super Specialty Hospital, Dr. R.K. Nab sir, who is President, Delhi IAP. Now I invite all the chairpersons to introduce our eminent speaker, Dr. Bakul Parekh sir.
Yeah, thank you so much. So antibiotics is one of the important thing in the present era. So one of the President Action Plan of an IAP President Action Plan 2020, in the name of a war, writing an antibiotic rationally, we have conducted almost one national TOT along with the 5 zonal TOT under the visionary leadership of Dr. Bakul Jayant Parekh sir. To introduce Dr. Bakul Jayant Parekh, sir does not require any introduction. Sir is a well-known personality not only in India, across the world. He is the president of Indian Academy of Pediatrics and also secretary of SAPA. Sir is also a CEO of our DAAP, and also sir is in a digital center for excellence in Indian College of Pediatrics, and is well known across the world in the pediatric community, and also passionate about whatever the work is doing. He take it to the art and deliver it. So that's what it has been happened in the year 2020. So flood of epidemics of academics has been propagated across India. With these few words, now I invite Dr. Shyam Kukreja sir to say a few words before handing it over to Bakul sir.
So it's a great privilege and an honor to have so many IAP dignitaries on one platform for this session. So thanks to everyone and most welcome to all of you. Dr. Bakul Parekh, Dr. Piyush Jain, Dr. Basavaraj, Dr. Ramesh, and they are the topmost dignitaries of IAP. It's an honor, sir, to have you here. Now coming to the session today, that is antimicrobial stewardship. And I think Dr. Bakul Parekh is going to speak on this subject and give us some key messages on this subject. And then later on, we take forward the further program. So I'll request Dr. Bakul Parekh. I'll tell you, this program was initiated during my chairmanship of ID chapter in 2018. And it was interesting that during that time, it was sort of a idea which came to me, it was conceived. And then, what do you say, Chingari became a Karwan. I think the people started joining and it became a Karwan. And after that, the program was made, and program after making it, the final program after several trial runs, then Dr. Paul.
Sir, unmute. Shyam Kukreja sir, unmute.
Unmute yourself. Dr. Shyam Kukreja, please unmute.
Kukreja sir.
Okay, I think after this program, with several trial runs in 2018, this program was fine-tuned in the last IAP National Conference at Mumbai. And after that, Dr. Bakul Parekh took over this program and propagated to all over India.
So he has been a very enthusiastic president. You have seen what he has done to DIAP. We thought this year is going to be a waste because there's a corona, nothing can be done, no physical meeting can be done. And he made this program in this issue as an opportunity. And he made DIEP program. I remember he started his presidentship and we were making some video programs on, I was making on vaccination, I was making on typhoid. And after that, the DIEP platform came, and I think now it is history. All of you know what has happened. So he has made a memorable year. So this is the capability of our president. So boss, salute to you, and the session and the floor is yours.
Thank you, Dr. Shyam and Dr. Bhagaraj, for your kind words. I am nothing without my team, and it has been a teamwork rather than me doing it individually. And I am very happy that I have been given this opportunity by the organizers. And I am also very happy that this session is being chaired by the chairperson of the conference, as well as the one who has been the brainchild behind this antimicrobial stewardship. So I hope that I justify to the topic given to me in his eyes. That will be my achievement. So with these few words, I'd like to start my talk by sharing the slides. As you all know that antimicrobial stewardship is very important in present days because antimicrobial resistance has become a global issue. This statement will prove that in IDSA 2004 reported that bad bugs, no drugs, as antibiotic discovery stagnates and a public health crisis brews. We have ICUs where so many things happen to lead to sort of ESBLs who are gram negative, which are resistant to antibiotics. They get transferred, plasmid get transferred from hospital to hospital, city to city, country to country, and thereby leading the global issue. We have detected Streptococcus pneumonia, which are drug resistant in cases of meningitis. Then we have 1/4 of the world's multi-drug resistant tuberculosis in India. And we have typhoid superbug, which is spreading throughout Pakistan, our neighboring country. And we know that this particular problem is as hazardous as mountain climbing and bungee jumping. And we, through these antimicrobial stewardship, want to take it to an ultra safe level. And how to achieve that we have to work out. And also we know that Sir Alexander Fleming in 1945 has alarmed us regarding antibiotic overuse and resulting resistance. And the studies have shown direct relationship between antibiotic consumption and the emergence and dissemination of the resistant bacterial strains. So what is antimicrobial stewardship? It is nothing but a rational use of antibiotic, thereby preventing the adverse reactions and thereby preventing the additional use of healthcare resources. We have got finite resources of antibiotics and we have to use it very judiciously. And how to manage these antibiotics is by ensuring that they are prescribed by clinicians and used by patients only when needed, and ensuring that they are prescribed in right diagnosis, right drug, right dose, right duration, and right route. And the goals will be to achieve the maximum benefit out of the treatment and minimize the harm to the patients and the community. And we know that antibiotics is the only class of drugs with potential to impact both the individual as well as the community. At individual level, when you use it unnecessarily, it leads to alteration in microbiota, thereby leading to allergic disease and autoimmune diseases. And at community level, the antibiotic resistance spreads very fast and leads to global issue. So we were talking about rational use of antibiotic, appropriate use of antibiotic, optimal use of antibiotic, and now we say it is responsible use of antibiotic, and that is the crux behind the antimicrobial stewardship. So what is needed? We require really systematic efforts to educate and persuade the prescriber, to follow the evidence-based prescribing, and to avoid antibiotic overuse and resistance. And how it can be done? We have many actors involved in this at individual level, at organizational level, and at government level to implement them and convert it from policy to action. And at individual level, we have prescriber and a user. A prescriber has to make an accurate diagnosis, send the appropriate cultures before starting the proper antibiotic, and once started, they should be able to stop and escalate or de-escalate as required. That is very important. And for the patient level, they have to use the only prescribed drugs. Don't use the ones which are left over, and there should not be any self-medication. So look at this case scenario. A 4-year-old boy with fever and throat pain for 2 days and has congestion throat. We know that mostly it is viral, but when it goes to a municipal hospital, he is prescribed Comoxicillin for 5 days, but he gets only 1 bottle. At corporate level, azithromycin for 5 days, he gets 1 bottle of 15 ml. And at individual level, he may buy 1 bottle for Cefotaxime. And all this leads to probably inadequate dosaging and no proper duration followed. And if you go to a family physician, which may be an homeopath or Ayurveda or otherwise, they will maybe go for the injections, like injection streptopain. And all this leads to chaotic treatment. And there is an antibiotic abuse in office practice where the surveys have shown that 50% of the antibiotics are given inappropriately and 30% or more are unindicated, especially the conditions like fever without focus, upper respiratory infection, watery diarrhea, soft skin and soft tissue infections, UTI, LRI. So you will find innumerable incidences where you will be able to see in your neighborhood also that doctors are prescribing very irrationally. So there has to be a core element towards the antibiotics towards them, and that is the most important part should be commitment at the level of clinicians and the facility leader. And what they are supposed to do is to be an antibiotic steward. In fact, at IAP, I was talking to Basavaraj and others that we should start with a certificate course on being an antibiotic steward, and we should give that certificate which a doctor can display in his clinic. And also they should be displaying many other things which will be supporting the antibiotic stewardship program. And we should identify a single leader to promote the antibiotic stewardship. And what are the steps? Identify the high priority conditions, identifying the barriers to improve the antibiotic prescribing. Why doctors are not following those prescriptions or consensus guidelines? There must be some reason. And establishing standards for antibiotic prescribing. So what is the high priority condition? Watery diarrhea and upper respiratory infections are over-prescribing antibiotics. Throat infections have over-diagnosed antibiotics. Cefixime is used for sore throat like a rock agent. Non-severe AOM, we know that we can wait, but there the antibiotic started upfront. And amoxicillin, which is a good drug, first-line drug for pneumonia, is being underutilized. Then what are the barriers because of for this? Clinicians' knowledge gaps about best practices and clinical practice guidelines. They may not be knowing or they may not be attending the CMEs which they are supposed to. Clinical perception, patient's expectation for antibiotics. They always feel that patient will be happy only if you prescribe antibiotic. They are very busy in their practice. So to get rid of the safety part, they prescribe antibiotics to be on safer side. And then clinicians concerned about decreased patient satisfaction with clinical visits when antibiotics are not prescribed. So how to overcome these barriers? Clinical knowledge and gaps can be covered up by education like CME, workshop, mobile apps. Clinical percent of patients' expectation for antibiotics, we can educate the patients. Perceived pressure to see patients quickly, we should restrict our practice to limited numbers and be disciplined in prescribing. And the concerns of the patient satisfaction, we should have proper counseling and communication skills. And then establishing standards for antibiotic prescribing. That of course can be done by using smartphones, guidelines which are developed by IAP. We have IAMS program, National Antibiotic Program, then there are IDS and ICCU, and so many others. And we have our Bible of Nelson textbook and pocket book, which can always refer to regarding dosage and the drug. We have our own drug formulary, which is very good. If you look at the drug formulary, you get details about the antibiotic itself, or you get the details of the disease where what antibiotics you are supposed to prescribe. So definitely you can do a rational therapy if you are really inclined to do that. So as a clinician, I should ask myself before prescribing antibiotic, whether this is an infection. If it is an infection, whether it's a bacterial infection, then what is the likely pathogen? Whether this condition needs immediate empirical antibiotic because it's serious. What is the site of infection? In the case of CNS, we give an antibiotic which cannot cross blood-brain barrier. No meaning. Is there a reason to suspect drug resistant bug, or is there any comorbidity? If you keep all these factors in your mind, you will be most of the time right. So empiric antibiotic is required certainly in case of bacterial infection where infection is very obvious clinically and you don't need to do any investigation. But when you have a high probability of bacterial infection on clinical grounds, definitely you are justified in starting antibiotics. But before that, you will send samples to diagnose the microbiological diagnosis and the antibiotic sensitivity. And once you have that report, then of course you will treat with the suggested antibiotic. In some cases of viral infection where there is atypical progress, we have to think about antibiotics. Then about policy and practice, as Dr. Sam Kukraja used to say when he started with the AMS program, I distinctly remember, you cannot start everything together. That will confuse people, but at least start implementing one thing at a time. Like what we say in quality improvement, we always follow a SMART principle, where it should be specific, measurable, accessible, and possible. So time-wise possible. So if you follow that and do that 2 or 3 PDSS cycle, assess, reassess, and come to a nice, good quality practice and quality reasonable therapy. And then of course you should do the tracking and reporting and education expertise the patients and clinicians. So you will definitely use evidence-based diagnostic criteria, and the treatment recommendations should have developed communication skills. Written justification, you write the diagnosis and write why you want to give an antibiotic. Then you will be most of the time definitely on the writer side, and provide support for this clinical decision. So in general, when a patient comes, you will start diagnosing on the evidence-based or clinical and physical examination has been stressed in past by so many academicians. Start the treatment as recommended, follow the guidelines, and do some rapid tests if required. And then, of course, you do documentation, write the diagnosis, and write the reason to start antibiotic. That will be the best possible way. And then you start tracking at facility level and individual level. And what happens in your antibiogram, you should be looking at it. And then, of course, you will be having all those workshops and clinics and so many other things which are doing already. So if we talk of antibiotic stewardship in the inpatient cases, let us look at this case. The 3-year-old Magna has come with fever, cough, and rapid breathing for 2 days. He's admitted and has been put on ceftriaxone and amikacin. Now let's analyze. What will be our thoughts? It can be bronchiolitis, it can be Valry, it can be asthma, it can be pneumonia. In case of bronchiolitis, if we go into the details, as per the age, 2 months to 2 years, he should be generally a happy-looking child who is non-toxic. There should be an insidious onset, gradually increasing with rhonchi and crabs. In case of Valry, the age group is 6 months to 6 years, with insidious onset gradually increasing with rhonchi and crab, but there may be a previous history of viral infection. In case of asthma, recurrence is the most important part of it, and the age group, that is 5-year-old, who is non-toxic and wheezing, and there is good response to bronchodilator that comes from the diagnosis of asthma. And if all these three are not there and child is very toxic, then of course you know that you are dealing with pneumonia, and there you are justified in starting antibiotics. So if you give a little thought, spend a few minutes after looking at the clinical picture, then you will be most of the time right. So no antibiotic in these three conditions, definitely antibiotic in pneumonia. So how to improve the antibiotic use? By optimizing the diagnostic. So in case of pneumonia, when in doubt, of course, we have always been taught that X-ray is not required when there is a clinical diagnosis of pneumonia, but sometimes may require to do CBC, and X-ray chest to know whether there are any complications or we are missing something else, and then proceed further. And then, of course, we should give lots of time to antibiotic timeout, because most of the time when you start antibiotics, you tend to do it blindly for 10 days or 7 days or 14 days without realizing, but definitely you should be happy to narrow down your duration of therapy and do some de-escalation based on the culture report, and also think about the dose and the route of the administration, and then it will help in our stewardship. Infection and syndromes as interventions to improve the antibiotic use are very much required, and guidelines and recommendations of be followed depending on the facility specific antibiotic policy. Like that day, Dr. Bala Subramaniam was taking lectures for the postgraduates, and he was talking on antibiotic policy at Kanchi Kamakoti, and they have come up with the book and the policy, because every time the batches will differ or change every 2 years. But then if there is a policy, they will follow certain policies very strictly. And now the optimization of duration of antibiotics is coming in, and there are so many reports which shows that uncomplicated urinary infection you may treat for 5 days, community acquired pneumonia you may treat for 3 to 7 days depending on the response, VAP can be treated for 8 days, and so on. So you should follow this particular criteria, look at this recent developments, and restrict yourself to using antibiotic to the optimum period rather than giving for a longer time, thereby overexposing your bacteria. Or sometimes when you give for lesser time, you underexpose the bacteria, and then they develop resistance. The point prevalence surveys of antibiotic use was done in 6 hospitals, and it showed in 681 children that 61.5% were prescribed antibiotics, 98.2% they were having antibiotics of various sorts, out of which third generation cephalosporins were prescribed for almost 40%, on 15% BL/BLI, and the commonest was LRTI, where 25% of the antibiotics were given. And in 37%, third generation cephalosporins were given against the national policy recommendations of penicillin or BL/BLI. So you know that people are listening to these CMEs, but they are not putting it into practice in their practice, and that is leading to all this confusion and chaos. So there are 2 types of core antibiotic stewardship programs in indoors. One is front end and the other one is back end. In front end, where microbials are made available through an approval process with some restricted formularies which are available and with pre-authorization. In back end strategies, where antibiotics are reviewed after the treatment has been started with prospective audit with intervention and feedback. So if you look at this, antibiotic prescription done by the primary team in case of front end, then first few closed doses are permitted for selected antibiotics, and then there are some restrictive criteria which is looked upon, and then the antibiotic stewardship team or infectious disease physician gives an approval, and then he advises what is to be given to the patient. And in the case of back-end strategy, which is generally followed in all the corporate as well, is there where you prescribe the antibiotics by the primary team. Day 1, you review the dose and possibility of IV to oral switch. And on day 4, you review all appropriateness considering the entomicrobial culture results. And then you review the duration of therapy. And that's how your team comes into picture and then gives approval for further treatment in the patient. So at government level, of course, they have started with National Action Plan for combating antibiotic resistant bacteria. And the goals of the National Action Plan is to slow the emergence of resistant bacteria and prevent the spread, then strengthen the national One Health surveillance, development and use of rapid and innovative diagnostic tests for identifying resistant bacteria. Now we are going to get point of care tests in terms of Maldives and so many other things. Accelerate the development for newer antibiotics and vaccines, and improve international collaboration and capacities for antibiotic resistance prevention, surveillance, control, and antibiotic research and development. By 2020, it was decided to establish antibiotic stewardship program in all acute care hospitals, reduction of inappropriate use of antibiotics in 50% in outpatient settings and by 20% in inpatient settings, and in all 50 states to monitor regionally important multi-drug resistant organisms and provide feedback, and elimination of use of medically important antibiotics for the growth promotion in food producing animals. So at government level, so many things are going on, but we have to comply with them and follow the guidelines. There was a Chennai declaration, which was for the first time in India. There was a meeting in 2014 or 2013. They came out with a sort of oath, which was to be taken, and the declaration was given to almost all the states. And this was the first ever meeting of medical societies in India on issue of tackling resistance, with a plan to formulate a roadmap to tackle the global challenge of antimicrobial resistance. ICMR and NCDC also started antimicrobial surveillance network in 2013 and 2014, and the Indian Ministry of Health and Family Welfare has launched 5-year National Action Plan on AMR, and currently it comprises of 25 public and private sector hospital laboratories across the country that report antibiotic susceptibility data on important resistant pathogens. And in 2014, ICMR joins with hands with IAP, and they came out with 4-point plan to tackle the antimicrobial resistance by developing and disseminating the guidelines, educating the doctors, and developing infection control guidelines for small hospitals and nursing homes, and collecting data on antimicrobial resistance for the clinicians. And this was again Government of India under the leadership of JP Nadda in 2017 had come out with certain guidelines. And this is our own Dhanya Dharmapalan and Vijay Evle from Apollo. They have also presented their paper in European Society with the findings that there was lack of time, personnel, and resources. There are national antibiotic guidelines for pediatric and neonates that needed to be developed. Microbiology services have to be improved. Local governing body and NPSP network has to work together and mandate 48 hours feedback after starting an antibiotic, and provide online clinical pharmacology support for comorbid conditions and regular training. And at organization level, of course, IAP is doing so many activities which you know, and whatever is doable in AMS is document the diagnosis, justification note whenever antibiotic is prescribed, identify the area of change in prescription behavior, implement one thing at a time, self-evaluate and self-audit of use of antibiotics is very much required, commitment to be antimicrobial steward, display posters of commitment in the clinic like no antibiotics for watery diarrhea, no antibiotics for watery nose, and so on, so that patients themselves get trained and they will ask doctor when they write an antibiotic, why you are giving antibiotic to my child. Implement the standard guidelines and recommendations. Peer opinion and discussion is very important. If you find somebody of your colleague prescribing antibiotic inappropriately, you can have a friendly discussion and ask him why you are doing that, and try to train him or try to suggest him as to what to do. And then, of course, you get updated by attending CMEs, use pocket guidelines and smartphones. Sensitize fellow practitioners and family practitioners. Make responsible use of antimicrobial in practice. Include diagnosis, justify the note, and let us all pledge to be a good antimicrobial stewards. So this is what usually we should do when we want to start an empiric antibiotic. Think about the likely pathogen, think about the likely antimicrobial resistance, looking at your local antibiogram, prior antibiotic exposure was done or not, look at the severity of infection and the site of infection in the host comorbidities, and accordingly modify when cultures are available to most narrow spectrum and appropriate antibiotics, and give the right dose, the right duration, and the right route. So encourage rational antibiotic practice by reducing antibiotic pressure in individuals, hospital and community level. Use combination therapy selectively, especially it is used for TB, malaria and HIV, but not in general for all the bacterial infections. And practice infection control, because prevention is always better than cure. And if you can prevent the infection you are most appropriately, then you are happy. And promote the immunization, because it prevents things like MDR typhoid in your practice, and that will help in avoiding this resistant infection. But what are the don'ts in antibiotics? Prescribing antibiotic when not indicated, polytherapy, using a higher antibiotic for routinely community-acquired infections, using more than one antibiotic when not indicated, like in typhoid, where people prescribe cefixime and azithro together, subtherapeutic doses and insufficient duration, changing antibiotics too frequently, or adding on instead of changing, and using irrational combinations. So in general, in short, what are the strategies in pediatric settings? Review and analyze antibiotic use after they have been prescribed, reach consensus on antibiotic use before they are prescribed, prompt initiation of antibiotic use when indicated, avoiding the use of antibiotics for conditions not due to bacteria, choice of first and second line drugs for the demonstrated or supposed bacterial etiology responsible for the disease that requires treatment, identification of proper dose and duration of antibiotic, and switch from intravenous to oral according to the patient with the disease, choice of conditions for which antibiotic prophylaxis is needed, educations like lectures, handbooks, and CMEs, formation of multidisciplinary antibiotic stewardship team, obtaining administrative and leadership support, continuous and transparent monitoring of antibiotic use, adequate use of diagnostic tests, including point of care tests, and knowledge of local resistance rates for different diagnoses and different pathogens. So I'm sure together, if we decide, we can do it. Thank you very much for patient hearing, and over to the chairperson, Dr. Shyam Kukreja.
Dr. Bakul Parekh sir, it was a wonderful talk we had, and you have explained literally everything in half an hour's time. You know, you have covered literally all the aspects of antibiotic usage, rational antibiotic use, antimicrobial stewardship planning, how we can carry out. My message to the pediatrician is use antibiotic judiciously, use only when it is really required, use in appropriate dose, use for the appropriate time, and only use when absolutely required. You know, a simple example, if we can kill a fly with a fly swat, why should we use Scud missile and Rafale aircrafts? So we have to keep the antibiotics in reserve, because in the horizon we cannot see very many molecules of antibiotics. So we have to go in for all these things. In the panel of galaxy of people are there with me, I'm going to ask each and everyone what we should do. I'll first go over to our National Vice President, Dr. Vasudev sir. Message to pediatricians about usage of antibiotics.
Thank you, Dr. Bakul, for a very nice and very educative talk. I think we have been listening to these talks for years and years. But what is important is, when would we start practicing that? When would we start following that? It's only our own inner heart. Nobody can change. By listening to these talks, I think we can just get educated. But unless we have our heart to change ourselves, nobody can change. And as Dr. Naab said, that we all know where not to use, which are viral infections, where we can avoid them. Why do we write viral fever and then still give an antibiotic? And when I asked the patient, why are you giving this amoxiclav along with it? My doctor said it's a viral infection, but this will help. The doctors themselves are not teaching and preaching the right thing. So the house has to be corrected first before we can blame the patients. And of course, in our country, the availability of antibiotics over the counter is one thing which probably is the biggest menace. And Dr. Bakul also knows, with Dr. Vijay Yevle in 2014, Dr. Shyam Kukreja was also there. We had a meeting with ICMR, and I was questioning them, why can't we stop the sale of antibiotics over the counter? And everybody was looking at each other's face, and even the Drug Controller of India could not say anything. Why can't they do it? So unless there's a will to do it, political will to do it, I think we cannot achieve. We will keep fighting with ourselves, within our group, maybe educating, criticizing, but unless there's a political will, I don't know where to get that will from, where the day will come when over-the-counter products will not be available and we will have a more rational. But till that time, whatever best we can do at our end, I think we have to give the best at our end. And yesterday, as our Nobel laureate was telling us about the sparrow which has got a drop in his beak and still wanting to extinguish the fire, I think that is the best message, that our drop of effort should continue, and whether we extinguish the fire or not, but let us continue to have our efforts, and wherever we can, we do not use it and set an example before we tell others not to do it. Thank you very much.
Thank you so much, Dr. Vasudev, sir. Now I'll go over to our most dynamic Secretary General of IAP, Dr. G.V. Baswaraj, to give a message to the pediatricians of Delhi and across India about the usage of antibiotics.
Thank you so much, Dr. R.K. Nath, sir. Indeed, it is a thought-provoking talk by our Honorable Visionary President, Dr. Bakul Jayant Pari. We have conducted so many things to make the people to aware about this antibiotic usage. But one of the message I would like to give at this stage is when not to use an antibiotic. If you can able to carry that message, I think the whole purpose of this talk will be suffice. Thank you. Thank you.
Thank you so much for your message. Now I'll go over to Dr. Jasjit Singh Bhasin. He is there in the panel to please give a message to the pediatricians of Delhi for the usage of antibiotics. When to use, when not to use. What is your message?
Thank you, Dr. Naab. Thanks for inviting me to give this opinion. Thank you, Dr. Bakul, for an excellent presentation. You squeezed a whole day symposia in less than half an hour. Excellent job done, sir. And what I have seen, my personal experience, that if you are under scrutiny or if someone else is in your peer group is likely to check your prescription, the antibiotic prescription drastically comes down. In our department, what we do in our hospital is, if you write an antibiotic, you have to justify, write the reason. What we train our residents is to give the reason why this antibiotic has been started. And it is the institutions which have to take the lead. Once the institutions takes the lead, gradually the practice percolates in the catchment area, the practitioners, and then the general practitioners. Everyone wants the patient to remain with them and want to deliver the results, which we are trying to deliver through the use of antibiotics. But if this message percolates from the institutions and in the catchment areas that antibiotic use is not required, most of your patients will respond and will do better without them. I think we'll do our job.
Thank you so much, Dr. Bhasin. Now I'll go over to Dr. Harish Pemde, our Joint Secretary Liaison, for his words of wisdom on this issue.
Thank you, and good evening, everyone. Senior persons are there. This is a very, very important topic. We did a small study, a thesis study in our hospital. Actually, various kinds of practices were there, and we found that we had a guideline from our own college, and we had guidelines from ICMR and from NCDC, but people were not following it. We found that there were some inherent difficulties in following those guidelines. So we made our own guidelines for the unit. And when we followed it, guidelines in the form of PDF, we had posters everywhere. And we found that using the guidelines doesn't deteriorate the patient. It reduces the hospital stay. It reduces the change of antibiotics later on. So whatever guidelines we make, the main guidelines according to our own culture sensitivity reports in the hospital and the institution, and follow them. It is very, very important to follow the guidelines. Just by making guidelines and making them available is not sufficient. If we follow the guidelines, certainly we get the better results. Thank you very much.
Thank you so much. So the message was very clear. If we make guidelines, we have to follow them and ensure that the juniors also follow. And now I'll go over to Dr. Sangeeta Yadav, madam. She's also there in the panel. Please give your statement about this.
Very rightly said that an antibiotic stewardship is the need of the hour, and we have been abusing azithromycin as an antiviral. Very good messages through this program which has been taken, and Dr. Shyam Kukreja has spearheaded with the support of our leaders in Central IAP. And definitely justification is required, as Dr. Bhasin has said, and we must actually look into ourselves whenever we are prescribing, whether this antibiotic is actually needed or not, because we are in for a lot of trouble, which has been spelled out.
Thank you so much.
Thank you.
Now I'll go over to Dr. Arun Wadhwa, my dear friend. about his statement on usage of antibiotics.
No, I think by now everybody has said whatever had to be said. I think most important thing would be our own peer review. And whenever we write an antibiotic, we must answer, or at least we should make a habit of writing why are we starting, like what we used to do for tuberculosis. When why are we starting this ABT? So we write why are we starting this antibiotic? And plus, of course, awareness with these chemist shops, free availability, all that Dr. Bakul has highlighted, GPs. I know these days the most bugging thing which bugs me is writing in COVID. Writing azithromycin for children, doxy for adults. So many adults have told them not to take, but they still take. So somehow it's there that they feel something preventive has to be done, and antibiotic is prevention. So somehow we have to be teaching that there's nothing like a preventive antibiotic.
Thank you so much. Now I'll go to our dynamic secretary, Dr. Smita Mishra, madam, to say some message about it.
Thank you very much, sir. That was excellent presentation, and I went word by word of it, and I really assimilated quite a lot. But then I start my statement with the question put by Dr. Pankaj Garg. Some medical legal coverage needed for not using antibiotics in a particular situation. For example, in my early days as a pediatric cardiologist registrar, one patient had LRTI, and it was supposed to be like a viral infection in a ventricular septal defect, patient with the ventricular septal defect. Patient was told not to use antibiotic, the regular treatment, and was discharged. And subsequently, patient expired. And there was a then medical legal case asking for 1 crore rupees as a compensation. So that is one part, I think, because Dr. Pankaj said so, so I thought this part I should bring to the fore.
Thank you so much. Now that we know the galaxy of panelists, they all are saying about antimicrobial stewardship and the proper and judicious use of antibiotics. Why not have a pledge-taking ceremony on this issue? And for this, I'll request my conference chairperson, Dr. Shyam Kukureja ji, to please tell us about the history of this pledge-taking ceremony and go ahead with the ceremony.
Okay. The first answer to the two questions. One is a medical legal, and the second is Dr. Vasudev's issue that there's so much widespread use, we may not be able to do anything. But he also gave the example that chidiya having pani and trying to extinguish the fire. So I think it is a sort of that. I tell you very interesting observation. In our hospital, we do not use antibiotic in watery diarrhea. No doctor uses. So as a result, what has happened? The nearby chemist in diarrhea is writing zinc also. So I think we have to percolate the message from somewhere. So this has to be there. If all of us start in watery diarrhea, giving zinc and as well as some probiotic and ORS, this combination we write just as a placebo or your probiotic, zinc and electral or maybe any ORS. I think this message will go down to the chemist, to the RMP, because we are the trend setters, the key opinion leaders. People start following us. So you cannot say because everyone is writing, so I should not be bothered about it. So I think we should be bothered and something has to start. This discussion I had with Dr. N.K. Arora when I was making the first draft. The Dr. N.K. Arora from AIMS is now in England. And he told me this, you have to start from somewhere. Don't worry about it, you start it. So this is one message. Second, regarding medical legal case. My concern is if you have a watery diarrhea and you give antibiotics, there can be a medical legal case on you because you won't be able to justify them. So it is seeing the, I think, angle from different angle. So I think it's very, very important that it is both ways. You won't be able to justify watery diarrhea and giving antibiotics because you will be writing purge rate is very high, large watery stools, and then you say I'm giving antibiotics. How will you justify? So this is this way also. Now coming to the pledge ceremony, I think I had a trial runs first in Jodhpur, then in Jaipur, and Jaipur we had a 2.5-hour session. Dr. Sanjay Gorpode, my ID secretary, was also there. We presented our 2.5-hour session. As soon as I completed, I said, let's begin with two things. One is we won't use antibiotics in watery diarrhea, and we won't use antibiotics in watery nose. If we start from here, because we have gone through a lot of rational antibiotic therapy as a big subject as a part of antimicrobial stewardship program. So we said, okay, let's start with this. And I tell you, the credit goes to Jaipur delegates, consisting of a lot of senior people like Kasliwal and a lot of other people, I'm forgetting the names. And they stood up and they said, let's doctor take pledge na कि यही ICIS करते हैं कि we won't use antibiotics, and let's start with this, with watery diarrhea and watery nose. So this is I think they started this, and credit goes to them. And after that, these images became viral on social media of pediatric growth. So this is a small story about pledge. Please unmute yourself.
Now, would you like to go about pledge ceremony, or should I carry out?
Where's Sir, Dr. Bakul Parekh?
What will be? I will give that credit to Dr. Shyam Kukreja, and he should make others take. Please.
I think it's
basically
I think this is not a different pledge. It is pledge is same as Hippocratic Oath.
Yeah.
Because in Hippocratic Oath, the essence is do no harm. First, do no harm. So by giving not giving antibiotics where it is not required, it is also the same thing. So it is not different from any Hippocratic Oath. So we'll say like this: I take pledge.
I take
pledge. I take pledge to become antimicrobial stewards from today.
To become
antimicrobial stewards from today.
That's it.
And we will not prescribe antibiotics for any watery diarrhea and watery nose.
To begin with.
Let's not give antibiotic to any watery diarrhea.
AAP also, AAP also started like they have a lot of I think posters made in the doctor's clinic for the doctor's clinic that no amount of antibiotic will treat your cold. So they have posters. I think IAP Delhi and IAP Center can make these posters, and doctors can have in their chamber so that the patient doesn't demand antibiotic.
We'll do it, sir. We'll do it.
Actually, we should incentivize the sort of prescription audit. If suppose anonymously, if you look at the prescription audit and somebody is found to be 80% correct, we should give a gold certificate of antibiotic steward, and that should be displayed in the clinic with all these posters in various languages.
And it will be real good.
Thank you so much, sir. Now, I'll put it this way to make it deeper in the mind of the delegates who are watching us. Put your right hand on your heart and just follow me and speak after me. I will practice support and disseminate antimicrobial stewardship. From today, I am antimicrobial steward.
I am antimicrobial steward.
Thank you so much.
Thank you.
Thank you. In the presence of Dr. Bakul and all the dignitaries here, this is a great ceremony which we have carried out, and it will carry a big meaning, sir. Thank you so much.
Thank you, everyone. Thank you, Dr. Bakul.
I want to make one thing, just one statement. I think this thing should be propagated every time so that it becomes into the minds of everyone. And we should also involve the general, our graduates, undergraduates, and MBBS also. Because unse pehle hi wo likh ke aate hain, so that tendency is there. We pediatrician will do it our best, but its information should go to postgraduates as well as MBBS also. Those who are general practitioners.
It can be done at a UG/PG level because they are the plastic brains. If they are trained properly, they will come out with the right ideas. So it should be included in the curriculum, and there should be at least half paper on antimicrobial stewardship.
Definitely, sir. And your program should be disseminated throughout the country, even for the MBBS and
unless until they get the certificate of antimicrobial steward, they will not be allowed to appear in the exam. So that's how the workshop should be done.
Information of everyone, Lalit. We have in IAP very good programs of RAP, WAR, PSPID, and then antimicrobial stewardship. They are very good programs.
And
I think every branch should conduct these programs.
Definitely, we will go.
And every medical college should conduct this program.
Yes,
absolutely.
Sure. It should be conducted at all levels.
Yes.
Thank you so much, Dr. Farooq sir.
Dr. Kukreja and Dr. Bakul and Dr. Savaraj are all there. In the last war meeting, if you remember, I had just requested one small thing that see, pediatricians we can train and teach. But what about the general practitioners who are the biggest, I would say, culprit?
And veterinary doctors.
Sir, Vasudev sir.
That's what
we are working out on an IMA with along with IMA. We are coming out with a module which is focused onto the general practitioners too. Bakul sir and Vijay sir is already working on it.
We are working with the IMA president.
1 to 1.5 hour module where we can train the general practitioners also, and not a very lengthy module like we have in war, but a very concise and a brief, about 1.5 hour module. So
Definitely.
that percolate down to the general practitioners.
Yeah, we are coming out with that module where will be only what to do. Only that thing will be covered, and it is about 1.5 hour module, and we are working with the incoming IMA president. So we had a meeting also already, and they have agreed.
That will be great. Great.
Thank you, sir. Thank you very much once again for coming, sparing your valuable time and being with us. You have really made our conference one of the best conference so far. Thank you so much.
Thank you, sir.
Made a difference.
Thank
you, Dr. Basaraj.
Thank you very much, sir.
Thank you. Thank you.
Thank you so much, sir.
Thank you. I thank all. Now, please,
stay on.
Dr. Gray, sir. Please, Dr. Nirupma, carry on with the further proceedings.
After antimicrobial stewardship, now we'll proceed to preventive pediatrics, that is vaccinology. Vaccinology, latest development in various vaccines except COVID vaccine. Now for this session, this is a panel discussion. Now for this, I will like to invite all the panelists. Dr. J.S. Bhasin, sir.
Dr. को फोन करना पड़ेगा. He's not around, no? यहाँ पे नहीं है मेरे ख्याल.
Yes, sir.
Is he in the attendees?
मैंने उनको फोन किया था, अभी वो फोन नहीं उठा रहे.
Yes, sir. Dr. A.K. Datta, sir, is senior consultant at Indraprasth Apollo Hospital and former director and professor and head of department pediatrics at Lady Hardinge Medical College, New Delhi. Dr. J.S. Bhasin, sir, sir is director and head of department of pediatrics at B.L. Kapoor Super Specialty Hospital. And Dr. Harish Pamde, sir, Dr. Professor Sangeeta Yadav, ma'am. Ma'am is director professor and ex-head of department in charge pediatric and adolescent endocrinology at MAMC Delhi, and joint secretary Central IAP 2018-2019 and vice president elect North Zone 2021. Dr. Harish Pemde, sir, sir is joint secretary license, and sir is professor of pediatric LHMC at Kalavati Saran Children Hospital. And now I invite our panelists to introduce our speaker, Dr. Arun Wadhwa, sir.
दत्ता को बुलाना है.
Sam calling.
उनका फोन कह रहा है रॉन्ग नंबर.
उनका फोन कह रहा है रॉन्ग नंबर जो हमें नंबर किया.
Actually, he talked to me around an hour ago. मैंने उनको बोला आधे पौने घंटे में आप ज्वाइन कर लेना. तो अब तो बहुत टाइम हो गया.
व्हाट्सएप कॉल करके देख लो. व्हाट्सएप कॉल करके देख लो, कई बार मिलता नहीं है ना.
इनको ढूंढ रहे हो?
डॉक्टर दत्ता.
रॉन्ग नंबर तो नहीं बोलना चाहिए उससे.
रॉन्ग नंबर पे अगर फॉरवर्डेड है तो फिर रॉन्ग नंबर दिखाएगा. अगर
सर एक बार मैसेज कर दीजिए ना, जो भी नंबर है, क्योंकि पहले भी तो उस पर बात हो चुकी है ना.
हाँ, अभी आधा पौना घंटा पहले बात हुई थी.
तो मैसेज कर दीजिए उस पे, वो आई थिंक कनेक्टिविटी इशू है.
नहीं तो शुरू करते हैं डॉक्टर अरुण, काफी पीछे चल रहे हैं.
चलो हमारा लास्ट है फॉर्चुनेटली.
हाँ तो सर जो है वो आके फिनिशिंग टचेस हमेशा देते हैं. सर का एक जोक आखिर में हो गई होगा.
हेलो सर, आपकी वेट कर रहे हैं, ज्वाइन करना. अच्छा या हाँ, मैं आपको फोन कर रहा इतनी देर से, वो
रॉन्ग नंबर आ रहा है.
ओके, करें ज्वाइन, बस 2 मिनट्स. ही इज देयर ओनली. डॉक्टर पेमड़े कहाँ चले गए?
वो भी यही होगा.
सर एक मीटिंग थी सर
डॉक्टर
आगे
दत्ता के घर में मैंने बात की है, सर ज्वाइन कर रहे हैं।
हाँ ठीक है, थैंक यू।
तभी बिजी था।
नहीं मैडम
तो
पहले
पेमदे तो है, डॉक्टर पेमदे तो है।
आगे
फिर आगे सर स्टार्ट करें।
Now it is coming. Now it is coming.
Okay,
welcome
good.
sir, welcome Dr. Datta sir, welcome.
Good evening, sir.
Welcome, sir.
Yes, good evening, everybody.
Good evening, sir.
सर का तबीयत
Waiting
ठीक है
for
ना?
you.
ओके
सर के जोक से शुरू करेंगे।
नहीं
लास्ट
लास्ट है ना, ये हमारा सेशन भी लास्ट है।
ठीक है, सेशन लास्ट।
सेशन तो लास्ट है, 8 बजे से एग्जीक्यूटिव बोर्ड की मीटिंग भी है।
हाँ 8 बजे तक खत्म कर लेंगे।
चलो 8 बजे तक खत्म कर देंगे और क्या।
ठीक है,
जब बोलोगे खत्म कर देंगे।
We'll start the last topic for the day. What's new in vaccines? We'll talk about other vaccines other than COVID. And I don't know, by design or default, I'm always last in the day. Maybe by this time, everybody feels that everybody must have gone. So even if nobody listens, it's fine. We'll talk about basic, bedside, and beyond as the theme of the conference is. We've done quite a few talks about basic and bedside in vaccinology. So we'll talk about beyond today. And I'm a student of vaccinology, Arun Vadva. So we'll first meet the panelists, as you have already introduced all of them, Dr. Datta, Dr. Pemde, Dr. Jayesh Bhasin, Dr. Sangeeta Yadav, and myself. I'll be the student asking the panelists some questions. So I'll request to the panelists that we have 16 questions today, and I have time of 50 minutes, approximately 3 minutes for each question. So please be brief. And these are all futuristic vaccines. We don't even know whether they'll actually come, when will they come. So we just need to know some basic points, what all pediatricians should know as basic things, what is there in store for vaccinology in future. So deep technical points are really not required. Just give basic points, what we all should need to know. So we'll start with first Dr. Datta. Sir, we know that BCG is not really a very good vaccine, and the maximum efficacy people find is 60–70%. So we need to have a better vaccine, and it's been so many years we've not had a vaccine. Is anything new boiling? Is anything new coming? And what about the new thing, recombinant BCG people are talking about? What is it? And what are the advantages over the conventional BCG we've been using for so many years now?
Thank you, Arun. Thank you, Arun. Can you hear me?
Yeah. Yes.
Okay. So let me first thank the organizer for inviting me and giving me a chance to be a panelist in this particular session. Regarding the BCG vaccination, first let me take you to a little bit basics of the BCG. Otherwise, you will not understand what recombinant BCG is. So the traditional or a conventional BCG is derived from the Mycobacterium bovis, and it acts both non-specific as well as in a specific manner. So it has got both innate immunity, it enhances, as well as adaptive immunity. And in the adaptive immunity, the traditional BCG, what it used to do is that measure histocompatibility cells type 2 and type 1. There are 2 types which are there. So you will find that the CD4 cells are being stimulated by the traditional BCG. That is the measure histocompatibility complex type 2. Now, recombination of the BCG by adding certain enzyme and special enzyme which has been added here by the Serum Institute vaccine recombinant BCG is listeriolysin from Listeria monocytogenes. There are other also enzymes which are being used, especially in Gamaleya Institute in Moscow, and the Oxford University also has prepared another recombinant vaccine. So this particular listeriolysin, once it is being added, it has been found that it not only stimulates the measure histocompatibility complex type 2, but it also enhances the measure histocompatibility complex type 1 and thereby induces CD8 cells. And this is most important, the CD8 cell enhancement is most important in the prevention of tuberculosis. And that is why this recombinant BCG development has started. Now, there have been studies on this, and especially with Serum Institute of India vaccine, the trial has been done. Like to state that there are three basic purpose for which has been started. One, it has been started just like to replace the traditional BCG, and therefore first the trial was done in adult. Phase 2 trial has been completed in South Africa and shows that it enhances CD8. Then they did the trial in the newborn infants also, and they found in the phase 2 trial it is good. Now they are waiting for the phase 3 trial. So this is so far as the replacing the traditional BCG vaccine. The second trial, which is being done now and it is under process in several places in India as well as in Bangladesh, and they are having 6,000 such subjects. In this, what they are doing is that they are trying to find out whether this recombinant BCG vaccine is going to prevent the recurrence of tuberculosis. So what they have done is that they have taken 6,000 cases of primary tuberculosis, pulmonary tuberculosis. They have excluded non-pulmonary, extrapulmonary cases. And in this pulmonary tuberculosis cases, who has completed 9 months of treatment of category 1 only. So after that, what they have done, they are following them up for a period of about 1 year right now, and then they will follow it further, whether there is recurrence of tuberculosis is occurring in those. So the second objective or hypothesis is that to prevent the recurrence of the tuberculosis, pulmonary tuberculosis. And the third way it is also being done is that this is also being just for an innate immunity. This is also being tested, or there are about 4,000 subjects which are being taken, and this study is a multicentric study in India, whether they are preventing COVID-19 through the innate immunity. And because of this immunity, innate immunity, this vaccine is now also being considered to be another bacterial vector. And on this bacterial vector, they are trying to introduce certain other virus, bacteria, parasites, as for example, RSV, HSV, then HIV vaccine, hepatitis C vaccine. All those vaccines are being trying to be produced through this vector-based vaccine as a platform. Also malaria, toxoplasmosis. So these are the different types of vaccines which are being tried. So this is in short about the recombinant vaccine, and I am sure it is going to come. It is still not being licensed, but it will be licensed very soon, maybe within a year or two.
Yes, the trials being done in Pune, they probably will be out soon. And actually this was not made by Serum Institute, it was made by VPM. That's why it's called VPM 1002, the Vaccine Project Management Institute. They have licensed it to Serum Institute, and they are doing phase 3 trials already. In fact, before the COVID came, 2-3 years ago, one large trial was being done in Greece. 2,000 adults were there, and they were being done for enhancement of immunity for older people, more than 60 years of age. So this interest was already there. Now it's suddenly become very interesting. In fact,
it has been started since 1994. Actually, this vaccine trial has been done.
GSK is also making a BCG new recombinant.
Yeah, GSK has done it long back. I just went through their the whole project.
In fact, there's one intravenous BCG also which has been tried. They feel that as soon as the newborn is born, they give intravenous BCG. In fact, inhalation BCG is also being tried because it will protect the lungs.
Most possibly, it will be only this.
Which will come soon. Yeah, recombinant will come very soon. I think within a year.
It will come very soon. The rest of the vaccines, I do not think will come.
Yes. Yeah, not so soon. Yes, that of course is that. So moving on to after BCG, we would move on to the next common vaccine which we use is the hepatitis B vaccine. And there are so many studies, not in children but older people, adults. We've seen that the third dose of hepatitis B is usually missed, and they were thinking of making a vaccine which is 1 dose or 2 dose. So they have started, this vaccine is licensed in US and they have started giving it to the older generation. It's licensed for more than 18 years. So we would ask Dr. Sangeeta, ma'am, what do you think about this vaccine? Just tell us about a little more detail about this new vaccine which has been licensed by the CDC.
Yeah, before I talk about the vaccine, I would first of all thank IUP Delhi, Dr. Naab, Dr. Smita, and Manish Gupta and the entire team for having thought of this topic. Wonderful program along with this future vaccine topic which Dr. Vadva is conducting. And I can tell you, Dr. Vadva really gave us very challenging questions and we really had to look for it. And most of it is not spelled out even in your guidebook. That is the best part. So therefore, this panel, the panelists really had to do some homework also related to this. So I looked at it and as Dr. Vadva has said, that this new vaccine is actually an adjuvanted vaccine. And that is why with the yeast-derived recombinant Hep B vaccine, which is called, got a immunostimulatory adjuvant, which is very complex. Yeah. Cytidine, phosphate, guanosine, oligodeoxynucleotide motif or 1018 adjuvant. And actually this attaches to the toll-like receptor 9, which stimulates directly the immune response to hepatitis B antigen. And as he said, it is approved for more than 18 years, a 2-dose schedule. So the advantage of this is that it will improve the coverage, it will improve the protection, it will have a higher immune responses. When they compared it with the GSK3 dose, this thing, they found that definitely the seroconversion across all the age groups, especially amongst the elderly, had come up to around 90%, which otherwise would be around 70%. And they also found that in the hyporesponsive population and who do not adhere to the vaccine series, actually it will be more useful, especially amongst the males, the smokers, the obese. So that distinct advantage has been seen, and definitely logistically also it will become more feasible and economically also more feasible because they found higher seroprotection rate amongst this population. However, the long-term antibody response and all is not yet available for this. So therefore, with this, and especially amongst the study was conducted amongst the type 2 diabetics, where they found definitely these chronic illnesses like CKD and diabetes, definitely this vaccine is superior and economically will become more feasible. That is what I wanted.
So actually the earlier vaccine wasn't so bad actually, but this one has a slightly better efficacy, but the most important advantage is that it's in 2 doses given 1 to 2 months apart. So the people taking the vaccine, the number of people taking will be definitely more, the compliance is better. And of course, in high risk comorbid conditions, it has shown better results than the previous vaccine. So we have some advantage of this over the previous one. Then coming to a very next common problem we face, we know that AP vaccines normally will not provide as long-term protection as WP, TH17, TH1, all that is there. But WP vaccines have their own disadvantages of pain, swelling, fever. Sometimes people may not take this WP vaccine as second booster or first booster because of the pain or fearful, whatever, they don't like to take that. And maybe other shortcomings like combination vaccines, IP may not be there with WP. So what are we thinking of next in the future about a good pertussis vaccine? Are we looking forward to something new coming up? Ideal pertussis vaccine. We don't have an ideal one still.
Thank you, sir. Thank you, organizers, for giving this opportunity, and thank you, Dr. Badwa, for giving really new topics to us, and we could find some new information from that. Before I reply to that, first we should find out the why do we need a new vaccine, because this is a very, very old vaccine, very much in use. Actually, we all know that pertussis is a strictly human pathogen, and clinical pertussis re-emerged few years ago. That's also we know. And there are certain shortcomings for both the vaccines, as you very well said. Actually, the little bit going in the immunity part, this is very important to understand. The wholesale vaccine and the natural disease causes an immune response, which is a type TH1 and TH17 type. Whereas the acellular pertussis vaccine causes an immune response, which is a TH2 type. This is the basic difference in both the vaccine, and that is how they provide the protection. So it results if we get a disease or WP vaccine, then this limits to some extent the colonization of the bacteria in vaccinated people. But people who are vaccinated by acellular pertussis, this colonization continues to occur. So with both the vaccinee is protected perfectly, but those who receive acellular pertussis vaccine, they can continue to infect others. Okay. So that is the reason we are looking for a new vaccine which can have effect of both the wholesale as well as acellular pertussis vaccine, because we need to prevent both disease as well as its transmission. So what various things have been tried or being tried? We do not use wholesale pertussis vaccine because of its toxicity. That is the main reason for using acellular pertussis vaccine. The toxicity is mainly because of this lipopolysaccharide component of the cell wall. Okay? So people have tried to chemically extract, make it inactivated using some chemicals, and reduce this lipopolysaccharide levels in the wholesale pertussis vaccine by 80%. So thus this will reduce the side effect or toxicity of the vaccine. So this new vaccine will be as good as acellular pertussis vaccine as far as side effects are concerned. Then probably we get benefit of wholesale vaccine. So this is a good news that which may come in some time. Another methods which are being used are to develop a new acellular pertussis vaccine. So that one method is they are putting some new adjuvant, they are putting some new antigens in this acellular pertussis vaccine. Basically, three or four things are being attempted. One, they are making the live attenuated pertussis vaccine. Another is outer membrane vesicle pertussis vaccine, or genetically modified vaccine, and adding some new adjuvants also make some changes in these vaccines. First, about live attenuated pertussis vaccine. This vaccine has been developed from the B. pertussis from Tohama 1 strain, and which has all three important virulence factors. And this requires a single intranasal dose immunization with BPZE1, and this effectively colonizes the respiratory tract. So with the wholesale vaccine, we get immunity which is systemic. With this vaccine, we get systemic as well as local immunity. So after giving the single intranasal
so this is
dose,
probably the most promising you're looking at, BPZ.
Yes. So immunity is there in the mucosal immunity also developed.
Also will be prevented.
Yes, there is some immunity in the lungs also. So when this vaccine will come and will be registered, this will be most promising one. Another one is outer membrane vesicle vaccine. This is a very, very new thing which happens in this bacteria.
Like meningitis B, they are using this.
Yes, yes. Outer membrane vesicles are spherical structures which are derived from the cellular envelope of the gram-negative bacteria. This also contains various antigens of this bacteria. So using that, vaccines are being made. And this vaccine will respond in a human person will respond for a mixed TH1, TH2, and TH17 response. So this has benefits of both acellular as well as wholesale vaccines. A human response will be like both the things. And another AP vaccine is coming with a new antigen, that is adenylate cyclase toxin to AP vaccine is being added. So this becomes highly effective after that. And certain new adjuvants are being tried, so that response becomes some TH1 type also. So this delivery of pertussis vaccine by intranasal route has been the potential to enhance the local immune response in the nasopharynx and may provide a solution to the problem of asymptomatic colonization, and it can reduce the transmission of bacillus pertussis. So that is a very, very important thing, and we look forward to have this intranasal vaccine.
In fact, there's very interesting theory, although not proven in humans, it has been proven in baboon and mouse models, that when you add IPV to DTAP, it also gives a response towards more TH17, TH2 rather than only TH2. So, you know, TH17 is stimulated by adding IPV itself to DTAP. So this combination itself works something like a DTWP WP vaccine. Last year, I'd gone to some conference, and there they had launched this recombinant vaccine. I'd taken a photograph. I thought I'll share with everybody. This is a single. That's not a combination with HIV or diphtheria or anything else. It's only a standalone AP recombinant vaccine. But I found it very interesting, so I took the photograph of that box. This was last year, September 2019. Looks like ages ago, but it was only last year.
But how do we use it?
It is a recombinant vaccine. This one has been licensed only for 10 years plus. As of now, it is used only in Indonesia and Vietnam and Malaysia. I think not even Malaysia. Indonesia has been used. So
I just wanted to know, add on, what is the seroconversion rate? Because our whole issue was that our seroconversion rate with the existing pertussis vaccines were only 70%, and that too a lot of waning was there very fast. That's why we had to go for DPT at 5 years and then later on also. So I just wanted to know what is the seroconversion rate.
These are under development, and still some studies have to occur. Then only the license will be there. So at least I don't know the answer to this question.
The nasal vaccine is showing very good promise, and the seroconversion rates are more than 90%. Best is it gives you local immunity in the nose as well as the respiratory tract. And that is the one which probably will come soon, maybe 2-3 years down the line. Soon means it is under phase 3 trial only now. And phase 3 has to be a large, it is the longest and the most expensive trial ever, all phase 3 trials. So we'll move on to the next vaccine, IPV. IPV, all know we have to give IPV to all children. It is the only 3-component vaccine. Oral polio does not have 3 components. We have to protect against 2. There's a shortage of IPV. We cannot make IPV in our country because IPV would need BSL-4 prevention facilities, which we are not able to provide. BSL-4 is base biosafety level 4 is the polio virus. So there is an option which is called the Sabin IPV. The other IPV which we have is a Salk IPV, and we have a Sabin IPV. This Sabin IPV has been in use in China and Japan, and we do need to get this IPV, if not the other Salk IPV. This is easier to produce, less. So we'll talk about this IPV. I think Dr. Bhasin is left. He should tell us about this Sabin IPV. Dr. Bhasin, please.
Yeah. Thank you, Dr. Arun. And thanks for putting me in the distinguished company of director professors. Since I'm not a professor, I will try to stick to my time and speak within 3 minutes allotted.
Thank you.
So you did part of my job by telling what exactly we are going to talk about. We all know that initially oral polio vaccine was used, but because of now after 2000, the vaccine-derived polio virus cases are more than the wild virus cases. So the need to shift to the injectable polio. Sabin IPV is your SIPV, and the IPV which we have presently is known as the classical or the Salk IPV. So Salk and Sabin, they have been going off and on.
Which this one they call CIPV, so that both of them not S.
Yeah, so classical IPV is Sabin IPV, which is the inactivated. Now we have the Sabin inactivated vaccine, which is from the same strains where you have the oral Sabin vaccine. The problem with Salk vaccine was that you need, as you yourself mentioned, very strict laboratories and where you can manufacture. The cost of manufacturing is more, as well as the risk of the disease wild virus spreading from these containment areas was very high. So the vaccine itself has been available right since 1980, but it has not been in use. In 2012, Japan was the first country where they developed this Sabin IPV along with different DPT antigens as a combination vaccines. But again, that was never used. In 2015, China had 2 vaccines which were licensed for use as a standalone Sabin vaccines. Of these, one vaccine has been approved by the WHO Expert Organizing Committee, and this will come out as the standalone first Sabin IPV. The problem with the Sabin IPV was that we had to conduct enough trials, which for the Salk vaccine were conducted in vero cells Now that was also a costly affair. So the animal studies, the phase 2 studies needed to be done in primates before they could be done in humans. So all those factors led to the delay, but finally a vaccine has been approved, which is not yet for commercial use. How soon we are going to get it, we don't know. But the dosage is going to be exactly the same, 0.5 ml, day 0, 30 and 60, and a booster after 1 year. So it will be a 4 days. There have been non-inferiority trials comparing this vaccine with the classical IPV, and it has found to be equally effective and safe vaccine. So this is a good news, because once this is approved and is freely available, countries which do not have the facility to store the Salk vaccine, which is manufactured from the live vaccine, they will be able to produce from the attenuated strains of the oral vaccine. So storage capacity, the constraints, the logistics will be better, and it will be more freely available. And this is the way forward. And we all hope that this will soon be available for regular use.
Very good. Thank you. I think you explained very well why Sabin can be manufactured in our country, why Sal cannot be manufactured in our country. And another good advantage of Sabin IPV will be because, the oral polio vaccine is the one which leads to CDVPV. And when you have vaccine-derived polio virus, that's actually a Sabin virus because it's derived from the oral polio. And this SIPV has been found to be more effective against preventing these CVDPVs, because the virus strain is the same. So the efficacy against CVDPV is better as compared to wild polio virus, but this is what we need. And the good news is that DRL, Dr. Reddy's laboratory, has already tied up with the Chinese company, and we might get this soon in our country before the end of 2021. So we'll probably end the shortage of IPV very soon.
Hopefully, yes. Yeah.
So what is this question is done. Then a very common typhoid vaccine. Don't worry, I'm not going to ask whether boosters are required or not. Dr. Datta, we can come back to you. Why are we not able to make a trivalent, tetravalent typhoid vaccine, which includes paratyphoid A, B, C? And why is it taking so much time? This typhoid came in 2013, and it's already 7 years. We have been telling everybody, every other meeting, that this is coming, this is coming. It's been 7 years. We haven't been able to make this.
Before I come to the typhoid vaccine, I just want to add one point so far as the polio vaccine is concerned. Okay.
Yes.
Now, there is another strain, hyper attenuated oral type 2 S59 strain, which has been developed, and it is being used to tackle the CVDPP outbreaks in several countries of the world now. You know that this year already, I think more than 700 cases of CVDPP type 2 has already occurred, compared to last year, which was in, I think, 200 or something like that. So to tackle that, this hyper attenuated type 2 strain has been developed. So this is just for your information, and it is already there. And Government of India has also asked WHO that they should give a stockpile of this particular strain if there is in case of emergency use. Now, coming to the typhoid vaccine, why we are not able to make trivalent? It is not that we are not able to make trivalent or tetravalent or bivalent typhoid vaccine. It depends upon the market. The market, if they want trivalent or tetravalent, because this is a problem basically of developing countries of the world. And that is why typhoid is the most common, followed by paratyphi A. Paratyphi B and C is very, very uncommon. And in countries like in India, especially non-typhoid salmonellosis is much less compared to African countries. So that is
Southeast Asia, NTH is quite high.
Yes. So we'll be making, definitely there are in the pipeline, a bivalent vaccine pipeline is already there in India. The biological events is already trying to manufacture Salmonella typhi with paratyphi A. And in the world, there are several other candidate vaccines which are there, which includes paratyphi A, B, Salmonella typhi, as well as Salmonella typhi and plus non-typhoid 2 Salmonella enteritis as well as Salmonella typhimurium. So these are in the process in the pipeline. In fact, not only this trivalent as well as they are trying to make a further oral, more modified and more potent oral typhoid vaccine, which is also in the pipeline. So we do not know when it will come, but these are in the process.
There's another point also, sir, that paratyphoid A does not have the VI antigen. So, the typhoid vaccine has the VI antigen and this does not have. So they have to have something common between paratyphoid and typhoid to make a common vaccine. VI antigen sharing is not there with paratyphoid.
It has to be a different, but combination of the vaccine is possible. Combination of vaccine is possible. It is not the same typhoid. VI antigen is there, but this VI antigen is not structurally similar to typhoid Salmonella typhi. Structurally similar VI antigen is similar with Salmonella typhi as well as Salmonella paratyphi C, not with paratyphi B.
Yeah, so C is very similar. So they can make C, but C is not so prevalent.
That is what I'm telling. So it is not that VI polysaccharide is not existing. It is existing, but it is not structurally and immunologically similar as Salmonella typhi. So you will require a VI antigen only of Salmonella paratyphi also, but only paratyphi C is structurally absolutely similar. And to come to your next question, I'm sure.
Fronday is also similar. So I wanted to ask you, what is this new vaccine? Does it have any advantage?
Yes. So there is a new vaccine which has been developed by biological events. And in this new vaccine, what is the difference? They have taken VI polysaccharide from another organism.
C. fronday.
This polysaccharide, VI polysaccharide, they have taken from Citrobacter frondae. Now, Citrobacter frondae is a common cell which is usually a soil bacteria, and it helps in the nitrogen, you can say, in the environment, nitrogen metabolism in the
nitrate to nitrite it converts actually.
Nitrite to nitrate conversion, it helps. Now this is a common cell in human being as well as in animals, and in the human beings it is not causing in a healthy individual any disease. Structurally as well as immunologically, there are 3 VI polysaccharide which are absolutely similar. One is S. typhi, one is S. paratyphi C, and Salmonella dublin. So these as well as Citrobacter frondae.
So just tell us please if there are any advantages of this.
I'm just going to tell.
Because we have a talk on frondae 2 days from now.
Acha, you have another.
In this PCNI only there's a talk.
Advantage is that this particular vaccine, they have added, that is the conjugation is being done with CRM197. CRM197 is slightly better as a conjugate protein compared to the tetanus toxoid or diphtheria, because it is non-toxic is also there, and it does not require any deactivation by formaldehyde. So this is how it is really a little bit
less side effects maybe
over tetanus toxoid. Now, other advantages, so far as the advantage is there, it is not going to create any problems because it is a biosafety level 1 organism compared to the biosafety level 3 organism, which is Salmonella typhi. So in the manufacturing process, there will be no hurdle. So far as the environment is concerned, there is no problem of any environmental contamination. So these are the advantages of this particular vaccine.
Yes, I think we'll talk about this on Saturday 4 to 5. There's a talk on 2,
If
3.
you are already talking, you are talking from 4 to 5 on this?
No, not 4 to 5. Mine is only 15 minutes. Dr. Shyam Kupreja is also there. There's a 2 topics on typhoid.
Okay, fine.
Then we'll go back to Dr. Sangeeta Yadav and ask her about the influenza vaccine. We know that influenza vaccine has to be given every year, and people are not interested in giving influenza vaccine 90 times in their lifetime. So we have to have a vaccine which works for at least 10 years, 5 years, or best would be once in a lifetime. So what about this universal influenza vaccine? When do you think it should come? And tell us something new, which is technologies which are being developed, like the patch, influenza patch, or tablets or something which is coming up soon.
Okay. First of all, I would address what is universal influenza vaccine. That is most important to understand, because so far we have been having strain specific, or we are having some subtype specific, whether it is type H1, or sometimes we have multiple types with H1, H5 and all. And universal influenza vaccine is actually including both group 1 and 2 of influenza A, and it may include influenza B also. So the universal flu vaccine which we want should be at least 75% effective, protect against both group 1 and 2 influenza A viruses, have durable protection, and should be suitable for all age groups. That's what. So far we're working on pandemic potential vaccines and seasonal, but the universal influenza vaccine, we need long-term seasonal prevention, long-term pandemic prevention, and zoonotic prevention. And as you have said earlier, that these people, there is low coverage, low take of this vaccine because one has to take it every year, and people do not want to take this vaccine again and again. And also it has economic and logistic challenges.
So it should have
So
a
the
broader
new
coverage and
vaccines,
a long-lasting effect. That's what these two
yeah.
should be there.
And the other thing is the newer technologies which they want are so that we can have something which has a longer term protection, which will cover everything. So there are a whole lot of these vaccines which are being developed in relation to whether we can have a DNA type of vaccine, whether we can have a viral vector vaccine, or we can have virus-like particles which can be used for making this vaccine. And all these will be useful for having longer duration of protection and better coverage for covering the various groups of vaccine. And also they want neuro technology related to the intradermal micro-injection delivery system, which can be used for the elderly as well as for the children. So these are the few neuro technologies which they want to come up for the flu vaccines. And I do not know when they are likely to come up, because we all know that there is a live attenuated nasal vaccine, the nasal spray vaccine is available, but again, it has been used. Serum Institute was using it. We have all used it sometimes when they had brought it into the market. So that is what is about the influenza vaccine.
Yeah, I think this 2020 year will go down as a breakthrough year in vaccine technology. Soon we'll have all these mRNA and smaller technologies, nanoparticle technology coming up for all these vaccines, and development also will be faster. Hopefully it should help. Corona.
Actually, COVID is taking away everything, and therefore everything else has become backseat.
Yeah, but these new technologies will come in helpful for these other vaccines also, probably. So then we move on to, I think now it's Dr. Pemre's turn again. And sir, in short, because you also have to attend the executive board meeting at 8, please tell us in short about these new rabies monoclonal antibodies which are there. What are the advantages, disadvantages of both the two monoclonal antibodies?
Thank you, Dr. Badwa. First, I should acknowledge Dr. Anurag Agrawal. He has helped me in framing the answer to this question. Sangeeta Yadav is a witness. He always complains. So see, we have two types of...
And he's doing a study also.
Yes, yes. So we have these two types of monoclonal antibodies. One is human and another is a murine monoclonal antibody. First thing is that we must use these HRIG or monoclonal antibodies whenever it is required, and whatever is available, we must use. This is one. When both are available, then we can choose one over the other. So the human one has some advantages, like its dose is less, it is very advanced one, and very safe to use. It is not immunogenic. It can be used if the same thing or similar thing has been used earlier also. It doesn't cause any antibodies against those things. Serum sickness-like illnesses are not there. But it is a monovalent only, against only one particular antigen of this virus it acts against. Whereas this murine one, as its name suggests, it acts against two viruses. Okay, so if some different strain is there, then also it is very, very useful, but certainly it has got some disadvantages also.
Two epitopes of the same virus.
Two epitopes of the same viruses. Two epitopes of the same virus, yes, you are very correct. But I wanted to discuss and that I just have a chance to go through another new development about it. It's animal studies only. What they did, they tried some monoclonal antibodies, which is RBC20 and RBC58, in the rabid animals. And they gave these monoclonal antibodies at the site of infection and in the brain. They found that there is some improvement. The animals were rabies free after some time. So there is some hope that these antibodies are used even for a patient who has developed rabies. So this is just something new which is being developed. So we hope to get this thing also, so we can save those patients who has developed rabies, and rabies may not be 100% fatal disease. Thank you.
If used early, maybe it will help.
Yes.
So in short, we can use either one of them. The most important carry-home message Sir has given is that you have to use these in all category 3 bites. Also in category 2 bites, if the patient is immunocompromised, the most important thing is to give the body antibodies. Which one you give depends on you, whatever is available. The volume-wise, I think the wound is very small and you want to give only local, then probably the human one, the volume
Human one is better.
Otherwise, either one, but important thing is to use something, please. The differences are not much major. Use something. Don't let the patient go away without taking a local injection. Good. So then another scourge, Dr. Bhasin, it's your turn now. It's the malaria. Fortunately, we see less of malaria now these days in Delhi, but all over India still there is a huge amount of malaria. And there was a malaria vaccine which was launched with much fanfare. We had so many messages, WHO launches malaria vaccine. But how do you feel how much is the effectiveness? I mean, what do you think about the vaccine? Dr. Bhasin, you're muted.
Okay, sorry. Thank you.
Thank you.
The vaccine was definitely launched last year with much fanfare, but it was used specifically in 3, say, African countries, Ghana, Kenya, and Malawi. And the results which they received there, this vaccine was the RTS malaria vaccine, also known as the Mosquirix.
Yes, as the Rix word says, it's GSK vaccine.
Yeah, so Mosquirix, it is a GSK vaccine. And it was, initially there was a lot of hype about it, but if you see in detail, this vaccine is to be given it was supposed to cause less clinical malaria, less severe malaria, 30% less, anemia almost 60% less, fewer cases of those affected needing blood transfusions. So severe malaria was definitely less. But when they analyzed in detail, what they found was the age group which is most vulnerable was the one which had the equivocal results. When this vaccine was given to children less than 1 year, the effectiveness was not that much. Children of the age group more than 17 months, they had the best results. So this particular vaccine is acting at the sporocyte part of the cycle of the malaria before it enters the hepatocytes. Then you have in the malarial cycle, you have your merocytes released, which enter the red blood cells. Then you have the gametocytes, which is ingested by the mosquito. And then you have again sporocytes generated in the mosquito. So there are at least 11 or 12 other vaccines which are being developed. This was licensed, but the effectiveness is very limited. And in the age group which is most vulnerable, it was not found to provide enough protection. So if you are trying to look at the population more than 2 years, it will provide about, say, 50 to 60% protection. But as in most of the pediatrics, when you are talking about hepatitis or typhoid, preventive measures are always more economical rather than going for such expensive vaccine programs with doubtful, say, efficacy. So I don't think we can expect it soon in our country. We would rather have a dengue vaccine, which is, I think, more likely
to
provide us more relief.
Yes. No, I think this is not the actual vaccine, malaria vaccine we were all waiting for. The efficacy is not beyond 50-60% and wanes off also very fast. Within a year, the vaccine efficacy goes off.
You need 4 doses.
Below 3-4 months of age. So there are lots of issues here. within a year you need a booster. How many boosters can you keep giving every year? So this is not the vaccine we are waiting, but actually, okay, there's something there which for countries where African countries where it's absolutely rampant, something can be done, but we need a better vaccine than this. And
they felt that this was too premature to announce the hype around it because it was in a very limited area and the effectiveness in a highly endemic area. So plus they found that the incidence of meningitis among those who had been vaccinated was almost 10 times higher than those who were not vaccinated. So that is another serious problem. So I don't think this vaccine is going to come anywhere soon, or we'll have.
From the learnings of this this launch, probably we'll learn more and get a better vaccine soon.
Yeah.
Okay, then before we go on to dengue vaccine, we'll go back to Dr. Datta. You know, actually, I purposely going by rotation, everybody gets rest in between. So I wanted to know about this rotavirus vaccine, because rotavirus vaccine, as you know, in developing countries, it's the efficacy is only around 54, 56%. Whatever it's made in India, made abroad. The broad vaccines, which in Western world gave 90% plus, here again, they dropped down to 56, 58%. So we need to develop some other vaccine which is better. And you know, after polio, injectable polio came and we found it was better. So we always started thinking rotavirus also can be made from oral to injectable. So what are we doing for this? When can we expect a injectable rota vaccine? And a few lines about the neonatal rotavirus vaccine.
This rotavirus vaccine, there are several in pipeline. One such vaccine, which is a non-replicating parenteral rotavirus vaccine, which is developed by PATH in collaboration with SK Laboratories, which are the business partner or commercial partner in South Korea. So they have developed this particular vaccine with a P8 strain, and then there are they have developed another trivalent strain with P4, P6, and P8 strains. They have done a phase 2 trial, and they have found that it is a very good vaccine, giving rise to more than 80% so far, the protective efficacy. But ultimately, the time will tell when, because the efficacy or effectiveness will tell you whether how much it is effective, and especially how much it is preventing the severe form of rotavirus infection. Because rotavirus, just by immunogenicity, you cannot tell that whether it is going to do.
Effectiveness is the most important.
Effectiveness is very, very important. So it is too early to tell. The neonatal.
It's already been licensed in Indonesia, isn't it? I read somewhere that.
No, it is still not being licensed anywhere.
Biopharma, Indonesia, I read somewhere. Let's see. Okay.
It is still not licensed so far. This is what is I got through. But there is a Serum Institute of India is also developing one such vaccine, but with the help of CDC. But this vaccine, they have undergone only the animal studies. Even they have not started the human. So they are yet to start this study, and I am sure this vaccine will take some more time to come into the market. This is what
studies means another 3-4 years minimum.
Yes, at least 3-4 years will require, and it is actually they are trying to mix it with pentavalent vaccine also, with hexavalent vaccine also, and different combination, permutation and combination. They are trying to make it so that it is being given at 6 weeks, 10 weeks, and 14 weeks, or 6 months along with that. And another
neonatal rotavirus vaccine.
Neonatal rotavirus vaccine is a good vaccine. There is already it is there in oral neonatal rotavirus vaccine, which is already being produced by our Bharat Biotech, and it is as good as any other vaccine.
So the new one is given rotavirus vaccine.
Yes.
Okay, good. So thank you, sir. Then we'll, I thought, we'll go back to dengue again. Like Dr. Prasin was saying, we'll ask Dr. Sangeeta Yadav about this. The dengue vaccine has been around for some time. It's been licensed in 6 countries across the world. Our patients also keep asking, sir, when are we giving this dengue vaccine? This year nobody asked, but till last year everybody was asking. So why not in India? And there's some problem. If there is some problem, can we have another better vaccine soon?
Yeah. We all know that this vaccine was licensed for use in 2015, and the trials were conducted in our country as well. And basically it was approved for children more than from 9 years onwards till 45 years. And this was to be launched last year in November 2019. However, it has not been launched in this country. And for the simple reason that it is definitely a good vaccine, and the schedule was 3-dose schedule, and it was supposed to have very good efficacy against the severe disease in dengue positive individuals. But what happened was that in seronegative individuals, it increased the risk of developing severe dengue disease. Therefore, it was not being launched, and now people are actually working on possibility of a better dengue vaccine, because we all know that there are 4 serotypes. And there is actually what happens is that therefore it is challenging, and they found that there is something called antibody dependent enhancement, which induces the pre-existing antibodies against dengue, which creates an obstacle for vaccine development, since neutralizing antibodies need to be generated to all the serotypes of dengue to confer the protection. So there are many vaccines which are underway, and these are actually the DNA vaccines and all these vaccines, so that they can have some adjuvants which can facilitate this antibody dependent enhancement and all these better affinity. And there are different types of live attenuated vaccines and viral vector vaccines, subunit vaccines, DNA vaccines. They are all in pipeline, and some of them are actually in the phase 3 trial also. And
the vaccine, I think
that is,
yes, that is the one which is highly hyped now.
Which one? Chimeric?
Takeda.
Yeah, that is the one which has come up, which was earlier in phase 2, and now it is available. And so these are some of the issues, and these we know that we are not able to get all vaccines, but there is a reason also to it, that they found that this antibody dependent enhancement has actually been observed for various other viruses also, like HIV, SARS-CoV-2. So therefore we have not been able to be very successful towards these vaccines. So people are working on adjuvants and to improve the immune responses. That's what I wanted.
I think AD was the first time we heard about AD was when dengue vaccine came. Before that, we were aware of this phenomenon. And in simple words, we can say that suppose the child is not having dengue antibodies and you give the live vaccine. This Denvexia is actually a live vaccine, and it's given in 3 doses, 0, 6 months, and 12 months. So during this period, or after the vaccine developed, after you've given the vaccine, the patient produces antibodies which are neutralizing and the non-neutralizing antibodies, and you get dengue fever after that. Then the AD comes in and they get a severe episode. It's like we say that dengue fever second time, third time is more severe. So it's like when you give a live vaccine, when you get dengue fever, it becomes more severe. So that's how. And actually, even I think type 2, 3, which are common in India, it was providing only 60%, 68% for type 3. So it wasn't really, one is happy when it is more than 90%.
Actually, this trial was conducted from our institution only. Dr. Dubey had done, Dr. Jugesh Chatwal, they are all done. But it was actually approved for children more than 9 years till 45 years. That's what it was.
So coming to a very simple disease, HFMD.
Can I just add one thing in the dengue vaccine, please?
Yeah. Yes, sir. Yes, sir, please.
Now this Sanofi has come out with a combo pack where they are doing even the antibody test simultaneously. You can do it.
First you do the test and then the vaccine.
Then you are giving the vaccine. So this combo pack of vaccine plus antibody is being tested, and then you are giving. This is already, it's in use.
Yes. Thank you, sir. Thank you for the added information. No, I read it. I forgot. Okay. So what about this very common disease, HFMD? Do we actually need a vaccine for this? Although there's a licensed vaccine already, but people may not be aware, but there's a licensed vaccine for HFMD which is available.
Yes, sir. Yes, sir. So,
but
see,
HFMD
okay, sorry.
Not a life-threatening disease.
Yes. HFMD is definitely a disease, and I must tell you that when I was doing MD, we had a severe outbreak in Gwalior. Many patients of AFP polio-like illness was there, Some deaths were also there, and we found that this was the Coxsackie virus which caused this. So this also disease is caused by enteroviruses. Coxsackie virus is there, and we must. And this is also very prevalent in various parts of the country, Leh, Nagpur, and from everywhere. Outbreaks have been reported. Okay. About the vaccine, about the strain from India, it's actually the CVA16 and CVA6 are the main strains. In China, it is CVE71. It is EVA71 strain which is there in China. This vaccine has been made in China, licensed in China, but it contains monovalent vaccine for this A71. But we do not have this strain in our country. We need a vaccine which contains this CVA16 and CVA6. And this trivalent vaccine is under development. And whenever this vaccine comes to is licensed, maybe we can have this vaccine which may be effective against this disease in India. The Chinese vaccine is not of any use in our country.
Okay, so that means we should wait for a vaccine which is multivalent, which is effective against the enterovirus and the 2-3 Coxsackie viruses which we see in our country, the 6, 10, and 17. Those ones.
Yes.
And enterovirus also.
16 and 6. Yes.
So in short, we should remember that we should wait for a multivalent vaccine which is effective against entero and Coxsackie both.
Definitely.
Then another vaccine which is already licensed and it has been licensed by WHO is the hepatitis C vaccine, which most of us may not be aware. So please tell us more about this, Dr. Bhasin. It's your turn now.
Thanks again, Dr. Arun. Hepatitis E vaccine has been manufactured and licensed for use in China. Actually, there are two types of vaccines. Since hepatitis E is another virus which is spread through the fecal-oral route. So there are two vaccines. One is the E. coli derived, which is the Chinese vaccine, which they claim that after 3 doses, close to 100% seroconversion is there. The other vaccine is the baculovirus derived, which is the, I think, Belgian vaccine, SmithKline probably. That is also in market, but there are efficacy as well as safety concerns about both the vaccines. So what WHO recommends is it can be used in specific areas, targeted use, but not for routine use in any national immunization programs. And even in the Chinese vaccine, the E. coli derived vaccine, which is known as the Hecolin Innovax, it is to be used basically in 16 to 65 years. So most of the children, you are not going to vaccinate. And then there are safety concerns about vaccinating those who are more than 65 years, those who are pregnant. On one hand, they say pregnancy is a high risk. On the other hand, pregnant women are more prone to the adverse effects. So
pregnancy is worst in pregnancy.
Yeah. So use in a specific endemic area where there is a likelihood of an epidemic or something, that is only where it can be used. We don't expect this vaccine to be available as a part of a national program, or maybe it will be available for routine use through the private sources. But again, as I am saying, most of the vaccines which we are talking about, which are for waterborne diseases, if our country can invest on safe water supply, we don't need these vaccines as in the developed countries. And our country has demonstrated during this COVID epidemic that we can shut down the country for 3.5 months, more than the developed world, suffer 26.5% GDP loss. We have the capacity to do that, but we cannot supply safe water. If that is the priority with the government, you don't need all these vaccines and all this much investment.
Very well said, sir. So that means hepatitis A, E, typhoid, paratyphoid can all stop being given.
Yeah. You don't need really these vaccines like developed countries.
And in the hepatitis E also, there's the same problem. It's in 4 types, 1, 2, 3, 4. And 4 is what is prevalent in China, 1 is prevalent in Europe, 2 is in Africa. So you have to have a multivalent vaccine before it can be made as a universal hepatitis E vaccine. And best would be if we can have a combination of A and E. That will come even later. So long way to go still.
Long way to go.
Yes, so I think this is the last round. Dr. Datta sir, your turn. Tell us about the RSV vaccine. You know, this is one of the vaccines which we might see very soon. And if COVID hadn't come, probably would have seen in 2022 only the RSV vaccine would have come. And what are something about this? When do you think it is expected? It's given to pregnant ladies before term. So it's not basically a pediatric vaccine. It's given to mothers, expectant mothers. Dr. Datta sir, it's your turn.
Mute pe hai, sir.
Sorry, mute pe tha. So, RSV, respiratory syncytial virus, is a very important disease. It is not only, please remember that in infancy it causes bronchiolitis, but in older patients, older individuals, especially between 60 to 80 years, it causes havoc again. And there are about 3 million cases of RSV which occurs every year. And in USA itself, it has been recorded that 177,000 cases of RSV occurs, and there are about 17,000 deaths every year occurring in USA itself. In US company itself, Novavax was the first one to start developing this particular vaccine. And in 2016, a phase 3 trial was done with Novavax RSV vaccine. It is a subunit vaccine. And this particular vaccine trial which was done, it found that in older individuals 60 to 80, only 30% efficacy, and there was a lot of setback is there. Two other companies, that is GSK as well as Sanofi, both are in the process of manufacturing, and both are in advanced levels phase 2 studies which are going on. So far as the GSK vaccine is concerned, they are doing a subunit vaccine pre-fusion protein, known as PF protein. With that, they are trying to find out this particular vaccine, and they have done a trial and doing trial on pregnancy as well as older 60 to 80 years. So this is what is the GSK vaccine is doing. Now coming to the other vaccine, that is which is Sanofi Pasteur vaccine. They have two types of vaccine. One is the subunit vaccine, which is again containing the fusion protein, glycoprotein, and matrix protein. That is F protein, G protein, M protein. These are the three proteins as a subunit vaccine they are manufacturing. They are using it at two adult types of vaccine. That is, one is for pregnant. Giving pregnancy, it will ultimately, idea is that in the first few months, the baby should be protected. And older individuals, 60 to 80 years, again, the risk of RSV can cause death, pneumonia, and that is why it has to be given. And all immunocompromised, it is very, very important. And Sanofi is again doing another live intranasal vaccine. They are developing live intranasal vaccine for children, and they will be giving already the phase 2 study has been completed. They have given from 6 months till 18 months of age, and the result is very, very encouraging. Now phase 3 trial is going to take place in maybe another 2 years time. It will take minimum 2 years time for this vaccine to come back. And Novavax is again restarting their whole vaccine, which after that fallout or setback which had occurred in their phase 3 trial, again, they have been asked that you restart the right from phase 1, phase 2, phase 3 with a new preparation. So this is what is the state of RSV vaccine at this time. There has been another trial which has been done in adults by the Sanofi one. That is, they have done along with the influenza vaccine, because usually the RSV and influenza, the season is almost the same. And you will have to give almost every year this vaccine. RSV vaccine, the duration of immunity will not be a long one. It will be like the influenza flu vaccine, and you will have to give every year. So they have found that you can easily give it in the same time in a different site with flu vaccine. So this is the status so far as the RSV vaccine is concerned.
Very informative, sir. In fact, I think everybody would have benefited knowing about RSV vaccine in the horizon. So we'll move on to one more vaccine, which everybody says, why does it not come? Why is this not still there in the pipeline? It's been 30, 40 years, people have been investigating. This is the HIV vaccine. And it's a very deadly disease. We know it's a very prevalent disease. And what is keeping us away from an effective vaccine development for HIV? Dr. Sangeeta, please. Thank you.
Yeah. We all know that the HIV vaccine has been elusive and it has been challenging, and the virus is such that it escapes and it evades because it mutates very rapidly. And the structure of the virus is such that it has become very difficult to have a vaccine, even though a lot of different technologies and types were envisaged and worked on. Like they thought, okay, let us have pox virus vectors to make this vaccine. Then they also thought of the DNA vaccines to be, so that we might come up with some potent vaccine. Then they thought, let us use it on adenovectors. Let us try the subunit proteins. So nothing actually works with that model of that of the HIV virus. And so therefore it has become difficult, plus it multiplies, it mutates.
Like
so we
target.
did have
Target
these,
keeps moving, so where do you shoot?
so therefore they did come up with one vaccine which was tried in RV144 in this place, Thailand. But it didn't give a very good response. Only 30% efficacy was there, which they had tried out. So far, we have not reached anywhere near the HIV vaccine. And then they thought, why not use that new terminology, that is using the broadly neutralizing antibodies. They can stop the HIV strains from infecting the human cells in the laboratory. And there are some people who actually produce these broadly neutralizing antibodies, and these can be used for protection against the HIV. So that is now the recent concept, that we can start working on that, some novel design to make the vaccine candidates. That's what
it's one of those diseases where we might get a therapeutic vaccine first before the preventive comes. You know, it's like not only a moving target. As soon as the virus enters the body, it paralyzes the immune system. You know, so that vaccine may not work. And because they haven't been able to find an animal model for this, so there are lots of issues. People just say casually, "Arey HIV ki vaccine ab tak bani nahi hai, corona ki kaise bana denge?" So it's actually both are different viruses, both are different things, but they behave
their behaviors are different.
Yes, so. Yes, so we can't compare.
Yeah.
Thank you, ma'am. That was really good, informative. And then as we keep comparing, Ebola vaccine was the fastest vaccine to be developed ever till now. It took 5.5 years, and we are now expecting a vaccine to come within 1 year. Till now, Ebola had the record. The record is going to be broken soon. So I think Dr. Premlay sir, it's your turn. Please tell us just a few lines about the Ebola vaccine. We are probably not using the vaccine soon, but it has some similarities with COVID, and we have lots of learnings to do with Ebola vaccine.
Actually, for this Ebola vaccine, several things they did. They used this vesicular stomatitis virus, which is an animal virus, cattle virus actually. It is not for human virus. And they used this virus and they inserted one gene of the Ebola virus in this particular virus. And this virus was used for making this Ebola virus vaccine. And they took, as of today's standard, lots of time, but it was the smallest time before this corona came. And this was licensed in US FDA in last December only. So they have been using this vaccine. They use this vaccine in DRC Congo with very, very effective. It is about 89-90% effective vaccine is there. So, but there is, for us, the only learning thing is that several things which they use for development of Ebola vaccine, actually this time taken for the licensure of the vaccine is equal to the time taken for making the vaccine, as well as then doing trials and then doing regulatory permissions. That takes lots of time. And the usual time, this runs one after the other. But for Corona and for Ebola also, they did parallel things together. And in coronavirus, we have seen that how much political I would say activism is there every country and everywhere around the world. And we also witnessed, Dr. Datta is our ethics committee chairman. We also did some trial for diagnostic trial for some Israel products. And we could also give approval for ethics committee in 5 days, which is a record. So everywhere things are happening like this. People are shortening duration of the various processes. That is how this Pfizer vaccine for COVID has come in 10 months only. So that is the result of the various people who are working together for those things.
Yes, the same technology like inserting one virus into another virus genome
Yes.
and that giving, like what we've done for adenovirus, chimpanzee adenovirus, human adenovirus.
Yes, yes.
The problem with Ebola was that the disease was limited to a small place, and it died off before all the studies could be conducted. And the advantage, so to say, advantage in COVID is that it's there all over the world. You can do a trial anywhere, wherever. There's so many patients across. And so they did something like a ring trial. Ring trial means only one patient is affected. All the contacts were given the vaccine because, others sitting here in India, we take the vaccine, it doesn't help in the trial. So only the ring circle was vaccinated. Each contact was given the vaccine, and that's how they studied. And it was really good, marvelous piece of work because, they could license it within 5 years. And now with those learnings, we've done it in 1 year.
See, Dr. Badwa, this is a risk which companies have to take for pandemic vaccines. And the pandemic subsides, it is no longer there, all the investment goes in vain. So that is the reason we find that this year for the coronavirus, lots of government support is there around the world.
Yes.
That is why it has been developed very fast.
So in the initial beginning, I said we'll discuss all the vaccines B to Z. So B, C, G we had started, and now we reach the Z of today's discussion. Z is the zoster vaccine, and I think we've done fortunately in a good time. So Dr. Bhasin, it's your turn. Tell us why the zoster vaccine.
Just 1 second, there is a phone ring. Phone later, please. Sorry.
Why the zoster vaccine was withdrawn.
Yeah, sorry.
We are looking forward to some other vaccine. No problem.
Thank you. Like you, I'll be winding up. So I'll be taking the last vaccine for today. And zoster vaccine was something which was already available. The virus for the vaccine was available. We know zoster is caused by the same varicella zoster virus which causes chickenpox. So in 2010, I think the vaccine was licensed, was manufactured, and 2014 it was licensed for use. And the initial vaccine which was launched for zoster was the Zostavac, which was the same Oka strain which is used for your chickenpox vaccine. Only difference is it has a much higher dose of the live attenuated virus.
It has 19,500 units, almost 14.
So it has a much higher load of live attenuated viruses. It was recommended for use in more than 60 years. So it is nowhere near pediatrics. It is only for use in senior citizens, to which now I belong. And but the efficacy was found to be only for 5 years, and there were some side effects were also associated with this. After 5 years, you are not sure how long the efficacy is going to last. Seeing these facts, this vaccine has been withdrawn in June 2020 from the even from the United States. It is the company itself has withdrawn this vaccine, and now you have a recombinant zoster vaccine, which is by the name of Shingrix.
Yes.
And so this is a recombinant vaccine which has to be given in 2 doses. And the other major advantage with this Shingrix vaccine, zoster vaccine, is that it can be given to less than 60 years. Beyond 50 years, it is recommended for use. So people who are much younger than me can also take it. And the only concern was that if you have previously had chickenpox or you have taken Zostavax, you have to wait for at least 2 months before you take this dose. So the efficacy is pretty good. It is a recombinant vaccine, safe, but the side effects, the local side effects are almost as bad or even slightly more than the Zostavax. But the Zostavax, being a live attenuated vaccine, has been withdrawn, and now you have this recombinant vaccine. It will come soon to our country. I don't think there is anything which can stop it. And for people, it is a very severe pain-causing and neurologically irritating disease, and it will be a good addition to the repertoire of the vaccines available to us. And I think you want to add something, or this is
maybe
all?
Zostavax will also come back with a better version, because that drawback, like you said, 5 years was not worth it. If you see the post-herpetic neuralgia, everything is more when you're 70, 80 years of age. And the vaccine, if you give at 60 years, by 65, 67, your effect is gone.
Repeat dose, yeah.
There's no point, and there was no second dose recommended. So I think it was good that it was withdrawn. So that is what we learned with time. And this one, the efficacy is also better. That was only 68%, 69% when you give at 60 years. 70
Recombinant
years.
vaccines are an excellent way of manufacturing safer vaccines.
This one is 90% plus. So hopefully we should get this vaccine soon, and you and me can hope for a vaccine, kill vaccine, although we'll have to have 2 doses, but I think it will be worth it.
2 doses at a minimum interval of 2 months.
2 months,
and,
yeah.
I think I should begin by thanking you. And Dr. Arun, I really thank you for motivating me to study. You deflated my ego and punctured my self-esteem when you said you took just 1 hour to frame the questions, because it took me more than 2 hours to download the data and more than another 10 hours to read everything.
This is the case for everyone, I think.
Greatest fool can ask difficult questions, which the wisest cannot.
Try to present only the relevant factors, what as a practitioner I would remember, rather than going into, like our professors, into the details of the conjugates and the strains.
No, that's why I said in the beginning, let's talk about only practical things which we all should know. As pediatricians, we must know this, because people keep asking us, and people think that pediatricians are the one who deal with vaccines. We should know everything.
And one more thing is there, that one always has to have some justification and some explanation to whatever we are using and doing. So that little science is also required to our practical
understanding. Yes.
Yeah.
Thank you very much. Thank you all the panelists.
Thank you.
Panelists, all friends, colleagues, and Delhi
organizers.
Thank you.
Thank you all the panelists.
सर आपका जोक रह गया सर, सुना दो. मैं आपकी इसीलिए बैठा हूँ सर.
Arun, well conducted.
I would take leave. I have to join another meeting. I would take.
जोक हम आपको भेज
सुना देंगे, आपको बाद में सुना देंगे, हमें तो सुन लेने दो.
हमने सुने दो डॉक्टर.
अभी इस पे जोक सुनाने में कोई मजा नहीं है, समझे?
सुनाई दे रहा है सर, दिखाई भी दे रहा है एक्सप्रेशन.
वाकई सर, इसमें अटेंड करने में भी कोई मजा नहीं है. बहुत ही ये जो है, ये तो नाम की सर काबिलियत है कि सारा साल ये लगा रहा है. मैं कहता हूँ इसके तो कुर्सी के पीछे बैठ बैठ के खड़ा हो गया होगा कुर्सी पे, जितना इसने अटेंड किए हैं.
ये कमरा मैंने दे दिया वो इसी पर्पस के लिए सारा साल.
मेरा सारा पूरा स्टॉक तुम लोगों ने सुना हुआ है भैया.
इतना हिम्मत है सर इसकी, नाब की और स्मिता की. वो तो बेचारी अस्पताल पहुंच गई कोविड से. ये घूम के आ चुका है.
नहीं आप तो पहुंच के आ भी चुका है.
चलो अच्छा है सर.
एक सुना देता हूँ, पुराना वाला ही है.
पुराना सुना दो सर, हम कौन से नए हैं.
पुराना ही सुना हुआ है.
बहुत पुराने हो गए आप तो.
हाँ. कुछ लोग नए भी हैं.
Very right, निरुपमा.
Okay. निरुपमा इज नया, समझ सुन लो. तो there were 4 friends were there. इस तरह से कॉन्फ्रेंस हो रहा था, and all 4 friends had gone and physical conference, not like virtual conference. Physical conference, real conference, physical conference पे, और मस्ती करने के लिए जाते हैं, थोड़ा बहुत पढ़ाई उड़ाई कर लेते हैं. अभी जैसे हम लोग कर लिए है, रात का टाइम फ्री रखते हैं भैया मजाक करने के लिए. तो रात का टाइम पे all 4 friends, they were classmates together. They said आज रात को हम बैंक्वेट नहीं जाएंगे, हम किसी का तेरा घर रूम में बैठ जाएंगे और खूब पिएंगे और पुराना दिन का याद करेंगे. तो सारे उन लोगों ने, जैसे हॉस्टल में होता था, राम व्हिस्की सारा कुछ लेके जिसको जो अच्छा और पीने लग गया है. पीते पीते ऑलमोस्ट आउट ही हो गया. तो in between one of the person he had to go to the loo. तो बाकी 3 में डिस्कशन शुरू हुआ है. एक बंदे ने पूछा है, भाई तेरा बेटा आजकल क्या कर रहा है? बोलता है मेरा बेटा he started his career as a salesman in Boeing and now he is CEO of that company. And do you know that in the last Christmas, he has given a 4-seater aircraft to one of his best friend as a Christmas gift. I am so proud of my son. तो दूसरा बंदे को पूछा है, भैया तेरा बेटा क्या करता है? तो my son, he was also a salesman in Mercedes-Benz company. And do you know that in the last Christmas, he has given a brand new Mercedes-Benz car to one of his best friend as a Christmas gift. I'm so proud of my son. थर्ड बंदा जो बैठा हुआ था उसको बोला, तेरा बेटा क्या करता है? तो मेरा बेटा एक रियल एस्टेट एजेंसी में सेल्समैन था, but after few years he became the owner of that company. And do you know that in the last Christmas he has given a 3-bedroom set free of cost. He has given a gifted to one of his best friend as a Christmas gift. I am so proud of my son. In the meantime, the 4th friend comes from the loo, and he was asked. He asked, by the way, what you were discussing all about? But we are discussing about our son. By the way, what is your son doing? My son, he is gay. We are so sorry to learn our sons are doing so well. By the way, what does he do? He is a jockey in a nightclub. Oh, we are so sorry. So what is to say sorry about it? You know that in the last Christmas, one of his best friend has given a Christmas gift of a 4-seater aircraft to him. Another friend has given a brand new Mercedes-Benz to him. Another friend has given a 3-bedroom flat. I'm so proud of my son.
ये रिसेंट वाला है सर, ये रिसेंट वाला ही है.
नहीं सर ने मॉडिफाई करा है,
रिसाइकल किया है,
मॉडिफाई करा है to make it more apt. नहीं.
Thank you very much. You have made the day.
Thank you, sir.
Thank you, sir.
Thank you, Jinab ji.
Thank you.
Okay, ji, Dr.
Thank you,
Kukreza ji.
everybody.
Thank you, ji.
We had a wonderful
Thank
second
you
day.
all.
So
Thank
we'll
you,
meet at 8:30 in the morning.
ठीक है सर.
Arun Badua has conducted it very well.
Very well.
हाँ, और बहुत पढ़ाई करी, 1 घंटे में नहीं किया तूने ये.
क्वेश्चन लिखने में कितना टाइम लगता है सर? कुछ भी नहीं लगता.
उसने बहुत पढ़ाई किया है, तभी तो he was perfect.
क्वेश्चन लिखने में टाइम नहीं लगता.
हाँ.
क्वेश्चन लिखने में कितना टाइम लगता है सर?
तो आंसर भी पढ़े हैं.
सर अरुण को मैं एक वो करना चाहूंगा, उसके पास हर एक वैक्सीन का इतना वो है सर, पूरा एक बुकलेट है इसके पास हर एक वैक्सीन की, खुद अपना बना के डेली उसमें ऐड करता है, बिकॉज वैक्सीन इज अ चैलेंजिंग फील्ड ओवर द इयर्स इट इज कमिंग, सो ही जस्ट कीप ऑन एडिंग द पॉइंट्स. तो हर एक चीज के लिए इसके पास आंसर होता है सर.
ये बुकलेट मेरे से आप
वेरी कम्प्लीट.
बुकलेट नहीं, he can write a book.
ललित बुक नहीं, उसके बाद वही राइटिंग ए बुक ऑन वैक्सीनोलॉजी.
नहीं आज
In
तक कुछ
2017 also in Pedicon in Bangalore this topic was discussed and it was given to me, and then that, so I was actually this time searching if anything new has come up in the last 2-3 years, but a lot of new things have not come up, just a few things handful which I tried to
next year tak to because of corona so many developments will come in other vaccines also. Arun ठीक कह रहा हूं ना मैं?
ज़्यादा सर. Good night everybody.
Good night.
Okay, good night. Thank you.
Good night everyone. Bye bye.
Good night. Bye.
Bye. Thank you. Thank you, Dr. Kukreza. Thank you.
Thank you.
Good. Great.
Thank you, everyone.
Thank you.
Thank you, Nirupma.
Thank you, Nirupma. Yes. Nirupma, let's wind up the show.
Thank you, Dr. Datta. Thank you, Dr. Sangeeta.
Thank you. It was really good.
थके हो गए मैम, चाय कॉफी आपको नहीं पिला पा रहे हैं. Sorry.
Yes, sir. Thank you.
Dr. Kukreza, you must be tired now.
Yes.
But
वो एक दिन था वो जब आपको वहां मिले थे, उसके दिन के बाद से बंद